Good morning, everyone. Good morning, Chairperson. So, this is my first talk. We are going to start the session with evaluation of male infertility. This evaluation is important for the management of any infertile couple. So, we'll go to this. My topic is divided into these following headings. First, we will discuss about clinical history, physical examination, semen analysis, imaging, hormone evaluation, and genetic assessment of the patient. So, little about epidemiology. 15% of the couples do not achieve pregnancy in the 1 year. So, among all couples, 15% needs medical treatment to get their pregnancy. In 1 in 8 couples have difficulty in approaching the getting the first kid. Like that, 1 in 6 couples have problem in achieving the subsequent kids. Is this male factor infertility male factor is associated with 50% of the reasons for the infertility couples. Before going to evaluation, how to start evaluation? You have to start the couple evaluation simultaneously, both wife and husband together. If female partner age is more than 35 years, you have to evaluate them within 6 months itself. Generally, we will start infertility evaluation after 1 year. But if female age is more than 35 years, we will start at 6 months. All infertile couple who are coming to our clinic, for male partner, you have to do urogenital examination. It is mandatory. These are the most common conditions we will see in the infertility clinic. Idiopathic is the most common, followed by varicocele and obstruction. These are just for the completion sake. History. Taking proper history is 50% of success in our treatment. So this history regularly we will do. For urology perspective, we will see just very fast. But in infertility and analogy, we have to concentrate more on history. So to take history, we have small pneumonic in Campbell, distics, spermatotoxic drugs, infections and inflammations, childhood diseases, and sexual history. In this, just consider on red letters: recreational drugs, antihypertensives, antibiotics, anti-inflammatory agents, and radiation. These are the most common things we are going to expose in the society. So these things, whatever some patients addicted for cannabis, alcoholism, and smoking, these things will affect the sperm function and in different aspects. Some antihypertensive medications, calcium channel blockers and AC inhibitors have some sperm parameter abnormalities. They will cause sperm motility abnormalities. Antibiotics in this tetracyclines have direct spermatotoxic effect on some doses. Nitrofurantoin still not proven in human studies. They are showing some in animal studies. They have some spermatotoxic effect. Non-aging radiations, these things which are there in everyone's life in and around. So they all cause with all parameters of the semen analysis, they will decrease. Cell phone radiation, cell phone towers, wireless Wi-Fi routers, your laptop usage, everything, TV broadcasting units, everything will have radiation exposure on your sperm parameters. Then coming to infections and inflammation, this is potentially curable cause for male infertility. The MAGI is including urethritis, prostatitis, arthritis, and epididymitis. These will cause infertility through anatomic and functional means. Viruses have different entity. They will integrate their genome into man's genome, and sometimes they will transmit to the offspring also. Mumps arthritis also is associated with infertility. This thing, STDs and infection still not proven complete strong association. But whereas TB, it will affect every part in the genital tract, so it causes anatomical problems. There is effect in the infertility. Childhood diseases. Childhood disease is very important. You have to evaluate the infertile couple, male patient in his childhood, whether he undergone any pediatric surgeries, and he has any history of testicular torsion, and he has any history of undescended testes, testicular dysgenesis, or genetic evaluation. These things in childhood history is very important for the evaluation. Then coming to sexual and reproductive history, actually it takes in the 4th place in history, but it is very important and very neglected part in the history evaluation. Regularly we will start what is your sperm count, what is your hormone analysis, what is your genetic test and all. But this is very important. Most of the couples having this problem. First we have to ask them, they married maybe 5 years, 10 years back. First we have to ask them whether consummated marriage or not. Still now they have very penetrative intercourse is there or not. If at all they have penetrative intercourse, we have to ask male partner problems, whether he have any sexual issues, erectile dysfunction, ejaculatory problems, premature ejaculation or delayed ejaculation, anything. Okay, they are consummating, male partner is perfect, still they have any malpractice. Malpractice means any abnormal practices using spermicidal agents for lubrications, KY jellies, even your saliva also toxic to your sperms. So everything is good, he is perfect, mating every time, they are not using any lubrications. Then we have to ask them. The wife is douching immediately after intercourse. If so, we have to ask them to avoid that. This is also perfect, then we have to ask them how frequently they are meeting. One partner in another place, another partner in another place. If they are not meeting regularly, we can't expect anything from them. So if they are meeting frequently also, the time also very important. We have to tell them that where is the ovulation time, whether to check for regular periods is there or not. So particular ovulation time, they have to meet every day for 1 week to 10 days in and around the ovulation time. Then we have to ask them about prior conception history, whether you are dealing with primary infertility or secondary infertility. The duration of infertility is also important. This is an important factor when couple reaches you, if female partner age is 35 years, you have to be more cautious and you have to evaluate them a bit early. Don't wait for 1 year, you have to evaluate them within 6 months. Then coming to physical examination we have to see general examination and local examination. In general examination, these are important things: BMI, body habitus, alterations in the sexual characteristics. These all will indicate adequate androgenization is there or not. Is there any parameters which is going to reduce the testosterone levels? So how obesity will cause infertility is, we have negative feedback of estradiol on the hypothalamus, then increased leptins, increased sleep apnea, and insulin resistance. These all will lead to altered hormone in the obesity patients, then lead to infertility. Local examination, we have to look at the scrotum, visual inspection, whether size is increased, it looks like hydrocele tumor or something like that. Testis size, long axis of the testis, and symmetry, consistency. These are very important things in the local examination. In long axis, we will consider 4.6 centimeter is normal, volume it's 20 ml looks normal. These are two things we will use. Regularly we are using Prader archidometer for the volume assessment. For long axis, we can use caliper archidometer. In Prader archidometer, 1 to 3 is for the childhood, 4 to 12 number size will for pre-puberty, 4 to 12 is for the puberty time, 15 to 25 is for adults. Then epididymis examination and spermatic cord examination. Epididymis we will see whether it is flabby, turgid or like that. Spermatic cord examination, you have to look for presence of vas difference is there or not, and varicocele examination. In varicocele clinical examination, we have Dubin and Emler classification. It's a subclinical and palpable only with Valsalva, palpable at rest and visible at rest. These findings we have to do in the local examination. Then coming to examination of the phallus, we have to see whether he is able to ejaculate the semen properly into the cervical, into the vagina. For that, you have to look for phimosis is there or not, any hypospadias, epispadias is there, or any penile curvature in like Peyronie's disease. Then DRE also important in fertile couple. Look for the prostate, whether any hypoplasia is there or not, any prostatic cyst is palpable or not. Regularly seminal vesicles are not palpable. If it is palpable, it's suggestive of obstruction. And coming to semen analysis, now guidelines changed in 2021, recently 6th edition. Little bit variation in the normal parameters. So normal sperm concentration 16 million per ml is normal. Total motility now increased to 42 and progressive motility 30. Viable forms which should be 54 and normal morphology should be 4. The secondary semen analysis we are going to discuss in detail in next session. So just these two tests, if need, we will do. When we are going to do is, these are the indications. Antisperm antibody assay and pyospermia assay. In tertiary semen analysis, we will do DNA, DFI index and reactive oxygen species. So when we are going to do DFI, in case of unexplained and idiopathic male infertility, recurrent pregnancy loss, modifiable risk factors, if there is clinical varicocele with pregnancy, unable to conceive the pregnancy, prior to initiate or after failure of IUI or IVF, recurrent miscarriages. In these situations, we are going to do DFI value. Coming to imaging, these are the imaging, but regularly we are doing scrotal ultrasound. If need, some cases we are going to do transrectal ultrasound and abdominal imaging. In scrotal ultrasonography, first we will look at testicular size. This Lambert formula will use length, width and height into 0.71. Then testicular, after size you do homogeneity, whether it is homogeneous or inhomogeneous. Inhomogeneity we will see in aging patient, testicular atrophy and fibrosis. After looking that, look for any testicular microcalcifications is there or not, and after that look for a presence of varicocele. And lastly look for any lesions is there or not, testicular malignancy. Apart from this, there is a signs of some obstructive azoospermia signs. That is dilatation of the rete testis, enlarged epididymis with cystic lesions and absent vas. These are the indirect signs of obstructive azoospermia in ultrasound we will get. Sometimes when your clinical examination fails, this means your Prader archidometer fails, ultrasound will help you. These are the situations when you have large hydrocele, inguinal testis, epididymal enlargement, fibrosis or thickened scrotal skin was there. These situations, clinical examination may be a bit difficult. Those situations, your ultrasound will be helpful. Then vasography, nowadays we are doing very rarely. to know the patency of the vas difference. Important thing is when we are injecting contrast or saline, we have to inject in the direction of the prostatic urethra, not in the direction of the epididymis. Venography also very rare thing we are doing. In some cases where challenging cases and recurrent cases where you want to know perfect venous anatomy, we are doing, but very rarely nowadays we are doing. Abdominal imaging regularly we are doing for that. Renal sequelae of the congenital vas maldevelopment. If it is unilateral vas maldevelopment, we have to look for the presence of the kidney or not. If you have any isolated right side varicocele also, you have to suspect some intra-abdominal pathology. In these situations, we will do abdominal imaging. Trust regularly we are doing, we have to know about the seminal vesicle and ejaculatory duct status and to determine the level of the obstruction. If level of the obstruction is too high, the candidate is not amenable for the TU or ED. Cranial imaging, when your prolactin levels are more than 2 times or 3 times higher, to know the prolactin, pituitary pathology, we are doing cranial imaging. Then coming to endocrine evaluation, the couple whoever is reaching to infertility clinic, we no need to do check hormone analysis for everyone. Only some situations we are going to do, if count is more than 10 million per ml, your FSH is going to be normal. If count is less than 10 million per ml, then only we need to consider about hormone evaluation. In that mainly we will do these things: FSH, LH, testosterone. If patient is obese, go for estradiol. Prolactin if patient is complaining any ED. Vitamin D and TSH may be also helpful. Important thing is this hormone profile preferably you ask them to do in the morning times. This is more important in especially in young patient. The circadian rhythm is will be there in young patient. It will be attenuating as age increases. The morning peak, afternoon trough, this circadian rhythm will be going to attenuate as age increases. Genetic evaluation, these are 3 indications in obstructive azoospermia, primary testicular failure, recurrent pregnancy.
Dr.
These situations we are going to do.
You just conclude your
Yes, sir.
we are losing time.
So in vasal aplasia, we are going to do CFTR mutations. In non-obstructive azoospermia, we are going to check karyotyping and YQ microdeletions. In the recurrent abortions, we are going to do fish aneuploidy and karyotyping translocations. In CUA VD without renal anomalies also, we are going to do CFTR mutations. To conclude this, hormone evaluation is indicated in azoospermia and oligozoospermia patient. Karyotype analysis is indicated if count is less than 10 million per ml. If you are suspecting strongly obstructive azoospermia, there is no point in doing Y chromosome microdeletions. If your count is less than 5 ml, Y chromosome microdeletions is indicated. If it is less than 1 million per ml, it is mandatory. Don't do regularly ROS test. DNA fragmentation, which I said previously, indications, those situations we are going to do DNA indication. Like TRUS and other renal imaging abnormalities, we discussed previously, same like we are going to do. Thank you, sir.
Respected seniors and my dear colleagues, I am not going to discuss completely about what is new in the 6th edition because there is a lot of new things which has come into the 6th edition of WHO manual. But I want to take you to a few important points which need your thought process to get in and change. If you look at the WHO manuals as a whole, right from when it started, there are some changes happening in each manual. It was actually a quest for defining infertility through the basic lab parameter semen analysis. So one thing you have to keep in mind, it is a laboratory manual. It's not a clinical manual. It's a lab manual. That is one. Why lab manual was created? Because semen analysis is something which is very difficult to report. Even though we think that it is easy. Because there is a lot of physiological variation, day-to-day variation, intra-individual variation, racial variation. And if you are not properly standardizing your techniques, you will get different results for the same semen sample. Even the time is important. The time of examination is important. There is no other test maybe which is varying in such a large extent. So the standardization is important. That is why they have come with this lab manual. So WHO is a lab manual. That is one thing that I have to impress upon you. Secondly, initially they were looking at the sperm cervical mucus interaction also in a equally important aspect. But if you see that in the first three it is there, and in the fifth, first four it is there, and in the fifth and sixth, that cervical mucus interaction is out. Now it is only an evaluation of the evaluation processing of the semen. So this is one thing you need to really understand. Now what has really happened in the fifth manual to sixth manual? The most important change is a replica of what is happening across the world, across the clinical chemistry. It is nothing happening in the andrology, it is something which is happening in the clinical chemistry. The fifth edition, there was till the fifth edition, what is normal semen analysis? I already told you it is a quest for defining normal and abnormal semen analysis. What is normal semen analysis? Who decided what is normal? It is based on a consensus. You send mails to so many andrologists and get a consensus that this is the normal. This is the normal we practice. Okay, we agreed. After that, the EBM, the evidence-based medicine has come. The consensus has no value. You need data. So in fifth edition, they attempted creating a population data of different races, different countries, and say that the fifth centile, below fifth centile, you will consider it as abnormal. Very good. So we have a evidence-based medicine, we have a data and a scientifically, statistically derived normal value, a reference limit, we call it. But the clinical chemistry is not accepting this. It has changed. They have gone to a decision limit and a reference limit. They are entirely different. I will explain this because this is the most important change which has happened in the sixth edition. Reference level is depending on the physiology. It's defining the normal, not defining the abnormal. For example, you take the cholesterol values of different persons in the Hyderabad, and you plot it. That is the reference in range of what is the normal cholesterol value in the Hyderabad. But that may not be the decision limit. The decision limit depends upon what is the pathology you are looking at. You are looking at hypercholesterolemia, and based on so many your studies, clinical research, you decide that 200 is the limit. If the normal range in Hyderabad is above that, it is abnormal. So reference interval is actually, or reference range or the reference limits all pertain to a normal situation or normal data, but the decision limits is based on what you call as pathology. Now I will take you to what is happening in the semen analysis. If you are looking at so many patients who are below the fifth centile, even they are having kids. And there are many patients who are above the fifth centile which is not having a kid. You cannot say that they are not infertile. So you are not defining the normalcy there. So there is a substantial overlap. So there is no distinct boundaries between the fertile and infertile man. So the clinical chemistry group is telling that you define your decision limit. The clinician's job. It is not the lab's job to define what is a decision limit. It is a clinician's job. And we are not making any distinction. So what has happened? What we have believed, which is the reference limits, all the limits have gone. And then if you look at the sixth manual, there is no term like oligospermia, asthenospermia, teratospermia, because we don't have the normal limits. Now, what will you do? You have a patient, you have a semen analysis, he is having infertility. How will you proceed? So you have to explain to them that what is his semen analysis and where do they stand in the normal range. Okay, based on that you have to do a clinical examination and other investigations and see what is going to be your treatment. There is no branding of this is abnormal and this is normal in a semen analysis. This is the major change which has happened, or major change which has been proposed by the WHO. It may not be accepted by all clinicians. In different parts of the world, different ways of approaching it is happening. There are many criticisms to this also. So this is the population data you have got in the 6th manual. So I am not going to the details. You can probably keep this in your table and you can discuss with them. You are in the 25th centile, you are in the 50th centile, and this has to be improved and things like that. That will be more sensible if you are following the 6th edition. Now, if you want to compare the previous one also, you can keep both. Now, what is the difference, exact difference between the 5th manual data and the 6th manual data? What has happened in the 5th manual data is, it was actually including only 8 countries and 4 continents. So the complete world is not represented. In the new manual, they have included other continents, that they included Asia and many other, some parts of the Europe. Even now, they have excluded so many parts of the world. So it is not a complete one, but they have improved the data. And you can see in Asia, there is only one representation from China, and that is 1,200. That substantially make a bias in this data. So I hope I have conveyed what is a decision limit and what is a reference limit and how you have to take it forward if you are deciding to follow the 6th manual. Now, what are the other things? The other things are, mainly they have divided it into basic examination, extended examination, advanced examination. Previously, it was they were telling that basic examination and for research purposes. Now, the extended examination, they have included the DFI, the DNA fragmentation index. So they have included, it's an extension of your semen analysis. That is a good thing, because which is coming up and a lot of data are coming up. And even the genetic analysis comes in that. And advanced examination, they have included the assessment of ROS and oxidative stress. So they have included so many new things into this in the gadget of our investigation. But the only problem with all these things is, they have mentioned how to do things and other standardization things. But what is a normal value? Where should you take a decision to do this test? And how to proceed when you have a result is not at all mentioned. But that actually, that onus is upon us, the clinicians, to give data for making them a clear guidelines. And there are some emerging methods where you can do a semen analysis without a microscope. And such things have already that have been included into the WHO manual, and they have taken out so many redundant tests which we are no more using, like that sonography penetration test and things like that. And the major differences, I'm just skipping through the major differences. I'm not seeing the timer.
We have 4 minutes.
4 minutes, okay. Okay, so I'll just 4 minutes for 15. For 15?
Yes.
Okay. Okay.
For use.
Okay. So in the motility assessment, we had initially fast progressive, slow progressive, non-progressive in the 4th edition. We have changed the fast progressive and slow progressive. It is completely subjective and put it into only progressive. Now we have gone back to the previous one. The reason is still not known, and it is criticized also. The sperm concentration, they have mentioned the details of how to count and make a report, and that actually adds to the accuracy. And the vitality testing also, they have actually clarified a lot of issues, like 40% of, below 40% of total mortality, they are doing it. Previously, it was 40% progressive mortality, which also looked a little bit absurd. That was corrected. The sperm morphology is, they have put in so many photographs, which makes you easier to learn things and replicate in your practice. Now you have the extended investigations. I have already mentioned all these things. Extended investigations, advanced investigations. They have included sperm preparation where they have actually mentioned the magnetic activated cell sorting, and sperm cryopreservation sperm vitrification technique is mentioned. So in a nutshell, what we are seeing is they have put in all the newer gadgets with which will help us in managing an infertile couple, and they have taken off all the redundant things. So it's actually welcome move, more evidence based. So what are the strengths of this new sixth edition? It has a more robust data. It's a scientific approach. Newer modalities are there, and the redundant are excluded. The weakness is lot of the lack of thresholds, as I mentioned in the DNA fragmentation and other things, and the data has to be updated with more results, more inputs from other countries, and it provides a lot of opportunities for a future research on the decision limits and identifying the threshold and indications, and it has to be done by the andrologist. And the threats is the abundance of technical material make it very difficult to be read by a clinician, and they may not read it and they may not follow it also because of this lack of thresholds and reference limits. Thank you so much.
Thank you, sir, for the kind introduction. Coming to my topic, this is like introduction topic for this session, because everything is included: medical management, surgical management. We have speakers. So my topic is like an introduction, and it says why male factor evaluation is important and how it is useful for gynecologists in treating their female partners or optimizing the results of their fertility. So we all know that male factor is seen in more than 50% of the couples where there is infertility. So now coming to male factor workup, why it is important. So now before even coming to male factor workup, first thing what we have to understand is oligoasthenoteratozoospermia. This is not a disease. This is
oligoastheno.
Oligoasthenoteratozoospermia. This is like a phenomenon. This is like fever. So there should be some underlying cause for this. It can be genetic, it can be varicocele, it can be infection, it can be hormonal imbalance. Now we have to understand what is the cause for that, and we have to identify whether this is treatable, this is a treatable cause or untreatable cause, and based on that we have to take a decision. So now what are the options we have in a patient of oligoasthenospermia? One is lifestyle modification. In lifestyle modification, again, sleep, tobacco, alcohol, sedentary lifestyle, all these are the causative factors for oligoasthenoteratozoospermia. And second option is identifying the underlying cause. And then comes medical management. In medical management, we have infections, hormones, and antioxidants. We have speakers for all these sessions today. And surgical management, we have varicocele surgery and partial ejaculatory duct obstruction. This comes under surgical management. Then comes IUI and IVF. Now, here, why we have to optimize the oligospermic patient? Now, first thing what we have to understand is what if optimization is not done? So, most of the patients will end up with IVF procedure or ICSA procedure, which is psychologically and financially, it's a roller coaster ride for these couples. There is no guarantee that they will succeed, though the success rates are 50%. Even if they are undergoing third IVF or fourth IVF, there is no guarantee that they will conceive. So now our idea is to optimize the male patient and at least downgrade the treatment what they are planning to go ahead. If the patient is suitable for IVF, we have to make him okay for IUI, or if a couple is planning for IUI, then we can help them in conceiving naturally. Then second need is to increase the success rates of IUI or IVF or ICSA. If a patient is having infection, even if they undergo IUI, the chances of there is a very high chance of DNA fragmentation index, so the chance of IUI success is very less. Or even in patients undergoing IVF procedure, the the success rates will come down significantly when there is high DNA fragmentation rates. So by treating these male patients, we can actually increase the success rates of IUI and ART procedures. And lowering the chances of early pregnancy loss, we have to understand that even if there is a couple who are having a recurrent early pregnancy loss, male factor is also one of the possibility. So we have to understand that there we have to treat the male. And to make the fertility treatments more affordable. So if a couple who is affordable for IVF, then it's okay. If a couple is not affordable for IVF, then we can actually, if we can downgrade them to IUI level, that means we can increase their semen parameters to IUI level, we are significantly decreasing the amount spent on ART procedures. So now, to summarize, I will tell you for all those postgraduates, I will tell same things in 5 or 6 case scenarios, how male infertility helps and why it is important and what I and we have to learn from this part. The first case scenario, here was a 33-year-old male. He was married since 5 years. His count was 1 million. Bilateral on examination, there was bilateral gross varicocele. His FSH was 14, which is on the higher side, and testosterone was on the lower border, but normal. And the couple was not willing for ART procedure. Financially or psychologically, they are not mentally prepared for IVF. The only thing they said is, doctor, we don't want IVF. So then they came for varicocele surgery. Since their FSH is on the higher side, I counsel them, in spite of doing varicocele surgery, your count may not improve. Your only quality may improve, but patient wants varicocele surgery in spite of negative counseling. Then we did varicocele surgery. After 5 months, patient came back. His semen parameters were 4 millions. Concentration was 4 millions, motility was 48%, and morphology was 3%. Then again I counsel him. See, I told you that possibility of natural, all these were counseled before surgery. Now I think this is the time you have to take a decision and you have to go for IVF. This is in early my practice days. And patient says, sir, no, still I don't want to go for IVF. Give me medications, I want to try naturally. So I said, there are very few chances. Why you are wasting time? I think instead of wasting time, you have to go for IVF. And after 2 months, he came to me. If I would have said that there is chance of natural pregnancy, you try for another 6 months, then I would have been in a different position. Now he came to me saying that, doctor, you said natural pregnancy is not possible. See, my wife got natural pregnancy. So I said, I thought of saying it's luck. It may not happen every time. And I said, okay, congratulations. Because since I pushed him for IVF, I was not in, he was in blaming side and I'm in the receiving end. Then again, after 2 years, he came back. Again, second natural pregnancy. Again, when I did semen analysis, it was only 7 million. So what Dr. Vinod was saying, so now all those limits, percentile values, sometimes we have to believe in those, but this can happen. So always when counseling negatively, we have to be little careful. Second case scenario, again, varicocele patient, 33 years old male patient, married for 5 years. Patient had normal sperm counts, but low motility, very low motility. So his DNA fragmentation was done in a fertility center. It was on the higher side. So actually they referred this patient to do TISA on the day of IVF. They said, sir, DNA fragmentation is high. Patient don't want varicocele surgery because he has been counseled that varicocele doesn't need varicocele surgery. They said, we just want a TISA, testicular sperm, so that we can do IVF. So I can't, since patient was already referred for TISA, we only counseled him about varicocele and what are its effects. Then we did TISA and IVF, there were poor quality embryos. And then after the IVF, patient came back for varicocele surgery. And after varicocele, patient conceived with IUI after 4 or 5 months. Here, the take-home message from this one is, now downgrading the procedure. If varicocele surgery was done before, at least one IVF procedure, we would have avoided IVF procedure. And all the mental trauma with the IVF failure. So coming to case 3, 36 years old North African patient, married 7 times, semen analysis was azoospermia. And he has bilateral small volume testes with bilateral clinically varicose. FSH was 32, LH was very high, testosterone was very low. So he was already on gonadotropins since last 3 to 4 months. So he underwent TISA, no sperms. Biopsy report came as maturation arrest, late maturation arrest. So then we did varicocele surgery, and again after surgery, with the help of gonadotropins, occasional sperms were seen in the ejaculate. So later he underwent IVF. So now the message from this case scenario is, for patients even with no hope, by doing some treatment, we can give them some hope. But this happens after seeing all these case scenarios. We should not think that every patient who comes with varicocele we should operate. We have to identify who will improve with varicocele, who don't have, when patient is not having any other chance, we have to operate. Anyway, my colleague Dr. Raghavendra will tell us about when to operate a varicocele patient and when not to operate a varicocele patient. So coming to fourth scenario, a couple with 7 years marital life. There was 3 times early pregnancy loss. Couple had 4 IUIs and 1 IVF. Even with IVF, patient had early pregnancy loss. Husband semen analysis, as sir said, he will repeat semen analysis in every patient. In this patient, semen analysis was done in regular diagnostic centers for many times. All those semen analysis report shows normal study. Only some report says pyospermia. So when the fertility center started with DNA fragmentation test, DNA fragmentation was very high, and in all those semen parameters, only the pyospermia was neglected. They thought that it is normal. Sometimes they give 5 days course or 6 days course of antibiotics. In this couple, the main reason for recurrent early pregnancy loss is only seminal infection. Female factor was totally normal. After treating their infections, couple had natural conception. So now the take-home message from this case scenario is role of sperm in recurrent early pregnancy loss. There are various case studies which says that male sperm is one of the cause for recurrent early pregnancy loss. So it is not the only female issue. So according to this study, among male partners of women with recurrent pregnancy loss, varicocele was seen in 4%, and 23% of patients, male partners, they had infections. So now both male partner might be a contributing factor towards recurrent pregnancy loss, and both male partners in case of recurrent pregnancy loss, or even in normal patients, normal infertile couples, both male and female evaluation should start at a time. So anyway, indications for semen culture, my colleague will be talking about indications for semen culture, when to do semen culture, not in all patients. Coming to last case scenario, 34 years male patient, semen analysis showed oligoasthenotetrospermia, count motility was on the lower side, FSH was normal, testosterone was normal, testis was normal, epididymis was bulky and turgid. Scrotal Doppler says typical filarial dance sign. So here, the importance of scrotal Doppler, sometimes we say scrotal Doppler is not important, but here scrotal Doppler really helped us. If scrotal Doppler was not done, so we would have thought that it's like regular infection. Regular infection, we would have put him on doxycycline or some antibiotic and we would left. But since we found that there is typical filarial dance sign in the scrotal Doppler, we put him on DEC, he responded well. Later, he conceived with IUI. So, see here, I'm not saying patient conceived with naturally, but at least we helped him in conceiving with IUI. We helped him in downgrading the procedure from IVF to IUI. Last case scenario, 28 years old male patient, obese patient, semen analysis showed oligoasthenotetrospermia, count was 3 million, motility was 22%, came for evaluation, FSH was 10, testosterone was very low, estradiol was very high. So here testicular size was 6 to 7, which is on the lower margin. So he was treated with gonadotropins and antioxidants, and we had put him on anastrozole. And after the treatment, the count went up to 8 to 10 millions, And again, the couple conceived with second IUI. First IUI was failure, second IUI, couple conceived. So again, take home message from this is even patients with severe oligospermia, we can give a try, but the try should not be more than 2 spermatogenetic cycles. If patient is not responding in 2 spermatogenetic cycles, then we have to refer them to ERT procedure. So the last point, which is very important nowadays, is the major enemy for male infertility nowadays. We thought smoking, alcohol, lifestyle, these are the common enemies, but the common enemy which has taken down sperm parameters in last decade is nothing but plastic. So it's one of the bisphenol which is in plastic bottles. Its main target is male reproduction. So this is how it comes into picture. So now we always think that we don't use plastic bottles, but when we use water from a plastic bottle, that is taken from refrigerator, but how it is transported, that is important. Whether it is cool drink bottle, whether it is water bottle, how it is transported, when it is exposed to sunlight, that is important. Once this bottle is exposed to sunlight, there is bisphenol released into the system, and bisphenol will affect. See, again, last decade we are all used to this, taking curries in curry points, teas in plastic cups. No, bisphenol will affect steroidogenesis and spermatogenesis, and it stays in sperms for our genes for 3 generations. Okay, thank you, doctors.
Respected chairpersons and seniors and my dear colleagues, the medical management of infertility is a very vast topic. So I've just tried to throw light upon 2 or 3 points and bring before you a few of the evidences which we have. But I won't be going to the details, and I may be frisking through the slides fast because we don't have time. We have only 15 minutes. But I think I may be able to tell you what is a basic concept of medical management in infertility. So first of all, which patient of your practice on infertility needs a management, medical management? Should not be very enthusiastic about it, because most of the cases you face are idiopathic. And for idiopathic cases, it is basically an empirical management, and as just like Dr. Rahul said, we will be optimizing patients. We will try to optimizing patients with the little bit of evidence we have. Okay. And all the time when you treat, you have to be very careful. Primum non nocere. First, do no harm. So that is a basic thing in andrology. If you're doing a varicosilectomy, be careful about the artery and don't damage the artery and say that I have done a varicocele. Second group is the hormonal causes. See, the bulk of the medical management of infertility is revolving around this. We are trying to find some hormonal cause here and there and treat it. So that, why? Because this is the area, these are the type of cases where you get the maximum benefit and the maximum result. So what all research is happening is we are looking into the andrology, the endocrine aspect, and if we are finding some hormonal abnormality, we are trying to correct it. And the genetic cause, there are some anecdotal studies which is showing some importance, but nothing like Klinefelter and other things that also I will mention. And this is all about the endocrine, how you treat and how you plan the management. You know the track, everybody is aware of it, but I want you to focus on the FSH is going to the Sertoli cell, that is basically for the maturation of spermatogenic cells, and Leydig cells is stimulated by LH, and it is producing the testosterone. And you should be knowing that the intratesticular testosterone, that's a testosterone inside the testis, matters, not the testosterone in the blood level. And you have various steps where you interfere in this endocrine control algorithm, and we will go to that one by one. The first and foremost thing I need to convey is, first, do no harm. Never ever prescribe testosterone to a patient who is coming to you for infertility, or even thinking of infertility. You should not prescribe testosterone. Why? Because if you are giving it, you are suddenly managing the, you are stimulating the feedback mechanism and suppressing the intratesticular testosterone and suppressing the spermatogenesis. And you are not sure when you can reverse this patient. There are some indications you give testosterone and all, but we have seen so many patients who is struggling to get it reversed. It may take 6 months, 1 year, 2 years, God knows. And sometimes it may not reverse at all. So you have to be very careful when you prescribe a testosterone, and whenever you see a patient who is taking testosterone at whatever age, tell them that to stop it. That is a social service. Secondly, that the gonadotropin releasing hormone, not very commonly used. But when you have a problem, you can try using this because of this. It increases the pulsatile release, and the mode of administration is difficult, costly. So I'm not going to the details, just for completion's sake. This is very important, the gonadotropin treatment in a hypogonadotrophic hypogonadism. You can treat them with HCG. HCG is equivalent to it's almost similar to the luteinizing hormone. It works like a luteinizing hormone, and it provides more testosterone. If you have hypogonadism, which is due to a lack of LH stimulation, you can give them. And there are different types of, you have to titrate the dose, maybe twice weekly. You can give from 1,500 to 3,000 units or even higher, depending on the requirement of the patient. And some dose adjustment has to be done, and you will get excellent result in such patients. But suppose you are treating a patient with idiopathic oligoacinospermia with gonadotropin, thinking that there will be some hormonal element. There is very limited evidence. But there are many groups which are studied giving HCG for all these patients and trying for that. But there is only limited evidence. Then in some patients with hyperprolactinemia, it's not a very big number. Mostly we see this in erectile dysfunction. And unfortunately, I have never seen a patient who is suffering from hyperprolactinemia in infertility. I'm just mentioning it for completion's sake. You can give a bromocriptine, and if that is not responding, or if you want to give a lighter dose, you can try switching over to carbogoline, because it is taken once or twice weekly, and it's a small dose. And patients are really complained about it, and its main use comes in erectile dysfunction. I have never used it in infertility, but it is mentioned. Now I am again taking you to that diagram, which is our savior, aromatase inhibitors. We are going to discuss about aromatase inhibitors. What happens there? The testosterone is synthesized by the Leydig cells, and it gets converted to estradiol in the peripheral fat. And that is done by the aromatase enzyme. So we are trying to reduce the conversion. Why we want to reduce the conversion? Because the estradiol is giving a negative feedback. So we want to reduce that conversion. And we have so many off-label uses of such drugs, like anastrozole, letrozole, and things like that. And this works by blocking the aromatase inhibitor. And it is indicated if you have a non-obstructive azoospermia, that is also off-label use, only little bit evidence. And in oligospermia patients, if you look at the T ratio, if it is less than 10:1, you can think of using an aromatase inhibitor. And now I am again taking you to the next one, that is a selective estrogen receptor modulators. Here the mechanism of action happens at the central level, at the estrogen receptor level, where the modulators will block the effect of estrogen, and they may be working like an anti-estrogen and producing more testosterone, available testosterone, so that there will be good spermatogenesis. Clomiphene citrate and tamoxifen are commonly used, and unfortunately we have to be very careful that clomiphene citrate has an intrinsic estrogenic action. For some patients, we have seen the testosterone level coming down and the spermatogenesis coming down when you are giving clomiphene. It's because of the intrinsic estrogenic action. The evidence for this is, there is one paper in 2013 which showed increased pregnancy rate, and another there is a meta-analysis in which only one showed an improvement in the pregnancy rate, and the Cochrane database shows no improvement. So these are all anecdotal things we may consider as or a little bit evidence based on which we are doing the treatment. Now comes the biggest group of drugs which we usually saw in your OPD. It is antioxidants. Everybody is prescribing antioxidants. Even if you don't know anything about the management of infertility, you are using it. The basic concept is just like Dr. Havil has mentioned. There is a balance which is happening inside our body where we have the antioxidants, which may be enzymatic or non-enzymatic, and the opposite side you have so many bisphenols, plastic bottles and other things, your cell phones, everything, which is putting in the oxidative stress. So our question is, suppose I am adding to that antioxidant panel with some drugs, whether it will improve. For that we need to know what is the oxidative stress I have, what is the ROS level in my semen, and suppose I am taking a medicine, how it is going to improve. Unfortunately, we don't, I mentioned the first talk itself, we don't have a clear-cut idea about the ROS levels and other things, what is the normal level, what is the standardization of the techniques, but there are groups of researchers trying to bring out the standardization, the ROS level measurements, pre-treatment ROS levels, post-treatment ROS levels, showing some difference. These are all promising things which may come up in next 5 to 10 years. So what is all about these antioxidants? What are the available things? You must be knowing so many things like vitamin C, vitamin E, N-acetylcysteine, folic acid, carnitine, coenzyme Q10, and so many things. So the main problem is, we don't know what is the exact dose and what is the effect. And the fortunate thing is, nobody is going to penalize you for giving a low dose or a high dose, because all of them are marketed as food supplementations. They are not drugs. So the pharmaceutical industry is also free, because it is a food supplement and not a drug. So many restrictions are not there. We don't have to prove it to the DCJ that it is a good drug. And there is a Cochrane review which has come in 2011, which shows some evidence on the antioxidants are doing good in terms of live birth, seminal parameters and things like that. But I don't think that it is a very optimizing thing like this, because if you go into the depth of the meta-analysis, you know that the results are based on 1 or 2 studies. Because meta-analysis is usually like that. If you are doing a meta-analysis in an area where there are not much evidence, you will get a result. It is just like a garbage in, garbage out. So we have feed garbage into that meta-analysis, the garbage will only come out. But scientifically, there is a benefit in one of the Cochrane data. Now I am giving you a few studies which has shown some effect on this, like coenzyme Q10. Carnitine has shown that some effect in some other studies, like Lenzi and all are the proponents. Then omega-3 fatty acids, looking at the omega-6 and omega-3 fatty acid ratio. If you will have more omega-6, so if you are giving omega-3, it will be good. And this may be one of the last slides. Usage of antioxidants, you have to be very careful on the last point I have mentioned. Long-term usage of antioxidants can produce negative effects. So just by treating empirically, you should not do harm to a patient. And This is one expert advice which was given by one of the seniors in andrology, like Steve's. This is the thing which he prescribed. I just put in the slide because all andrologists will have his own concoction of antioxidants. And in sperm retrieval in NOA, all the data are very, very little. The evidence is limited. Thank you.
Yeah, as you all know, Dr. Raghavendra is a very promising upcoming andrologist and fertility specialist practicing in Apollo Hospital, Hyderabad. He has done a lot of, you can see his intro slide. He's got training from Wayne Cornell Medical College. He has published many papers along with international colleagues. He's authored book chapters, many good publications. And recently has conducted a successful conference on sexual medicine. Over to you, Raghavendra.
Thank you, sir. Thank you for the opportunity. Good morning to everyone. Now I'm going to discuss on varicocele surgical dilemma. So ever since first varicocelectomy was done by Tulak for azoospermia where sperms were there, and more than 5,000 articles are there on this subject. But still, even in 2020s, we are talking about why there is a surgical dilemma. So let me try to clarify, because it is a dilemma. I have to talk about the evidence. I'm not going into the theoretical lecture here. So it is a surgically correctable cause. So as a surgeons, we are interested to fix the varicocele. I think all of you are well aware it is a dilated, tortuous pampiniform plexus of veins. And if you are not treating the varicocele, what is going to happen? It is a progressive decline that ultimately person will have an effect on the fertility or various other parameters. It can hamper the testicular growth. There is now evidence for there is a hypogonadism where testicular levels are also going down. It may raise the DNA fragmentation high, or even oxidative stress is also high. Sorry for the technical glitch. So what is the physiopathogenesis? Ultimately, it is a raised testosterone, testicular temperature. It is causing the Leydig cell dysfunction, Sertoli cell dysfunction, raised reactive oxygen species, oxidative stress, and DNA fragmentation, ultimately hampering the fertility of an individual. So even today, it is a only physical examination, but it has got too many limitations of our physical examination. With the available guidelines, we need to document the varicocele before doing any intervention with the scrotal Doppler as per the EAU guidelines. And always, whenever you are in the OPD, whenever you are examining all infertile patients, ask them to in a standing position so that you can analyze better, you can assess better the varicocele, then they can go for lying down position. So initial standing position will help you to assess the varicocele. Even you can palpate the vas better. And this is what I use in my OPD, which will help me to detect the reflux. Because I have sent one patient has come to me with varicocele of different grades. He has gone for 10 radiologists for the same patient. 10 reports are there: grade 1 varicocele, grade 2 varicocele, no varicocele, testicular volume discrepancy. Why it is happening? Because there is no standardization even among the radiologists. So in infertility practice, it is a Pandora's box like our abdominal pain. So standardization for our own colleagues. You can have a close interaction with your radiologist, pathologist, or lab technician. Probably we can give better results. These are the various grading systems. I am not going into the depth. Certainty grading now recently we are practicing. What are the various options? Surgical option, it can be retroperitoneal, inguinal, subinguinal, microsurgical, laparoscopic, percutaneous embolization, sclerotherapy, medical therapy. So whenever you see a patient in the OPD, you say there is a varicocele. Immediate question is what is varicocele, how it affects, and immediately they'll ask whether it is medically curable. So it makes sure that there is no medical role. It is a structural problem. There is an anatomical defect. It has to be corrected. It has to be fixed by the surgery. Whether that is an indication is there or not, we have to see. But as a bypassing method, this ART will come. So what is the best way to fix a varicocele and what is the evidence? So there is a meta-analysis clearly says it is a microsurgical varicocelectomy is the gold standard procedure for various reasons. So another meta-analysis from RCTs is also showing even in 2018, it is a microsurgery which gives better results. Regarding the grade of the varicocele and impact of varicocelectomy. So higher the grade of the varicocele, better the results. If the lower grade 1 or subclinical varicoceles, no way. Grade 1 varicocele on your physical examination documented with varicocele, still there is an improvement you can see here. Even in the grade 1 varicocele, statistically significant improvement is there, but the magnitude is less. Subclinical varicocele. So what is subclinical varicocele? It is diagnosed only by the scrotal Doppler. You should have a clarification here. There are patients on our physical examination, there are limitations. Some patients won't allow you to touch the scrotum. Some patients, there is a very tight scrotum. Previous surgery is there. Hernia is there. Hydrocele is there. In those patients, if there is a varicocele of higher grade, it is not subclinical varicocele. There is a technical difficulty in analyzing those patients on physical examination. You have to understand that. All the guidelines say there is no role of subclinical varicocele for surgery. So the evidence is very weak. Probably we have to wait for future. Adolescent varicocele, same indications like adults. So when to operate a varicocele, guidelines are very clear, even if it is adult or it is a adolescent. Persistent semen abnormality, testicular volume discrepancy more than 20%, and persistent pain is there. These are the standard indications for the both. And there is an adolescent varicocele, but it is a clinically palpable varicocele. So what to do in those patients? If he is able to give the semen sample, testicular size, if it is normal, there is no discrepancy, and semen parameters are normal. Just you need to follow these patients at every 6 months. If there is a progressive decline over a period of time, then that will be an indication for surgery. Even Vinod sir was talking about the decision limits, but in the second lecture itself, he was talking about idiopathic OAT. So still, we are practicing the 5th edition guidelines only. As a clinicians, it is difficult for us to take the decision when you are talking about, if you think that this is going to cause some abnormality later on, it is very difficult to convince our patients for surgical indication. They'll think that you are convincing forcefully for the surgery. It is very difficult. Probably time will tell when the decision limits come, clinical decision limits, as sir was talking. Till that time, we have to follow 5th for decision making. Even the guidelines year 2023 also. So whenever there is an abnormality testicular reduction, this is for adolescent. Progressive testicular dysfunction is there. And in the era of ART, what is the role of varicocelectomy? It will increase the success of IUI. What is the meta-analysis saying? In treated and untreated varicoceles, it is also improving the success of ART results, even ICSI, IVF, IUI. So again, one more meta-analysis of randomized clinical trials. It is also convincingly says that varicocelectomy improves ART results. This is the largest study on the varicocele, where total 49 articles were there, including 6 meta-analyses and 32 systematic reviews, and 11 original articles were there. That also showed in 2018 or 2019 varicocele repair is cost-effective treatment method that can improve the semen parameters. It can improve the pregnancy rates, live births in more infertile patients. By improving the semen parameters and sperm structure, varicocele can decrease or even eliminate the need for ART. I almost tell in all the gynecology lectures, at least I can grab 10 to 15% of patients from you to avoid ART after doing a varicocele surgery. So that is where natural pregnancy will come. If you operate 100 patients, 10 to 15 will go for, provided they are very young at age. Cost effectiveness? Definitely yes. Varicocele surgery is cost effective. Varicocelectomy and non-obstructive agiospermia only in selected cases. Whenever there is an hypospermatogenesis or late maturation arrest in the biopsy, which is available. So 10 to 15% of the cases where you can get the sperms in the ejaculate. What is the advantage? It avoids the TSA or chances of natural pregnancy, even though it is very minimal. Even if they become agiospermic, even after correction of the varicocele, still there is a high chance of sperm retrieval in those patients post varicocelectomy because of the internal changes within the testis for the spermatogenesis. So what is the meta-analysis systematic review saying? Yes, definitely it improves, even though magnitude is less for non-obstructive agiospermia. Hypogonadism, Evidence is still accumulating, but still it is not sufficient. But there are few reports, meta-analysis, it is not a good quality, but it is showing testosterone results may also improve. In my practice, I see in very few patients post-surgery testosterone levels are increased. And DNA fragmentation, yes, but it is also still evidence is weak to correct a varicocele for only for the high DNA fragmentation. So this is a slide as a urologist or surgeons we should understand. So why we have to operate a varicocele? Our primary aim is to improve the semen parameters for a natural pregnancy. If not, we can improve the semen parameters per IUI. It is a downgrading of ART as Dr. Rahul was mentioning. And it is an upgrade obstructive, non-obstructive agiosperma patient for the ejaculate where we can avoid a sperm retrieval. And to improve the success of sperm retrievals if they are going ahead with any retrieval procedure, and upgrade the success of ART. So in spite of so much of infrastructure and technical improvements in the ART, still there is only 30 to 40% success after IVF fixing. So that we can enhance the success of ART by fixing a easily correctable cause. It is also beneficial in hypogonadal men, and it is a cost-effective treatment for infertility. I conclude my lecture with Anthony J. Thomas' words. Disregarding the excessive cost, risk of ovarian stimulation, multiple gestations, need for repeated cycles, it would seem a grave disservice to a couple not to offer a potentially curative solution to their infertility if the male partner has a varicocele and suboptimal semen quality. Thank you.
Thank you, sir. Good morning, everybody, and thank you, Surya Prakash sir and Dr. Bhupati, for this invitation. So, after going through a lot of dilemmas, confusions about semen parameters, testing, and whether even our diagnosis is okay, we now come to a thing called azoospermia where it is much easier. Okay. So, once we follow diligently whatever has been told so far, like whether the semen analysis has been standardized, etc., our diagnosis now will be fairly easy. Once we have done a diagnosis of azoospermia, with that the treatment starts. So it is no more a dilemma, no more confusion. So myself and Dr. Arun Karthik will be now going through the two major subdivisions of azoospermia. One is non-obstructive and one is obstructive. So going on to this non-obstructive azoospermia, we have to understand what is the pathophysiology, the diagnosis, and what genetic tests we do, even though we have a separate topic, and what are the recent advances. So this is what we are going to go through. So the incidence of azoospermia is up to, so as Dr. Bhupati mentioned, the infertility incidence is increasing. Out of the azoospermias, at least 85% is non-obstructive. So unless proved otherwise, unless we look for an obstruction, most of the times we usually see that it is non-obstructive azoospermia. So again, the causes can be hormonal, it can be genetic, and other things like antecedent testis, varicocele, toxins, chemotherapy, radiation, which we have been discussing from the morning. So going on to the diagnosis, semen analysis, clinical examination, hormones, and other tests. So semen analysis, not one sample, multiple samples, and a proper examination. So a pellet examination is very important so that we can identify a cryptospermia. Unless this part has been done, we cannot label it as azoospermia. Second thing is on the semen analysis, whether it is non-obstructive or obstructive. If the volume is normal, if the pH is alkaline, and if the fructose is positive, it is probably non-obstructive azoospermia. Even though there can be exceptions, variations, these are the three things which we can make out on seeing the semen analysis itself. We can make out that it is a non-obstructive type. Going on to clinical examination again, maybe the androgenization will be less, the testicular volume may be low, and there may be a varicocele. So these are again indicative of a non-obstructive component. Vas deferens is usually present, and maybe previous surgeries like say undescended testis, etc. may also be there. So again, these four hormones what we mentioned. So the main idea in diagnosing non-obstructive azoospermia is what is the gonadotrophin level and whether there is a testicular failure. These are the things which we want to make out. So the role of scrotal ultrasound and TRUS is very minimal. So whenever there is a doubt, we do TRUS, especially when the parameters are tending towards an obstructive cause. Other than that, in a non-obstructive azoospermia, the role of TRUS is very minimal. And ultrasound probably is only for completion, and whenever we think that there is a varicocele, then the ultrasound comes into the picture. So this slide has already been discussed. So the idea to put up this slide is, when we see the reports, when we see the FSH, LH report and testosterone, what do we infer? So we have to understand that this is the level of the problem. So in non-obstructive azoospermia, the problem lies in this level, so in the testicular level. So this may, whenever the testicular problem is there, this in turn causes a feedback increase in the hormones from the pituitary gland. So the FSH and LH will be high. So unless the LH and FSH are very low or undetectable, we are dealing with something called a testicular failure or a eugonadotrophic state, where the LH and FSH may be normal or slightly elevated, and the testosterone may be normal or low. So this is the main thing which we have to keep in mind. So again, whenever we see azoospermia, always our doubt is whether it is obstructive or non-obstructive. So we have multiple parameters to guide us. So one thing is whether the vas is present or not. So if the vas is absent, then it goes towards the obstructive side. And in most of the time, so even when the vas is absent, it can still be non-obstructive, but the percentage is very, very less. And the second thing is when the semen volume, the long axis of the testis, and the FSH level. So these are all, at every step we have pointers to tell that whether it is an obstructive type or a non-obstructive type. Because treatment wise, whenever we have a small volume testis with a high FSH, then it goes towards non-obstructive azoospermia. If the FSH is low on this side, then it is hypogonadotrophic hypogonadism, which is again being discussed separately. And on this side, we have either retrograde ejaculation, obstructive azoospermia, etc., where the treatments are different. Why is this distinction very important? Because in non-obstructive azoospermia, the treatment is going to be sperm retrieval. And before we do sperm retrieval, we need to be sure of the diagnosis, and we have to optimize the patient before taking him to the theatre. And we also have to have our backup plans. So diagnosing this patient, whether we will get sperms or not, and how does the prognosis be? All these things are the most important points in non-obstructive azoospermia. Other than that, the treatment is actually straightforward when compared to the other factors which we have been discussing from the morning. So these are all the things which we are able to make out. And from this, we come to a situation where we are dealing with a non-obstructive azoospermia with a testicular failure. So this is what, in a nutshell, we have to diagnose. So again, on the general examination, vas, semen volume, FSH, hormones, everything, there is a difference between non-obstructive and obstructive. And as we go through these things, we can, at the end of the evaluation, make out whether we are dealing with a non-obstructive type or obstructive type. So again, this is a schematic diagram which is helping us to identify the difference between obstructive and non-obstructive and the treatment options which we have. So on the right side, we have an obstruction, which may be either absent vas, ejaculated duct cyst, or a very proximal vasoepidermal obstruction, where the sperm production is supposed to be normal. So each of these into marks represents the area of spermatogenesis. So the major difference between obstructive type and non-obstructive type is, in non-obstructive, it is a patchy or a focal spermatogenesis, which is at different places which we may not be able to make out from the outside, while in obstructive, it is more of a homogeneous sperm production. So this is the most important distinction I would like all of you to draw attention to. And the most common causes for a non-obstructive azoospermia will be a deficient hormone, or a genetic defect, or a varicocele. So these are the three main things. So going on, we do karyotyping, Y chromosome microdeletion, when we are more sure that we are dealing with a non-obstructive type. And unless there is a complete absence of vas difference, we don't do a CFTR gene sequencing. So going on to the treatment of non-obstructive azoospermia. So as all the previous speakers have told, female factors are very important. So the success of the ART also is dependent upon the female factor. So unless the female factor is strong, sometimes the male factor correcting or even taking a very good sperm doesn't give the full benefit. So here the first thing should be a favorable female factor. Then comes genetics. Then we go for sperm retrieval. So in sperm retrieval, we target these areas by our operations to take the sperm from the testis, and we do what is called a 6C. So now we again have a semi-live session in the afternoon where the details will be discussed. But here we need to understand the various types of sperm retrieval. So we have MESA, PISA, TISA and TC. These are the four main things. So two operations happen at the epidermal level and two operations happen at the testicular level. So this distinction again is very important, where an obstructive type we can take or rely upon epidermal sperms, while in a severe non-obstructive where a testicular failure happens, probably we are looking at a testicular sperm. This reason being, in testicular sperm extraction, the pathology for TSA or TC mainly is non-obstructive, where we are having such a severe sperm production defect, where even sometimes the sperms do not reach the epidermis. So it is not fair to tell that we can do a PSA for a severe non-obstructive with the primary testicular failure. So that is the distinction or the concept which you would like to note. So again, coming here, in non-obstructive, it may be a situation where the needle may miss the sperm producing areas. In obstructive, the needle is likely to hit the sperm producing area. So this is the difference again. And going on to what is micro TC, we use an operating microscope to identify this particular areas. So that is what we are trying to do in the sperm retrieval techniques, where if on PSA or TSA, if you are not getting, how does a micro TC work? How does the graded sequence of these operations improve the outcomes? That is only because we are now trying to focus on these areas and pick up the sperms from those areas. So as a matter of fact, many of us, even before taking andrology, we didn't know the difference between IVF and ICSI. So in ICSI, we directly inject the sperm into the egg. The one more reason why we are discussing these things here is because couples are now more informative and educated than the doctors. So as urologists, somehow these things don't fit into the curriculum well, and when we take up andrology, when we start subspecializing, only then we start knowing these intricacies. So many of us would be telling IVF, but what is done here is the ICSI. That is where when we start talking about treatment of varicocele, etc., we say downgrading from ICSI to IVF. That means we are not doing ICSI, we are doing IVF. So when we go to prepare a couple with non-obstructive azoospermia for treatment, female parameters are very important. Discussion with husband and wife is very important, and also with the treating gynecologist. And also the discussion about the donor sperm comes into the picture. So the other situations which we will be facing as we start doing more micro-TCs or more azoospermia treatments are, we will be faced with the situation as to whether we have to do medical management before micro-TC, and when the micro-TC has failed, then what next? So role of medical management, as I told in the initial slides and regarding the testicular failure, whenever we are sure about the diagnosis, we are sure about the treatment, as in any other urological procedure. So if the FSH is high, if the FSH is say more than 12, 15, etc., and if the testosterone is reasonably normal, say above 300, then it probably means that there is no role for empirical gonadotropins, medical management, or antioxidants. So we can be almost sure that this is only a surgical case. And similarly, when we have already see a patient who came with a failed micro-TC or a failed surgical sperm retrieval, again there is a dilemma as to whether we have to proceed with another sperm retrieval or we have to go for donor sperm. Again, in this situation also, we have to go back to the basics and see what is the female factor, whether the previous surgical procedure was only a testicular sperm aspiration or a micro-TC, and if the micro-TC was done earlier, then whether that micro-TC was done in the right method. So those are the things which we are supposed to introspect, and before that we take the decision. We have to be strong in whether we have to give medical management before going for micro-TC. So whenever we go for a failed case, these are the things to note. And whenever we go for a fresh case, we have to do the workup. We have to see whether medical management will modify the situation and then go for the final treatment. And role of varicocele repair is again dicey, as Dr. Raghavendra already told. We do have some situations. So if a sperm retrieval was done earlier, and if the patient comes to you that we had a failed IVF or we used donor sperm, now I want to try for my own sperms, we should always get the old report and see at what level there was a problem, whether or not sperms were there in the previous sample. So these are the most important things. And next thing is, when do we do the next micro-TC? So if the micro-TC was done in our center and we were very sure that we had done a right approach, it probably means that there is no scope or no role for another micro-TC, and we can only think about empiric gonadotropins, etc. And the usual time limit is maybe 2 to 3 spermatogenic cycles based on the female factor. So this is in short about say non-obstructive azoospermia, how to approach. Even though there will be a lot of queries and confusions, I think this is the most important concept which has to be taken into the mind. what is the LHFSH value, what is the testicular size, whether we are dealing with a non-obstructive or obstructive type, the female factor, and what surgical sperm retrieval to do, and adequate couple counseling so that we can decide the final treatment correctly. Thank you.
Thank you for the introduction, sir. So, I think with azoospermia, I think Karthikeyan has covered how to approach a case of obstructive azoospermia, how to differentiate in the case of azoospermia, whether obstructive and azoospermia. So, it makes the job easy. So, what I will be concentrating is mainly the pathologies, what we have to understand in obstructive azoospermia. So, obstructive azoospermia, the meaning is it's a non-obstructive, it is there is spermatogenesis affected. Whereas in obstructive, it is the spermatozoa was absent ejaculate in spite of a normal spermatogenesis. Whenever a case of infertility evaluation, usually about 5 to 15% we see with patients with obstructive azoospermia. In case of azoospermia, the majority is usually around 60 to 85% is usually non-obstructive, whereas around remaining 15 to 40% is from obstructive azoospermia. Whenever we think of obstructive azoospermia, it can be either congenital or acquired, and we need not have obstruction at only one side. The congenital cause usually can be a congenital bilateral absence of vas difference, or it can be an idiopathic epidermal obstruction. The acquired causes, the commonest one is the vasectomy, which we offer for sterilization. It can be infection, trauma, or other iatrogenic injuries. So coming to the first cause, ejaculate duct obstruction. So it is a rare cause, but the most important thing we have to know is this is the only reversible, the surgical correctable cause which we have in obstructive azoospermia. So apart from infertility, we have to keep the ejaculate obstruction whenever we have patient presenting with ejaculative pain or patient with low ejaculatory volume or hematospermia. You should always think about ejaculate obstruction. So it can be a complete or incomplete partial ejaculate obstruction. In the case of complete, we have a low volume acidic semen, and usually there is a absence of fructose. But the partial ejaculate obstruction usually presents with the case of oligospermia. And again, it can be congenital or acquired. Congenital is usually because of the congenital atresia or stenosis of the ejaculatory duct, and it can be a Mullerian duct or ovarian duct cysts can be there. Acute ejaculatory obstruction is usually secondary to trauma. It can be because of infection, inflammation, or calculus. The another important thing we need to know about is apart from congenital acquired, it can be functional ejaculatory obstruction. It can be because of it can spinal cord injury, or it can be systemic disorders like diabetes or multiple sclerosis. So when evaluating a patient ejaculatory obstruction, physical examination, there usually it is unremarkable, but there can be enlarged seminal vesicle, or there can be a midline nodule, prostatic nodule in perical examination. Lab test already discussed. Basic test we do is the FSH, LH, and the testosterone, which usually are normal in case of obstructive azoospermia. We do transrectal ultrasound. This is the only role where whenever we have obstructive azoospermia, suspect obstructive azoospermia, we ask for a truss. Again, the diagnostic criteria is the seminal vesicle should be dilated more than 1.5 centimeter in the anterior posterior diameter. And we can do seminal vesicle aspiration also through the truss, where we have more than 10 sperms per IPR field. Again, it confirms the diagnosis of obstructive azoospermia. So treatment aspect, I'm not going into detail. The transurethral resection of the ejaculate duct is the main treatment for ejaculate obstruction. So the algorithm for managing a patient with ejaculate obstruction is, as already mentioned, clinical presentation is usually infertility. Also, patient presenting with painful ejaculation, perineal pain or hematospermia, think of ejaculate obstruction as a cause as well. Our workup is basic history and physical examination. Usually, as I mentioned, PR is not unremarkable. Lab test, gonadotropins and testosterone are normal. Then we have a strong suspicion of ejaculate obstruction, then we proceed with truss. If necessary, we can aspirate the seminal vesicle for confirming the presence of sperms. If we come to a conclusion of either it's a complete or partial ED, then the treatment of choice is Tourette. The other options can be a cycloscopy, balloon dilatation, or cyst aspiration can be other options. And the last thing which I mentioned, if it is a functional ejaculate duct obstruction because of spinal cord injury or any pelvic injury, systemic disorders, we can take PDF inhibitors. Otherwise, the only option left is we go for sperm retrieval and ART. The next thing we see in a patient with obstetric azoospermia is congenital bilateral absence of VAS. This is because of the mutation in the CFTR gene. Physical examination, whenever we examine the patient, when there is absence of bilateral VAS difference and the testis is normal, we always think in terms of CBAVD. And in majority of the patients, the seminal vesicle are usually absent or hypoplastic. This we can confirm with the TRUS. And in a few selected patients, we have unilateral agenesis in case of CBAVD. Usually, renal abnormalities are more common in unilateral absence of VAS. In few patients of CBAVD also, we have renal anomalies. So next is unilateral absence of VAS. It's a very rare clinical presentation we see. This is because of the failure of organogenesis of the Wolffian duct. In this, around 80% of the patients are present with renal agenesis, and even sometimes, usually these patients do not present with infertility because other VAS is present. But whenever there is a contralateral mesonephric duct abnormality along with absent VAS, then these patients present with infertility. The infective causes is epididymitis, gonorrhea, chlamydia. This can be the various organisms causing epididymitis. This epididymitis causes inflammation, scarring, and finally leading to epidermal obstruction. On examination, we have a large or indurated epididymis, and we can easily make out a clear-cut point of obstruction when we examine the VAS. And in case of TB, as we all know, it will be multiple segment of obstruction. It will be nodular and enlarged in case of tuberculosis. So, but usually epidermal obstruction in developed countries, infection is not the much cause. In our developing countries, usually the most of the epidermal obstruction is due because of infection. And in these cases, the only option available is this total exploration and microsurgical reconstruction. But in case of tuberculosis, the prognosis of surgery and the outcome is poor. The last is iatrogenic injury. This is because of vessel injury, because of various inguinal, scrotal, and pelvic surgeries. The mechanism of injury is mainly because of the transaction. More than 25% is because of transaction. And in this iatrogenic injury, especially if this injury happens either in the scrotum or inguinal canal, the surgical reconstruction option is possible. And the most common iatrogenic cause we see as surgeons, we do vasectomy for sterilization. This is the most common cause, but the most important thing is the reconstruction offers the restoration of their fertility. And nowadays, with increasing number of male sterilization and increasing number of frequencies, we have more number of vasovasostomy reconstruction these days. The advantage is, compared to sperm retrieval and ICSI, reconstruction is very less expensive, and the chance of multiple pregnancies are more. Patient can plan for the next pregnancy as well. So the previous Dr. Karthikeyan had presented how the algorithm for management of non-obstetric azoospermia. So whenever see a patient of azoospermia, the first our job is to categorize whether it is non-obstetric or obstetric azoospermia. So when we think it is more in terms of obstetric azoospermia, the most important thing we need to see is whether there is a normal semen volume and whether it is alkaline pH. So whenever it is a normal semen volume and alkaline pH, we think it is either vasal or epidermal obstruction, and the only option will be a microsurgical reconstruction. When there is a low semen volume and acidic pH, and if there is absence of one or both VAS, then you refer a genetic analysis. If the CFTR gene is positive, then the only option is surgical sperm retrieval and ICSI. If the CFTR mutation is negative, then you for renal ultrasound for checking for the renal anomalies. And if the bilateral, it's a low semen volume, acidic pH, bilateral VAS is palpable, then we go for TRUS. TRUS obviously will show the diagnostic, what I mentioned is the dilatation more than 1.5 centimeter. So we diagnose as ejaculate obstruction. The option can be turret, or the patient not willing for turret, we can go surgical sperm retrieval and ICSI. So a brief about turret is, we use a 24 French resectoscope and electrocautery. You resect the ejaculate at the level of the verumentanum. The success, what we see in that surgery, you visualize the milky fluid coming out from the resection level. But nowadays, with the advancement, we can use a bipolar cautery or a balloon dilatation or a holmium laser can be used. So the patency rate can be up to 95% patients have the patency, and the semen quality improvement issue around 60% of the patients. But the end, whatever in reproductive medicine, whenever we see, we have to always should not stop with the patency rate or semen quality improvement. Always we have to see the live birth, the pregnancy rate also have to consider. At the end of Q rate is usually about 10 to 30% is the natural pregnancy rate. Comparing to congenital versus acquired, in the congenital group, the pregnancy rate are higher, around 66%, whereas 12.5% in case of acquired cause of ejaculate obstruction. Coming to microsurgical reconstruction, that we will be discussing on the afternoon sessions about the vasovasostomy and vasoapodostomy. Next, surgical sperm retrieval. Again, the options available can be a real percutaneous or it can be open surgery. Percutaneous is from the epidermis, is the percutaneous epidermal aspiration. PISA is the most commonly which we do for obstructive cases, and TISA, this is the percutaneous. And coming to the open approaches, it can be a TISA or MISA or minimal invasive epidermal sperm reaction. These are the surgical sperm retrieval options which are available, again, which we will be discussing in the semi-live video session. So in case of obstetric sperm, to conclude, infertility because of obstetric spermia can be effectively treated by surgical deconstruction or by surgical sperm retrieval. Whenever the obstetric spermia is because of vasectomy and there are no other female factors, because when female factors is there, we should not consider about reconstruction. Patient with vasectomy with female factors normal, then microsurgical reconstruction is an optimal option which will help. And sperm retrieval is the best choice for obstetric spermia whenever the female has a rapidly diminishing ovarian reserve due to age or concern. We do not opt for reconstruction. We go for sperm retrieval in these patients. And there is coexisting female infertility factors, or there is a concomitant secondary male infertility factor in the male partner, or there is a likelihood of success of sperm retrieval than the surgical treatment. You go for surgical retrieval on ICSI rather than reconstruction. Thank you.
Endocrine system is the prime regulator of the reproductive functions. So male reproductive functions are mainly depends upon the crosstalk between the various reproductive and non-reproductive hormones. Any disruption in this fine balance can lead to the male hypogonadism and male infertility. So if you see the data from the WHO, almost 20% of the world population are infertile. So this is the data from the WHO. Almost 1 in every 6 person have faced infertility at some point of their lifetime. So the contributor of the male infertility is almost 30 to 50%. So this is the global data showing that. So the male factor infertility itself contributes to almost 30 to 50%. So this is the data showing the effect of the various factors on the sperm production and sperm quality. So this is the data from the almost 30 to 35 years. So they looked at the quality and quantity of the sperm over the decades. So if you see, almost in 1980 to 85, the average sperm count was almost 98 millions. By over these 33 decades, the sperm count is significantly reduced to 52 millions. So that could be one of the reasons for the increased prevalence of male factor infertility. So what are the reasons for the increased prevalence of sperm abnormalities? There are various reasons like, so environmental and occupational exposure like endocrine disruptors and environmental toxins, pesticides and heavy metals, they directly or indirectly affect the spermatogenesis and causes the dysfunction of the sperms. At the same time, causes the low testosterone due to the defect of the Leydig cells. So that is due to the either oxidative stress or indirectly by affecting the endocrine organs. So various endocrine dysfunctions like diabetes, thyroid and other endocrine disorders also directly or indirectly affect the HPG axis, which ultimately lead to the dysfunction of the Leydig and Sertoli cells, which ultimately lead to the development of the hypogonadism and infertility. So this is the basic core component of the male reproductive function. That is the HPG axis, hypothalamic pituitary gonadal axis. So the GNR, the hypothalamus is the prime regulator of the most of the endocrine systems or functions. So which secretes the GnRH, which stimulate the anterior pituitary to stimulate the LH and FSH. LH in turn goes to the testes in the Leydig cells, which stimulate the production of testosterone. So testosterone in turn initiate and stimulate the spermatogenesis through the help of the FSH and FSH. So the intratesticular testosterone is the main factor, so which is the leading force for the production of the sperms. So in turn, testosterone directly will go to the pituitary and suppress the LH and FSH, that is the feedback inhibition. So at the same time, Sertoli cells stimulate the inhibin that indirectly suppress the pituitary. So this is the feedback mechanism. So this is the basic component of the male reproductive system. So almost all the endocrine systems will directly or indirectly affect the HPG axis, will cause the defect in the production of the sperms, that is spermatogenesis, and the defect in the steroidogenesis that directly causes the hypogonadism and infertility. So the spermatogenesis requires the function of the both the gonadotropin, that is LH and FSH. So LH will stimulate the steroidogenesis, testosterone, and the FSH stimulate the spermatogenesis. If any defect at both these levels can lead to the male infertility or subfertility. So what is the importance of the endocrinology in the male infertility? Because most of the evaluation should involve the endocrine evaluation, because the endocrine disorders, if you identify properly, if you treat properly, so which is potentially reversible. So if the patient is noticed to have testicular defect or the primary hypogonadism, so most of the times it may not be reversible. But if you identify other causes of endocrine male infertility, it is potentially reversible. So these are the endocrine factors which lead to male infertility is almost 2 to 5%. They are the various endocrine disorders which cause the male infertility. So among those, most important one is the hypogonadotropic hypogonadism. So which is defect at the level of the hypothalamus or pituitary, which leads to reduced LH and FSH, ultimately lead to the hypogonadism and infertility. This is the hypogonadotropic hypogonadism, which can be congenital or acquired. So the most common congenital hypo is the Kalman syndrome. So other disorders, any CNS disorder can cause the hypothalamic or pituitary defect, which can cause the hypogonadotropic hypogonadism, like the infections or tumors or trauma, radiation therapy. So all the hypogonadism may not be due to organic disease. So some functional disorders also can cause the hypo, like any chronic illness or any malnutrition or excessive stress also can affect the HPG axis, when it can cause the hypogonadotropic hypogonadism. So hypergonadotropic hypogonadism is if the defect at the level of the testis which causes the hypergonadotropic hypogonadism. In those situations, the testosterone will be low and LHFSH will be very high. So most of the time, so hypergonadotropic hypogonadism may not be treatable. So if the defect is at the level of the testis, but some reversible causes can be treated, like so any drugs causing the defect at the level of the testis, if you stop those medications, which can be reversible. So this is the diagnostic evaluation of the hypogonadism. So if you suspect any, if the patient have any symptoms of hypogonadism, so look at the cause of the any secondary cause or functional causes. Rule out the functional causes. So if it is not there, measure the morning fasting serum testosterone. So testosterone have the diurnal and diannual variations. So that is the reason we need to take at least 2 samples of the testosterone in the fasting, because the food intake can cause the suppression of the testosterone. So morning fasting testosterone should be evaluated at least 2 samples due to the diurnal and diannual variations. So if the testosterone level is low, so that confirms the hypogonadism. So to know the reason of the hypogonadism, we need to look at the measurement of the gonadotropin, that is LH and FSH. So if the LH and FSH is high, then that defect is at the level of the testis. So then we call it as the primary hypogonadism or hypergonadotropic hypogonadism. So if the testosterone is low and LH and FSH are low or inappropriately normal, then we call it as a secondary hypogonadism or hypogonadotropic hypogonadism. So to know the reason, sometimes depending upon the clinical features, so the patient may require the genetic analysis to diagnose the Klinefelter syndrome or the evaluation of the other pituitary hormones or MRI to know the any pathology at the level of the pituitary or hypothalamus. So one of the common condition nowadays, which is leading to the hypogonadism, is the hypothyroidism. So hypothyroidism is one of the important diagnosis in the evaluation of the male infertility. So the hypothyroidism directly affect the HPG axis, so which can lead to dysfunction of the LH and FSH, which may lead to the hypogonadism, which lead to the development of the low libido, at the same time erectile dysfunction. And hypothyroidism also indirectly cause the reduced levels of the SHB, the sex hormone binding globulin, which impairs the total testosterone concentration, at the same time which also affect the testis, which also reduce the level of the free testosterone levels. So that indirectly or directly causes the dysfunction of the testis, so which lead to the abnormality of the semen quality and quantity and disruption of the semen sperm motility. So this lead to the male infertility. So if you identify early, if you treat properly, so most of the patients of the hypothyroidism which are associated with the male infertility can be treatable. And hypothyroidism also indirectly can increase the prolactin levels. So it also one of the secondary cause of hyperprolactinemia. So by doing that also, which can cause the hypogonadism and infertility. So even similarly, hyperthyroidism also. In hyperthyroidism, so the SHBG levels will be low, but free testosterone will be low. So that will lead to the erectile dysfunction at the same time, which also causes the defects in the sperm quality and quantity. So if you treat almost more than 85% of the times, if you treat the hyperthyroidism, the infertility also will be recovered. So these are the effects of the thyroid hormones at the various levels of the testes, which affect the Sertoli cells, Leydig cells at the same time, which also seminiferous tubules. So hyperprolactinemia nowadays is one of the common reasons due to the increased utility of the PPIs and the antiemetics and anticyclics. So drug-induced hyperprolactinemia is one of the common reasons. So prolactin levels, high prolactin will suppress the GnRH stimulation. The pulsatile GnRH secretion will be suppressed. That lead to the hypogonadism. At the same time, prolactin also have the receptors at the level of the testis, so which also directly cause the suppression of the steroidogenesis at the same time the spermatogenesis. And most of the times it is physiological or drug induced. If you rule out those drugs, it will be reversible. So or else it can be due to the pituitary adenoma. So the MRI is required, and most of the times medical treatment is sufficient for the hyperprolactinemia. So diabetes mellitus. So nowadays more number of diabetes patients we are diagnosing the reproductive age group. That is the reason. This is also one of the important cause for the hypogonadism and infertility. So diabetes will affect at the various levels, which will cause the hypogonadism or infertility. So pre-testicular, testicular, and post-testicular levels. So due to the effect of the HPG axis and due to the oxidative stress directly inhibit the spermatogenesis and steroidogenesis. So this is a study looking at the diabetes, so which causes the reduced progressive motility, so reduce the semen volume and normal form. So at any spectrum, so diabetes can affect the infertility, and as the duration of diabetes progresses, the hypogonadism also will increases. So obesity, now more number of obese people we are seeing. So obesity directly or indirectly will suppress the pituitary, and LH and FSH will cause the hypogonadism. So the kisspeptin is one of the important hormone which lead to the development of the puberty, at the same time the development of the spermatogenesis and steroidogenesis. So obesity will suppress the kisspeptin, that ultimately lead to the hypogonadism, and increased aromatization will also lead to the increased estradiol, that also suppress the hypothalamus, so which ultimately lead to the development of the hypogonadism and infertility. So acromegaly is one of the rare cause of the hypogonadism. So the growth hormone will directly suppress LH and FSH and ultimately lead to the hypogonadism. So coming to the evaluation of male infertility, if you suspect any hypogonadism or male infertility, so these are the basic investigations: morning plasma testosterone at least 2 occasions. So followed by, to know the reason whether it is hyper-hypo or hypo-hypo, we need the basal gonadotropins, that is LH and FSH, and depending upon the clinical situation, the diabetes evaluation, thyroid and prolactin, those are required depending upon the clinical situation. And for the final diagnosis, the patient may require the karyotype if you suspect any genetic disorder, or the MRI if you suspect any pituitary or hypothalamic lesion. So for the treatment, if you identify the basal endocrine disorder, if you treat, most of the times it will be reversible. The testosterone will improve, at the same time semen sperm quality also will be improved, and male infertility also reversible with the proper identification and treatment of the endocrine disorders. The only thing is that if the patient is having hypergonadism, hypogonadism, if the testis is the problem, then most of the treatment may not be that successful. So to conclude, endocrine regulations of the male reproductive functions follow the intricate mechanisms, and the principal endocrine axis is the HPG, and the most of the endocrine reproductive non-reproductive hormones will suppress the HPG, that lead to the development of the hypogonadism. And the hormonal evaluation is one of the basic evaluation in the management of the male infertility. So definitely with the proper treatment, the infertility will be improved. So thank you for your patient listening. So androgen therapy in hypogonadism is only for the maintenance of the normal serum testosterone levels and to improve the libido and mood and erections and the sexual intercourse. But it is not for the maintenance or induction of the fertility. So if you give the exogenous testosterone, which may suppress the intratesticular testosterone, because intratesticular testosterone is important for the production of the sperm or spermatogenesis. So if you give the exogenous testosterone, which may not be sufficient for the elevated levels of the intratesticular testosterone, so which may not be suitable for the fertility induction. So which is the only for the maintenance of the normal testosterone levels, at the same time for the erections and other sexual issues. So this is the flow of my presentation. So as we discussed, so this is the HPG axis, which is important for the testosterone, at the same time spermatogenesis. And these are three hormones for the maintenance of the normal fertility and the testosterone functions. So the testosterone is for the neurocognitive development and voice change. At the same time, the virilization of the growth. At the same time, the bone and muscle mass development. So the FSH for the production of the spermatogenesis, and HCG for the increased testosterone levels. So the hypogonadism is the failure of the testosterone, production of the normal testosterone, at the same time failure of the production of the normal number of sperm. So this is the definition of the hypogonadism. So hypogonadism can be due to any component of the HPG axis. So if the problem is at the level of the pituitary, we call it, or hypothalamus, we call it as the hypogonadism or secondary hypogonadism. If the problem is at the level of the testis, we call it as the primary hypogonadism or hypergonadotropic hypogonadism. Some patients may have combined primary and secondary hypogonadism. So there are various reasons are there for the hypogonadism, which may be functional or which may be organic. So any chronic illness or some drugs and other secondary endocrine causes also can lead to the development of the functional hypogonadism. And regarding the organic causes, which can be either congenital or acquired, in the congenital, it can be only isolated hypogonadism, that is the Kalman syndrome, which may be or may not be associated with anosmia. And it may be associated with the other pituitary hormone deficiencies, or the multiple pituitary hormone deficiencies, also one of the reason. And other metabolic disorders, or the radiation or surgery, neurological infection, any can cause the hypogonadism. So this is one of the recent case. So here is a 24-year-old male. So presented with the delayed development of secondary sexual characteristics. So he has no facial hair, and he has a childhood habitus. At the same time, the testis size and penile size is very low. So he's also classically telling that he is having anosmia. So this is one of the classical feature. And his testosterone levels are very low, 2.7 nanogram per DL, and LH and FSH are falsely low. So this is the classical case of hypogonadotropic hypogonadism. So his MRI showing the small anterior pituitary, and classically he is not having the olfactory sulcus and olfactory bulb. So which is the classical case of the Kalman syndrome, which is the congenital hypogonadotropic hypogonadism. So in this type of patient, there are two options for the induction of the puberty. So one option is with the testosterone or exon testosterone definitely induce the puberty, but which may not be improve the fertility. But here is a young patient, we can start with the testosterone therapy. For the fertility induction, we need the introduction of the gonadotropins or FSH and LH. So the symptoms should be there, and the testosterone levels should be low. So at least 2 testosterone values are required because of further diurnal variation, and the testosterone should be done in the morning fasting state, because food suppresses the testosterone levels. And even around 20% of the normal eugonadal men also have low testosterone levels if you take the single sample. That is the reason at least 2 testosterone samples are required for the diagnosis of the hypogonadism. So, and the most of testosterone bound to the albumin are the SHBG. So only around 2 to 3% of the testosterone is freely available for the actions. So that is the reason there are few conditions which may require the free testosterone hormone evaluation. So for every patient, no need of further free testosterone evaluation, because most of the labs may not be that standard. So that is the reason total testosterone is adequately enough. But these are 3 situations where free testosterone evaluation can be done. So one is if the total testosterone levels are the lower normal level. So if it is less than 200 to 400, so our borderline values, definitely we need to go for the free testosterone evaluation. But in some situations which will affect the SHB's concentration, then those situations also we need to go for the measurement of the free testosterone levels. Otherwise, no need of any free testosterone evaluation. So this is the diagnosis, it's already discussed. So what are the goals of the androgen therapy? There are the goals of the therapy depending upon what is the age of the patient. So if the patient is presented with a prepubertal hypogonadism or the adult hypogonadism. So in the prepubertal hypogonadism, the goal of the therapy is to induce the puberty and the development of the secondary sexual characteristics and the development of the muscle mass and increase the bone mineral density and the improvement of the erections and libido. So this is the goal for the prepubertal hypogonadism. For the adult hypogonadism, so the goal of the therapy is to improve the libido and improve the erectile function and improve the BMD and improve the energy, mood and motivation. So these are the 2 different goals for the hypogonadism, androgen therapy for the hypogonadism. So various formulations are available for the androgen therapy. So most commonly we use the testosterone injections, that intramuscular injections, which can be either short acting or long acting. And nowadays we have the testosterone gels, patches, and intranasal, transbuccal, other different formulations are available. But most commonly we use the testosterone injections. So what is the decision how to decide whether which formulation is useful for the particular patient, which is depending upon the preference of the patient and the preference of the physician, and the pharmacokinetics of the formulation and the cost of the therapy, at the same time affordability and the adverse effect profile. So the available testosterone parenteral injections are the testosterone enanthate and testosterone cypionate, which are given as the intramuscular injections. So which are relatively safe and one of the most effective drugs, and we have the long experience with the testosterone injections, and which requires less frequent administration. And the problem with the injections are that there is a significant fluctuations of the testosterone levels will be there, so that lead to the significant alteration of the mood and the erectile issues. So the dose is depending upon the age of the patient. For the pubertal induction, we'll start with a small dose, the 50 to 100 milligrams. So once in a month intramuscular, or if you want lesser dose, we can go for the 50 to 25 milligrams, 25 to 50 milligrams once in 2 weeks, and gradually we need to uptitrate to the adult dose over the few years. And for the adult hypogonadism, so we start with the full replacement dose, that is the 150 to 200 milligrams every 2 weeks. So immediately after the injection, the testosterone levels will go high. So it may reach above the normal levels within 1 to 2-3 days. That may cause the mood swings for the most of the patients. And within 2 weeks, the testosterone levels will fall down to the pre-injection level, or may go down again. So this is the problem with the testosterone injections. If you mitigate these issues, then we can reduce the frequency of the injection. Once in 10 days, 150 milligrams also can be used. So we have the lot of clinical experience with the testosterone injections, and the less frequent and inexpensive, and the patient can, if you educate properly, patient can inject the testosterone injections. But the problem with the injections are the IM definitely will cause discomfort, and there is significant fluctuations of the testosterone will be there in between the injections. The fluctuations will be there, and the frequent injections for the improvement of the fluctuations, and more erythrocytes. One of the complications with the testosterone is the increased erythrocytes, which is more with the testosterone injection when compared with the transdermal testosterone. So now we have the long-acting testosterone, that is the testosterone undecanoate. So which is given very slowly, so slow IM, so which cannot be given self-administered, it should be given in the clinic only. And there are 2 dosing patterns are available. So the 750 milligrams start and followed by repeat injection after 4 weeks, and after that every 10 weeks. So RS, we have the 1000 milligrams of injection in 4 ml, so which is started followed by the 6 weeks after the second injection, followed by the once in 10 to 14 weeks. So once in 3 months, you can give the testosterone undecanoate of 1000 milligrams. So less frequent injection, definitely, which may be preferable for some patients. And the normal testosterone is maintained, so the fluctuations will be less with the long-acting testosterone undecanoate when comparing with the testosterone esters. And the disadvantage is the large volume, which may be discomforting for the most of the patients. And importantly, the pulmonary oil microembolism is there with the long-acting injections. That is the reason we need to, after giving the injection, we need to observe the patient at least 30 minutes for the anaphylaxis and for the oil embolism. And if the patient develops any complications, so we may not immediately remove the injections. But if with the testosterone, transdermal testosterone, if you stop the treatment, the recovery will be very fast. So now we have the transdermal testosterone is available, like the patches or gels are solutions. So the advantages are the normal levels are maintained better with the patches or gels when comparing the testosterone injections. And the no injections definitely, and the dose flexibility is also there. But the problem with the patches or gels are the transfer to the females or the children, and the daily application, and more expensive when comparing the testosterone injection, which is more expensive, and it can cause skin irritation. So the advantage is if you stop immediately, so that the PSA levels will come down at the same. Erythrocytes also will be recovered very fast with the testosterone transdermal preparations. So this is a patch available in the 2 mg and 4 mg. So start with the 2 mg or 4 mg or 6 mg depending upon the requirement. So which should be applied over the non-pressure areas, and it should mimic the circadian level if you apply in the night. So various strength of the testosterone gels are available, which can be applied to the shoulder or upper arm, thigh depending upon the preparation. So oral tablets also are available. The testosterone undecanoate tablet is also available. So which is available in the 40 mg, 80 mg strength, which can be given 2 to 3 times daily. But the fluctuations are very high with the testosterone capsules when comparing with the testosterone gels. So these are the other available formulations. So if you see the graph, so with the testosterone injection, there is significant fluctuations of the serum testosterone will be there. So that leads to the significant mood swings for the patients. But with the long-acting testosterone that's undecanoate, so the graph will be very flat, then the fluctuations will be very low. And similar with the transdermal testosterone preparations. So how to monitor? So monitoring, there are two types of monitoring are there. So the monitor for the clinical efficacy, so whether the symptoms of androgen deficiency are there or not, and the serum testosterone levels and BMD, and to monitor the adverse effects. So the main adverse effect is the increased hematocrit and increase the PSA levels. So clinically, we need to monitor before starting the therapy and within 3 to 6 months. After that, every yearly we need to monitor clinically. And serum testosterone levels should be monitored after 3 to 6 months. And the goal is to maintain the mid-normal range. So there are two types of monitoring. So midway between the two injections, which will give the whether the dose is adequate or not. So which can test the testosterone levels immediately before the next injection. So which will give the whether the frequency is good or not. Yeah. So after for the gels and testosterone patches, after 3 to 4 weeks, we need to monitor. So these are the two common side effects for the testosterone injection. That is increased hematocrit. If the baseline hematocrit is more than 54%, better to stop better not to initiate. And if you after the starting, if the hematocrit is increased more than 54%, then better to stop. So or else it will cause the increased risk of thromboembolism or thrombosis. And the PSA, definitely if the age is more than 50 years, so definitely we need to monitor the PSA levels. Or over the course of the time, if the PSA levels is high, then we need to go for the proper urological evaluation. So before starting the therapy, we need to look some contraindications, but definitely, as I told, if it is not for the fertility injection, it is only for the maintenance of the testosterone levels. So if the patient is planning for the fertility, we should not start the testosterone injections. And if the patient is having active prostate or breast cancer, it should not be given. It should not start. And if the baseline hematocrit levels is also high, then better not to start with the testosterone injections. And uncontrolled heart failure and the recent MIR stroke also should not be start with the testosterone injections. So these are the common adverse effects with the testosterone injections. To conclude, hypo is one of the common clinical conditions which lead to the development of the hypogonadism in male infertility. If you diagnose properly with the proper management of the gonadotropins, the hypogonadism also will be improved. So for the testosterone levels, before starting the therapy, you need to look at the contraindications, and after starting the therapy, we need to clinically and biochemically monitor for the adequacy of the therapy. So thank you for your patient listening.
I'll be talking about the management of infertility in patients with hypogonadotropic hypogonadism. I'll try to do the justice in the time allotted to me. Yeah, next slide. This would be the outflow of my talk. I'll be talking about the hypogonadism, pre-treatment evaluation, the options available for us to induce fertility in patients with hypo, and will be summarizing at the end. I'll not be talking in detail about the physiology. We all know that the hypothalamus starts producing the gonadotropin releasing hormones at the appropriate time, that is at the puberty, following which there is a stimulation in the pituitary, because of which there is increased production of the LH and FSH. Now these two hormones have individualistic actions. FSH has an effect on the Sertoli cells, following which there is increase in the levels of the strength or the proliferation of the Sertoli cells, because of which the serum inhibin levels get increased. And this serum inhibin B levels, which are produced by the Sertoli cells, will have a negative feedback effect on the pituitary production of the FSH. Parallelly, LH, which gets produced in the pituitary, will stimulate the testosterone. The Leydig cells in the testis will increase the levels of the testosterone, and this testosterone will have a negative feedback on the production of the LH at the pituitary level. So the feedback mechanisms of the LH and FSH are slightly different. Now, why is this important to know this type of physiology? Is because we need to know a little bit about the mini puberty when we are talking about the management of infertility in the patients with hypo. So what is this phenomena of the mini puberty? In the mini puberty, that is after the birth of the male infant, what happens because of the sudden fall in the levels of the maternal estrogen levels, as well as the fall in the feedback mechanisms of the placental HCG, the quiescent HBG axis, which is there in the neonate, suddenly gets activated, because of which the levels of the gonadotrophins, both the LH and FSH, starts picking up. And this picking up of the LH and FSH can last up to 6 months of the age. The maximal effects of this LH and FSH, the maximal concentrations of this LH and FSH can be seen at 2 months of age. Now what happens because of which the elevations of both the LH and FSH, what is happening is LH increases the levels of the testosterone from the Leydig cells. There is an increased paracrine effect of this testosterone within the testis. Also, the increased levels of the FSH, which happens at around 2 months of age, the peaking of the FSH, what is happening? There is increased proliferation of the Sertoli cells, which means that more and more Sertoli cells are available for the neonate in the future. This has an impact on the future fertility potential. If this mini-puberty is not going to happen in an infant with established HH, that is hypogonadotropic hypogonadism, what is happening? The LH production doesn't happen, because of which this proliferation of the immature Sertoli cells at the mini-puberty is not going to happen. Now this point needs to be remembered when we are trying to treat the patients with hypo at the appropriate age. Now when there is no proliferation of these immature Sertoli cells, this fertility potential is going to come down the line, and this point needs to be considered when we are treating these patients down the line. Serum markers of the testicular development, I think I'll try to skip it. What is more important is we need to monitor the inhibin B levels at the time when we are monitoring the therapy for the hypo. And another point which needs to be considered is the LH, which stimulates the testosterone production. These testosterone concentrations within the testis is at a very high level. There is more than 30 to 40 times the systemic level, and this paracrine effect of the testosterone within the testis is going to have a beneficial effect in the seminiferous tubules when it comes to the cell maturation and proliferation in the long run. Coming to the etiology of the male infertility, most of the times it is because of the testicular disorders. Nearly 2/3 of them are because of that. About 5% of them are because of the disorders at the level of the pituitary as well as the hypothalamus, that is the pretesticular, which we are interested in the current talk today. Hypogonadism, we know that it is decreased levels of the testosterone, inability to maintain the testosterone levels, inability to produce the normal quality and quantity of the spermatozoa. The failure can be at the level of the pituitary, which is a secondary hypogonadism. The failure can be at the level of the testosterone, which is a primary testicular failure. Sometimes the dual effects can be seen, which is really uncommon. Now coming to the hypogonadotropic hypogonadism, as the name suggests, the hypogonadism is because of decreased levels of the gonadotropins. So the problem is at the level of pituitary. It is not able to produce LH, FSH, or not able to produce adequate concentrations or the adequate levels of the LH and FSH, which could in turn be because of the problem at the hypothalamic level. Put together, they can cause hypogonadotropic hypogonadism. The common causes are the acquired causes like tumors at the level of the pituitary, radiation, or some other systemic disorders which can be because of the hemocitosis and other factors which can damage both hypothalamus as well as the pituitary. The congenital causes, congenital hypogonadotropic hypogonadism, is little uncommon, seen in about 1 to 4,000 to 5,000 units. It can be transmittable in autosomal dominant or recessive way or in mixed ways. Coming to the treatment of the hypogonadism, we'll be talking more about the secondary hypogonadism. First, when we are trying to evaluate or induce fertility in the patients with hypo, we have to establish the cause. As said, it is a congenital hypo, or is it an acquired hypo because of the tumors or something else which has caused the damage to the pituitary or hypothalamus needs to be known. Why is it important? We should also address the other axis of the pituitary, not just the gonadal axis. Look into the thyroid axis, the adrenal axis before we address the gonadotropin axis also. The pre-treatment evaluation include the diagnosis of hypo, the history in detail, as well as the clinical examination to look at the testicular volume. If the testicular volume is lower than 4 ml, when the patient presents to us at the infertility clinic, it actually indicates, it is below 4 ml, it actually indicates the patient has not undergone the mini-puberty or the Sertoli cell proliferation has not happened. So these type of patients are likely to have a less poor outcome when we treat them for the infertility. Now coming to the hormonal evaluation, if you see in the patients with hypogonadotropic hypogonadism, the testosterone levels are obviously low, and they are low because of the decreased levels and the concentrations of the both LH and FSH. If the levels of LH and FSH are more and the testosterone is low, that means that the problem is at the level of the pituitary, then it is a hypergonadotropic hypogonadism. Now, what are the predictors of the good spermatogenesis induction in male patients with the hypogonadotropic hypogonadism? Now, the positive predictor factors include patients who has already undergone the puberty and developed the damages at a later date or after the puberty. That is in acquired cases of hypo. The testicular volume is more than 4 ml with no history of testicular, maldescent or the cryptorchidism, or someone who had a baseline inhibin levels of more than 60 picogram per ml and who had a good spermatogenesis response in the prior cycles are the ones who are having a positive, are the factors which have a positive predictive value when compared to the other things. Now, the treatment regimens which are available to us to induce the fertility, the first one is the gonadotropin itself, which is the pulsatile gonadotropin therapy. The treatment, this particular option is limited because the pulsatile gonadotropin administration should be given by the subcutaneous infusion pump. The availability of the infusion pump, the cost incurred, the expertise which is to be available when we are giving the subcutaneous gonadotropin therapy in a pulsatile way, all these limit this therapy. Will not go into the detail. However, the outcomes are similar to that of gonadotropins, except in cases of a problem with the pituitary levels, wherein this pulsatile gonadotropin therapy, GnRH therapy, may not be efficacious if the problem is at the level of pituitary, because the pituitary is not going to get stimulated because of the GnRH. Now, coming to the gonadotropin therapy, most of the times, 90% of the times, because of the gonadotropin therapy, the fertility can be induced. However, in about 10% of the cases, if the fertility cannot be induced, then we have the support of the assisted reproductive technologies. The available gonadotropin therapies include the drugs which have got LH-like action, that is human chorionic gonadotropin, the recombinant HCG or the recombinant LH, all of which are commercially available, except for the recombinant LH, sometimes it may not be available. FSH-like action like human menopausal gonadotropins, recombinant FSH and FSH which is derived from the urinary ureofolitropins. I'll just talk about two case vignettes so that we can conclude the talk. Now, first case is a 30-year-old man who has undergone a transperineal surgery 3 years back and was maintained on the other hormone support. He had 2 children and was wishing for fertility. And on evaluation, his testicular volume was about 8 ml. Both LH and FSH as well as the testosterone levels were low. So how do we go about in this patient? This patient was started on the human chorionic gonadotropin, 2,000 units twice a week. Achieved a normal range of hemoglobin and testosterone over a period of 3 to 6 months. His testes grew and the semen analysis showed improvement in the counts, and subsequently the spouse conceived and the target was achieved. And why was the HCG monotherapy so successful in this case? That's because this patient has already achieved the mini puberty as well as the puberty has been achieved. The testicular volume was more than 8 ml, so the Sertoli cell population was already matured and the proliferation of the Sertoli cells has happened. That's why in this case, simple HCG therapy alone will give you the increase in the semen counts, the sperm counts in the semen analysis. We are using the HCG because it is an analog similar to that of LH. It acts as a longer, it has a longer half-life than that of LH, which has a shorter half-life, and it can be used in replacement to the LH to induce the fertility. And again, similar to LH, the HCG can also increase the levels of the testosterone concentrations. And this alone can induce the fertility, especially in the patients with the acquired hypo. But FSH alone may not be able to help in cases of acquired hypo. It may require support of the HCG also. So the dose monitoring can be, you can start the dosages with as low as 1,000 units twice a week, can be up-titrated to 2,000, 2,500 and 5,000. The maximum dose can be 10,000 per week. Try to space it evenly, like, once in 3 days or once in 2 days. A gap of not more than 3 days should be kept to have adequate levels of the testosterone to be maintained between 4 to 8 nanogram per ml. Serum levels of the testosterone, estradiol, hemoglobin as well as the hematocrit should be monitored so that we do not overdose the patient, do not cause the erythrocytosis associated side effects. And once the levels are achieved, you can probably down titrate it. And if required, sometimes we monitor the levels of the HCG to the tune of 50 to 150 units per liter. If the fertility is not achieved, or if the semen analysis showed inadequate counts, then FSH can be added at the end of the 6 months, even after, or if the pregnancy could not be achieved the 6 months after the serum levels of the testosterone are maintained between 4 to 8 nanogram per ml, you can start the FSH. Now the FSH can be given in a dosages of 75 units thrice weekly to 150 units thrice weekly, maybe for 3 to 6 weeks. Sometimes the semen analysis can show the improvement in the sperm counts. And it can be administered in the same syringe as that of LH. Now coming to the case Vignette 2. Now this is a case of a Kalman syndrome who was diagnosed late in the tweens and who has come to us to the infertility clinic. His testicular volume is about 3 ml and he has azoospermia. Now in this case, the patient was started on the FSH 75 units alternate day, and after about 2 months, HCG 1500 units was started twice a week, achieving a normal levels of serum levels of hemoglobin, testosterone, estradiol and FSH. After 18 months, the testis grew to 20 ml, resulting in the viable singleton pregnancy and a healthy baby boy was delivered. Now, why in this patient FSH was started before the LH? Now, the logic goes is that this patient did not undergo the mini puberty, and at the level of the, and when he has achieved the age of puberty, he was not exposed to the levels of FSH. So the Sertoli cell population itself is low. So by adding FSH for about 2 months before we start the HCG, which actually increases the intratesticular concentration of the testosterone, when the Sertoli cell population itself is not there and it is not matured, the available testosterone may not be so effective in inducing a good sperm count. So these patients needs to be treated with FSH for about 2 to 3 months before we think of adding a HCG or LH to these patients. So adding an FSH can be monitored by looking at the serum inhibin levels. We know that the serum inhibin is elevated by the mature Sertoli cell. So once we add the FSH, the levels of the serum inhibin B levels get elevated. The FSH can be titrated depending upon the inhibin levels. And once the inhibin levels get plateaued, that is the time when we start the HCG therapy in these patients. And this may take about 3 to 6 to 9 months to start the HCG after the LH has been initiated. The points to remember is that androgen replacement therapy should not be used for the treatment of hypo males during who are desiring for the fertility. It may not help in the fertility at all. This is something which we have spoken just now. We need to maintain a time frame of about 3 to 4 months whenever we change the therapy. Start with the HCG therapy in the patients with hypo, monitor for 3 to 6 months. If there is no improvement in the sperm quality, the counts are not improved in the semen analysis, then start adding the FSH. And about 3 to 6 months we can wait. And after about 12 to 24 months, after maintaining the adequate levels of the testosterone in the range of 4 to 8 nanogram per nanogram per ml, if the fertility has not happened even after 12 to 24 months, we can take the help of ART techniques. Now, these are the clinical outcomes, and once you start the therapy, once the spouse is conceived, the choice is left to the patient. You can either discontinue the HCG therapy or continue the HCB therapy, which is advisable to continue till the second trimester, since the occurrence of the miscarriages are high in the first half of the pregnancy, and subsequently, depending upon the desire of the patient and the spouse, if they want any subsequent pregnancies, depending upon that, you can maintain the virilization either using the HCG or a simple testosterone can be initiated by discontinuing the HCG if the intention is only to maintain the virilization. Clomiphene citrate has a very limited activity. It is a selective estrogen receptor antagonist. However, it is having a very doubtful results, and most of the times it is not so effective. However, in the cases of pituitary, it is not really so effective to use the clomiphene citrate. So to summarize, gonadotropins are the recommended mode of therapy for most men with hypo who wish to become fertile, and they're the very convenient therapies when compared to the gonadotropin RH pulsatile pump therapy. If HCG alone doesn't increase the sperm count, and if the pregnancy has not occurred 6 months after the testosterone levels are maintained in the desired range, we should think of adding either FSH or the human menopausal gonadotropins. Most patients achieve the desired counts by about 6 months. Some of them may require up to 12 to 24 months. And if the sperms have appeared, but the pregnancy has not occurred spontaneously in 12 to 24 months, we can probably take the help of the ART techniques. And management once pregnancy has been achieved depends upon whether the couple is planning another pregnancy or not in the near future. The intention, if it is only to maintain the virilization, we can simply switch over to the testosterone therapy. Thank you one and all for your patient listening.
Thank you, Dr. Arun Mukka, for giving the practical.
So after listening to the endocrinologists about hypogonadism and its management, many urologists sitting here would be thinking, let us safely refer it to the endocrinologist. So whether we have to do that or we can start. Initially, I think when we have to learn these things, probably it's very important that we tie up with the endocrinologist, and there are so many other things which they do which we may not be able to do because we are not trained in that in the initial period of time. So when we approach a patient with hypo, so by hypogonadism, what I will be concentrating here is mainly the testosterone is low, that is less than say 250 to 300, and the LH and FSH are less than 2. So that is the definition for hypo, and only in those patients probably these are the treatments which will work. So what is our aim, and whether we are dealing with a severe oligoasthenoteratospermia or a complete azoospermia. This is the most important distinction we have to make. In a patient with say less than 1 million count, there is still a good chance that the sperm count will improve. But when it comes to azoospermia, we don't know whether the improvement is going to happen or how much time it is going to take. So the difference is very important. And next thing is how much time is available. So time and again we will be going through the same things today in the CME. What is the duration of married life? Whether the female factor is stable, and is there a societal pressure, and how much is the patient waiting to go through all these things? Because we should understand very clearly that the time required for these things is not short. And what are the patient expectations, and if the couple affordable for all these things? So we are looking at something where the HCG injection costs you around say 400 to 500 per injection, and the HMG goes up to say 1000, 1200. And it is, we are seeing at maybe minimum of 1 year to 1.5 years therapy. And if the sperm count improves, then still we may be looking at IVF, which is again say at least 2 lakhs to 2.5 lakhs. So when we start the therapy, it is very important to discuss with the couple, are you willing to go through all these things, and still the success may not be complete. So that discussion is very important. And what does the partner want? So because she is going to face all the brunt from the society telling whether how much time we have and how quickly they want the baby, etc. So at the outset, it is primary or secondary, whether it is all this pan-hypopituitarism, transaction, these things are above our mind, so we always take the help of the endocrinologist. We have done the evaluation, we have ruled out primary, like secondary causes, prolactin, etc. has been all ruled out. Now we have come to the situation where we know that it is a clear-cut hypo, and we will be able to do some justice to them in the treatment. So it's a clinical diagnosis, and after ruling out all this, and it should also be that there was no surgery done on the testes, etc. So we are ruling out everything, and we are coming to a conclusion. So then genetics is not routinely done, and this also requires long-term therapy. These are the two things which we should remember at this point of time. And the three main tests are LH, FSH, and testosterone. Here we don't do estradiol because already the testosterone is so low, so estradiol level may be low at that point of time. Maybe once the testosterone picks up, if the patient is obese, then estradiol comes into the picture. So the baseline testis volume, as it was mentioned by our previous speakers, so at least 4 cc to 5 cc, that amount. If it is more than that, then the outcome should be better. And there is no initial role for combined gonadotrophin therapy unless in certain special circumstances. And we have to have the next injection only after 6 to 12 months. When the testosterone has improved, only then it makes sense to add the second injection. So when to add HMG, testis volume has adequately improved, the testosterone has improved, and injection HMG can then be added. There may be a small role of clomid initially, the only reason being, even though we just heard Dr. Mukha's talk that clomiphene may not be very useful, it is a oral medication, it is very, very inexpensive, so we can add that if at all it is required. When to add HMG and how to give HMG is, so initially we should note that HCG is maybe 2 times or 3 times a week, while HMG is usually we go up to 3 times a week, and we don't initially prescribe recombinant FSH unless it is put forth by some special tests like genetic panels, and recombinant FSH is expensive. So we have to keep these things in mind when we plan the therapy, and we resort to TRT. So when a young adult comes to us without the question of infertility, for all these things like say penile girth, erections, etc., we can give TRT, that is testosterone replacement. And after completion of fertility and that window within the first and the second child also, we can give testosterone replacement. And the next important thing is, when do we do semen analysis? So we keep on giving HCG, and we are in the plan of adding HMG. So the idea to do semen analysis comes only when the testis volume has improved and the testosterone level has improved. So these are the two markers, and then we can do a baseline semen analysis at that point of time to see whether sperms have started appearing. And also we can also do semen analysis more frequently when we are adding HMG to the treatment. And next role is, when do we consider surgical sperm retrieval, and it's usually a TISA. And again, we do some advanced genetics here to see whether there is any other end place problem, like whether the receptor is okay, all those things, high funda things we can do. And so the two roles of the andrologist, especially when we are taking up with the patients for hypo is, one is very important is sperm cryopreservation. So sperm cryopreservation is very important because these treatments are costly. Patient may be willing for a natural pregnancy, they would be going through the treatment, but the moment they start seeing sperms in the ejaculate, they have crossed say 2 years, 2.5 years. At the time they may think that let us go with IVF now. So once the sperms start appearing, there may be a brief situation where sometimes the sperm production may drop also. So it's better to freeze the sperms whenever we see them. And whenever we get sperms by a surgical sperm retrieval, so when 2 to 2.5 years has passed, there is no improvement in the semen parameters, but the testicular volume has improved, the testosterone has improved, we may consider a surgical sperm retrieval, because maybe beyond that the treatment is going to be, it will take time, and we may not be able to reach the final goal where we see sperms in the ejaculate. And when we have done enough therapy and we have seen the sperms, it is also a good idea to freeze the sperms and switch the patient to TRT and let them decide when they plan for the second child whether to use these sperms or go for another round of HCG. So these are the important points which we have to remember as andrologists, so that we can guide the therapy in that particular order. Thank you. So we are now entering into one more difficult topic, which is genetics in male infertility. So when, what and how is what we are going to discuss. Again, as andrologists, we should be able to understand the genetics of male infertility. What are all the tests available? Because many times we get the reports when the patients come to us, they already have the reports with them. And what are the indications for genetic testing? So we should not waste time or money in doing these genetic tests when it is not required. And what are the situations where the newer tests will be useful? So quickly the basics, we all know that genes are responsible for all the bodily functions, and sperm production also has multiple genes. So this diagram is just to show you that at multiple levels there are multiple genes which are involved in sperm production. We do have 200 to 300 plus genes which are implicated in sperm production, maturation, motility, morphology, DNA fragmentation, etc. So it is impossible for us to understand or know each part, each name and all those things. But it is important for us to note that today we have tests which can detect all these things. But whether to use them and what is the presently followed evidence, this is what we have to understand. So we also have to always follow something called a pedigree chart, which we would have done in our UG days. So that's very important to understand what type of genetic problem we are dealing with. And the indications for genetic testing in male infertility is whenever there is a sperm concentration of less than 10 million according to the EAU, or all other guidelines they state less than 5 million, or azoospermia. So these are the two conditions of non-obstructive azoospermia, or less than 5 million count, where we can consider genetics. And whenever we have a congenital bilateral absent vas deferens also, we can consider genetics. So again, as in the morning we discussed about non-obstructive and obstructive, the genetic testing for obstructive and non-obstructive is completely different. So we have to understand the basic difference between the presentation. So we need not do CFTR when a patient has a high FSH. So the distinction is based on the testicular volume, the FSH and the presentation, the different genetic tests will be planned. So again, when we go through these tables, we have multiple names which are written, but we have to know that at least karyotyping and Y chromosome are the most important genetic tests for non-obstructive or severe oligoasthenospermia. And as the sperm defect worsens, so in azoospermia, we have the maximum incidence of genetic defects, and even in normospermia, we may have genetic defects, but they are very less. So what should a urologist know about genetic tests? The indication for the test, what sample it is done. So we sometimes even ask our urology friends, they come and ask us, is the test done on the semen? So we have to know on what sample it is done. What is the turnaround time? So how much time the test takes to be done and report becomes ready? What is the rough cost and whether there is an evidence to do this test and how to interpret this test. So as I told, these are the three main things which we will be asking for in our OPD. So the karyotyping Y chromosome for non-obstructive, and for obstructive it is CFTR gene mutation testing. And for CBAVD, so whenever we mean CFTR and whenever we mean obstructive azoospermia, the role of genetics come only when it is a congenital bilateral absent vas deferens and not for any other obstructive azoospermia which Dr. Arun was talking about, say epididymal obstruction or say midline cyst, etc. There the role of CFTR doesn't come into the picture. It comes only when we have a CBAVD. So 46XY is the karyotype for male, and karyotyping is also a little bit, because this is the most common test we will be ordering. So it is also called as chromosomal blood analysis, or it is also called peripheral blood karyotyping. It's a cytogenetic type of test. It is done on a blood sample, doesn't require fasting, can be done anytime. And it is done through this method where there is a cell culture involved. So it takes at least 2 weeks to 2.5 weeks for the report to come. And the conventional method is a G-band karyotyping. So this is slight information which we have to know, and this is how the karyotype appears. 46XY with there is no translocation or nothing. So the common problems which we can see here is the Klinefelter syndrome, which is the hypergonadotrophic hypogonadism, where the testis volume is less, the FSH is high, and the testosterone may be low or normal. And there are other reciprocal translocations, balanced translocations, etc. We also see one more condition called 46XX, where again it's very rare to find sperms. So going on to the subtypes, say there are many things which will be reported, 15P, 9QH. There are many things where the sperm analysis is normal, but the karyotyping was done because they had a recurrent pregnancy loss. And then the patient comes to us and asks, or we get referrals which ask whether this particular problem may be the reason for recurrent pregnancy loss. So we have to be sure whether this is causing the pregnancy loss or not, or this factor in the chromosome is only a bias, and there is some other factor which is leading to the recurrent pregnancy loss from the male side. These are the things which have to be going on in our mind. So going on to Y chromosome microdeletion. So this is the most important Y chromosome which is responsible for the male phenotype, and it is an acrocentric chromosome where it has a short and a long arm, and there are 3 subregions of the azoospermia factor region on the YQ. So this is what is YCMD, that is Y chromosome microdeletion, and deletion of this region may be in A, B or C, which can lead to various levels of severity of the OATs. So it can be seen in up to 7.5% of oligospermia and up to 10 to 15% of severe oligo or non-obstructive, where the incidence of Y chromosome is more. So whenever we do this sample, it is again anytime it's done on the blood, and the turnaround time is around 2 to 3 weeks. And here we use something called multiplex PCR agarose gel electrophoresis, and we mainly screen for the AZF region, which is region based. So we have specific STS marker, that is sequence stack site markers, which are used for Y chromosome microdeletion assessment. So if these markers in India were not used, then probably this report is not complete. So that also we have to remember whether all the markers of this geographical location are done or not. So AZF-A probably is almost equivalent to Sertoli cell only syndrome, and AZF-C has the maximum chance of sperm retrieval. There may be various combinations, partial AZF-A, partial AZF-B, all those severe various combinations are possible, where the outcomes are also according to that. The main role for AZF is to prognosticate sperm retrieval chance. The second thing is to counsel regarding transmission to the male baby, and also if there is a role for pre-implantation genetic testing. So going on to cystic fibrosis, which is a autosomal recessive disease, which has a wide presentation. So here, as I told, autosomal recessive, if only one partner has either is a carrier or is the patient himself, then probably it's still okay in the offspring. But if both the parents have one carrier, then they are going to get inherited with the disease at least in 50%. So that is the most important thing we have to remember. So the main role of CFTR comes in the picture where there is a bilateral absent vas difference. Unilateral may not be always related to this. Cystic fibrosis is a broad disease, as we all know, but this is one part where only the sperm passage is affected. So earlier we all used to think that only a CFTR delta 508 is enough to be done as a part of CFTR testing. But then came ARC5, where there was 5 important mutations assessed. But now we know that in the male partner, at least we have to do a whole gene sequence of the CFTR, even which is not complete. They see maybe 60 to 70 genes, and that's it at least should be done, so that we don't miss out cystic fibrosis in the male partner. And if we don't do this, or if even the female partner is involved, then we may need to do something called pre-implantation genetic testing. And this is a direct gene analysis test done on the blood, and slightly longer turnaround time of 5 to 6 weeks. Going on to advanced genetics, nowadays again we have to know these things because we are getting exposed to newer things. We have the genomic panel, we have the whole exome sequencing, couple screening in specific conditions, and PGS, which is pre-implantation genetic testing. It has multiple names. So genetic panel is to see whether the sperm defect itself is genetic or non-genetic, and to decide whether we can move on to a donor sperm if it is not correctable, or if there is going to be multiple failure. And if it is at the level of motility and morphology, we can also make out whether this is a genetic problem, and to decide if in a case of varicocele where we have a doubt, or whether in a case of NOA, that is non-obstructive azoospermia with varicocele, whether to go for surgery. These are the conditions where these panels may become effective in the future. And this is all we have genes to assess nowadays: impaired sperm genesis, sperm function, sperm DNA fragmentation, motility. There are so many things for which genetic testing is available now. So these are the common genes which we now pick up in oligospermia, and we also have something called the MMAF, where it is a multiple morphological abnormality. In these conditions, if we get these genes positive, usually the spermatogenesis is okay, only the motility and morphology are not okay. They do well with ICSI actually. So this is a better thing for the patient. So one more thing, what the discussion just happened about the FSH reports, FSH values. So there is some evidence in the last 2 to 3 years which says that there may be polymorphisms in the FSH, because of which maybe a recombinant FSH will work, or there are conditions where the receptor is a problem where recombinant FSH will work. These are the only 2 situations where we are using recombinant FSH. In other conditions, we don't do them. And a slight word about PGT, where we have to, as urologists and andrologists, we have to know about PGT, because PGT is a test which can identify aneuploidy in the embryo. So even if the embryo is grade A, sometimes if they are aneuploid, the implantation may fail. And we have to know that we are dealing with defective sperms whenever we see a patient with oligospermia or azoospermia. So this can induce aneuploidy in the embryo, and that can lead to failures. So if we are able to pick up these things before embryo transfer, then it will be good. That is what we do by trophectoderm biopsy. When the embryo is about to be frozen, we do this biopsy. We can make out whether they are euploid or aneuploid. There are multiple types of PGT. So each one has a particular role. And PGT can reduce the incidence of aneuploidy, and also it increases live birth rates because we are transferring only euploid embryos. And as I told, this is abnormal sperm which we are using. With advancing age, this comes into the picture. There are newer things called genetic microarrays, epigenetics, personalized genetics, which will be possible in the next 10 years. And something called the male infertility knowledge base, which is all coming up for us to get more and more guidance from genetics, and to personalize the treatment for each patient, reduce the failures, and choose donor sperm more wisely when we know that the own sperm is not going to work or will cause problems. Thank you.
Fresh and
This only. So male infertility is increasing, and we all know that is a big social stigma in our society. So that's why majority of the men won't come to the gynecologic clinics or the infertility setups to avoid the stigma. And we have also discussed that the semen parameters are dropping over the period of 70 years. WHO has seen a lot of decrease in the both sperm, all the sperm parameters, including the concentration and going up to morphology. And we know that 8% of men of reproductive age group seek medical assistance for fertility-related problems. And this has been discussed already. There are various causes of male infertility, and all these could imply on the sperm parameters, both at the level of concentration, motility, and morphology. And here, these are the common causes of male infertility. And the most common cause is varicocele. And idiopathic comes next because of our ignorance regarding the other causes which are leading to these problems. So today I will be talking about the actual optimization of male infertility at our fertility centers when they come to us. So as mentioned by my predecessors, that we have to evaluate them first, identify the problem, and improve on it. So the most, when you call severe OATS, severe oligospermia could be less sperm concentration less than 1 million, and it also includes cryptozoospermia and azoospermia as well. So when we talk about ART, it could be IUI, IVF, ICSI, PICSI, the recent advances, IMSI, and MOMSI. When you talk about IUI and IVF, and we are talking about severe OATS, definitely IUI and IVF doesn't have a place in their treatment. ICSI is the only way. And my next speaker will talk about PICSI and IMSI and how we are going to help these patients with severe OATS. So semen analysis, endocrine evaluation is very important in identifying the exact cause why these males are having these problems. And we also come across this test called DFI, which is taking its value in the evaluation of the male infertile males. And genetic testing has already been discussed, and I'm not going into the endocrines because Dr. Mukka has already elaborated about this. in his talk, and karyotyping is also important just to identify the reason why the sperm parameters are very low. And once we identify the problem, then we have to go on for the treatment. So before I go on to the treatment, I want to take few minutes on the DFI. I think this has not been covered so far, and it's gaining importance day by day. Previously, we used to say it's only for research purposes, but now we are going up to the stage that should we identify the DFI of the patient who comes to the fertility clinic, including all the patients, all the male patients with some problems. So if you look at the DFI of these fertile men and non-infertile men, you can see in men with normal semen parameters, if they have infertility, there is a risk of high DFI in these patients. In the same way, abnormal semen parameters, definitely a high DFI is expected. So what is the reason for high DFI? When you talk about high DFI, we should talk about oxidative stress and reactive oxygen species. And the sperm is highly vulnerable to this reactive oxygen species. And how these reactive oxygen species are produced is either because of the abnormalities in the sperm where they can't correct the reactive oxygen species, either in the form of increased production or decreased exclusion of these products. So the main causes are age beyond 35. Previously, it used to be, we used to think that men's age is not important, but definitely we all agree now that either in terms of reactive oxygen species or in terms of genetic problems or chromosome abnormalities in the sperm, men with with age above 35, the offspring has multiple problems, even up to the point to say that they might have chromosome abnormalities in the babies also. Previously, we used to think Down syndrome, the main cause is the age of the egg, but age of the sperm is also important, and it also can cause chromosome abnormalities in the offspring. And environmental factors like cell phone radiation, ultraviolet light, and lifestyle factors like obesity, diabetes, all these can increase the DFI in the sperm, which can eventually affect in the time to conception and also in the miscarriages. So men with high DFI in their sperm have shown that the time to pregnancy is more, and also miscarriage rate is more. So when do you do the test? If you want to do only to certain category of men, in unexplained infertility, recurrent pregnancy loss, advanced maternal age, clinical varicocele grade 2 and grade 3, and if you want to decide on varicocelectomy, even in grade 1, if the sperm parameters are abnormal. And post-chemo and radiotherapy, testicular trauma, severe infection. When you say severe infection, definitely if you do while the patient is having infection, there is high risk that the DFI will be high. So if you want to do a DFI test which is expensive, I would recommend that you treat the infection first. After 2 months, maybe you can subject the patient for DFI test. And we also do in patients with failed IUI, IVF, multiple failures, and also in recurrent pregnancy loss. We also notice that poor embryo quality after IVF or ICSI also could be contributed by high DFI. So how do we treat these patients? Definitely, our first go-to will be the urologist. So we'll send them to urologist to find out what the cause is, and if we have to do it ourselves, first we'll embark onto the lifestyle changes, mainly because we have seen from our previous talks that obesity can influence, and also obesity can also cause high DFI. So this would be the first point, if the BMI of the patient is high or not. Previously, we never used to bother about the BMI of the males, but slowly we are gathering evidence to say that it is also important along with the age of the males. And diabetes, thyroid, as we have gathered from the previous speakers, is also very important. So if you find a male with severe OATS, we just have to find out whether there is any thyroid problem, diabetes, or any other hormone problems which are causing this. So once we correct only, we should go forward. And then other medical treatments or other drugs that they are going through should also be taken into consideration, because you can see this slide, though it's very busy, it can show that it can impact the sperm production. So coming to the medical treatment, we already had a talk on medical treatment. So antioxidants, HCG, HMG, FSH, all these have been covered, but prolactin treatment is also important, and systemic corticosteroids, can also help in certain ways. Gonadotrophins, already we have heard about this. And what is the role of gonadotrophins in men with normal sperm count? That is also something which is coming up recently. I think some of the urologists have started already. I see prescriptions from Dr. Rahul using it, but we should gain more evidence regarding this. And definitely, I'm one of the proponents to go for culture test of the sperm, especially if the motility is less. I have seen a lot of patients where the motility is less, and if they had infection, treatment immediately with antibiotics for 14 days or prolonged treatment have helped them conceive naturally also. That is very surprising. So I would suggest that any male with severe oligoacinotereto should be subjected to culture, semen culture, before going on to any ART treatment. And retrograde ejaculation, especially in diabetes patients, we can use either medical management to avoid this retrograde ejaculation or urinary sperm retrieval. If the sperm count is good from the sperm retrieved from the urine, we can even go for IUI. And if the sperm count is not good, we go for IVF or ICSI. And antioxidants, especially in patients where there are risk factors like smoking, alcohol use, or obesity, antioxidants definitely have seen some role, but still strong evidence is needed. And from the Cochrane database in the meta-analysis in 2019, though there is low quality evidence, clinical pregnancy rates have increased, and evidence of increased risk of miscarriage has come down. Coming to the surgical side of the treatment in OATS, varicocelectomy. Sometimes there is a lot of controversy between urologists and fertility specialists whether we should go for varicocelectomy or not. But the guidelines say that in subclinical or grade 1 varicocele, if there is no problem in terms of sperm analysis or DFI, then no treatment is necessary. But in grade 2 or grade 3 varicocele, or patients who are asymptomatic but with abnormal semen parameters or high DFI, guidelines suggest that varicocelectomy is necessary. So coming to the recommendations for the repair, where there is palpable varicocele, definitely varicocelectomy is important, and the couple has documented infertility and they are not able to conceive. Just 2 more minutes, please. The woman has normal fertility potential, and if we correct the male factor, then if they have the capacity to conceive naturally, then varicocele operation is necessary. And if the male has 2 or more abnormal parameters. The effect we see in terms of pregnancy is increase in size of testis, increase in sperm parameters, decreased pain, and spontaneous pregnancy rates, and also improvement in pregnancy after ART. Even though they are going through ART or IVF or ICSI, the pregnancy rates are better, miscarriage rates are less in men who had varicocelectomy and then underwent ICSI or IVF. So these are some of the studies and meta-analysis which have confirmed that. So other ways of identifying best sperm so that we can have better embryos are being investigated, and one of it is MAX, where we try to sort out the sperm and get the best sperm out. Still, the strength of evidence supporting this is very less. So, and in OATS, severe OATS, the other question we have always is whether should we go for ejaculate sample or a testicular extraction. Again, we don't have strong conclusion to say whether testicular extraction will give us better embryos or the ejaculate sample. But my personal experience is if the sperm count is less but still available even a few sperm, I would go directly with the sperm rather than the T-cell. And the other important thing which we usually do in our clinic is to get a sample where the ejaculatory time or abstinence time is very less, because when the abstinence time is very less, the motility of the sample will be better because it is a fresh sample. So that is one important point which helped us to get a better embryos in patients with severe OATS. And again, we have to concentrate on what we are doing, how we are doing the wash in our clinics. And addition of theophylline and pentoxifylline has also been tried when there is no motility, especially in patients with 100% necrospermia. So these are some of the techniques which are being practiced, though we don't have evidence. We don't do this IMSI, but some studies have shown that it is beneficial in patients to identify the best, morphologically best sperm before ICSI. So to conclude, ICSI is the only treatment for severe OATS. No difference between ejaculate and TISA samples in severe OATS patients. Fresh and frozen TISA doesn't have any difference in the outcomes of IVF patients. And processing techniques and experience of the operator is very important. There are various laboratory methods which can enhance the success rates in terms of pregnancy or live birth rates in these patients. Thank you so much.
So where there is a scope, there is even an embryologist around. So I bring a different perspective from the lab. Dr. Rahul is there smiling. See, I'm the odd man out of the lot who comes from the lab. My talk will not be as, as this thing as everybody would, but I'll try my level best to put the lab's perspective in this CME. See, advanced sperm selection methods. So, since 1980, before I was born, the WHO has been giving all these laboratory manuals, not just for the examination, but also for the processing of the human semen. Though it may be any type of the semen sample in any condition, so this is the holy book for all of us who are practicing embryology, including the androtechs and everybody working in the lab. So what actually WHO says? Any ideal sperm separation technique should recover a highly functional sperm population that preserves DNA and does not induce dysfunction through the production of ROS by sperm and leukocytes. So our whole approach at the time of handling a semen sample in the lab is to handle it so carefully so that we don't induce or we don't let that induce the ROS, which is definitely has its own effect on the ultimate embryo development. So the routine approaches, as we all know, for the semen preparation at the laboratory are the swim-up technique, very simple basic thing when the semen parameters are normal, and there is a density gradient where we see the high amount of debris samples and high amount of abnormal spermatozoa around. So definitely DG has its own upper hand over this regular swim-up technique, and if the sample is too much compromised, we definitely go for a basic wash. So it may be any preparation technique. As an embryologist, we know how to get that one sperm for one oocyte. So our equation is 1:1 always. So definitely these techniques are based on the recovery of the sperm population with a high motility capacity. So the centrifugation which we use, the centrifugal force, what we use during these procedures definitely will have an impact on the DNA integrity, which we also agree. But to get a population, that is a protocol. So now what I can do to avoid the deleterious effects of this centrifugal force. So there are other sperm selection methods or some sperm preparation methods as well. I would like to bring to the table today. So basically the indications are, once the ICSI or once the IVF is done, on a day 5, we expect a blastocyst. So any low blast conversion rate is again, the deprived embryo quality, definitely there is a problem with the sperm which, as an embryologist, I selected on the day of an ICSI. Out of the cohort, see, I get millions. As I said, my equation is 1:1. So one oocyte, one spermatozoa. So that one spermatozoa which we are going to say, see, I used to say to all my juniors that we don't have the luxury to choose the quality of a oocyte, but we definitely have to choose the best sperm for that. so that the whole scenario will get changed. So any wrong step while selecting a single spermatozoa during the ICSI, the whole game is over. So definitely when there is a borderline sperm count with low fertilization with ICSI and repeated embryo transfers without implantations and repeated miscarriages and early pregnancy loss and reduced sperm morphology and motility and low quality cryopreserved sperm. So all these are indications where definitely we prefer to go for an advanced sperm selection method instead of going for a routine semen selections. So now I'll bring 4 methods of sperm selection at the time of ICSI, what we prefer from a routine. So definitely IMSI, which is intracytoplasmic morphologically selected sperm injection, and a physiological selection of sperms for ICSI, which is PICSI, what we generally call it as, and definitely magnetic activated cell sorting technique, which helps us in removing the apoptotic spermatozoa, and definitely the microfluidics, which is now the we love microfluidics, especially through because it involves very less labor in that. So bringing to the this thing, the intracytoplasmic sperm selection. So as the name itself suggests, is morphologically selected, and the morphology, what WHO says. WHO says, as far as the acrosome region should contain no large vacuoles and not more than 2 small vacuoles, which should not occupy more than 1/5 of the sperm's head. So this is what the normal appearance of a head should be as per WHO. So that's what we do. We see. See, the sperm has been enlarged to look into whether there is a vacuoles. Here we can see different kinds of head abnormalities are there, and depending on that, we definitely class the spermatozoa. A spermatozoa with no vacuoles or single small vacuole, they are all grouped into class 1, and then we have class 2 where we could find few more vacuoles, and a third class 3, which has a bigger vacuoles which are there. So definitely class 2, class 3 will definitely impair the embryo quality, but class 1 definitely, fingers crossed. So the difference, ICSI, this is a normal ICSI what we see at 300x, and definitely IMSI help us in elaborating, magnifying the spermatozoa to a level where every single this thing abnormality can be visualized. So this is definitely we get a separate objective, IMSI objective, which has been used along with your ICSI machine. So there is no need of an additional this thing for that. So and the routine ICSI, sperm selection, and sperm injection, incubation, everything is normal. Only at this time of sperm selection when it is magnified and then it is checked in the IMSI. Now coming to physiological sperm selection, or PICSI, what we call. So definitely here the important stage of any maturation of a spermatozoa is the development of CD44 receptor for hyaluronan, and present in the granulosa layer of the cumulus oocyte complex, and as well as the receptors for the zona pellucida binding. It may be ZP1, 2, 3, which are fundamental for the fertilization process in a normal day. So now sperms considered immature when there is a deficiency in these 2 binding sites. So this is a PICSI dish, what we use for the physiology. So these are 3 drops which are with the hyaluronan. So first we have to hydrate them, and then we add a semen sample to that, so that the sperms will go and bind to that. So it shows, the binding shows like this. Now, whatever the talent technique, whatever you call, the embryologist has to get the sperms extracted from those binding sites and then use them, again reselect them as per his or her convenience, and then select. So all the sperms which are bound to this hyaluronan drops are considered mature, and we expect them to give a good result in this thing. So as I said again, so this is the ICSI plate, which is how it has been prepared again. Now coming to MAX. MAX is again this thing under normal physiological condition, any apoptotic cell will externalize phosphatidylserine residues on the plasma membrane and can be recognized and efficiently eliminated in the female genital tract by the phagocytes. But what happens in a in vitro situation? So definitely we have to do something to remove those the sperms from the cohort which are apoptotic and which definitely is not going to help you out at the time for the proper embryo development or further on. So phosphatidylserine, a molecule with a high affinity for annexin 5, used as a apoptotic sperm marker, which is conjugated with magnetic microspheres, which are exposed to the magnetic field and can separate the apoptotic sperm from the non-apoptotic sperm. So the major role of the max separation device is to separate the apoptotic from the non-apoptotic sperm. So this is what, and the method of sperm selection is usually identify and positively eliminate the apoptotic sperms. So now, the advantages, it definitely reduces the number of the apoptotic sperm, as I am saying, thus improving the overall embryo quality and pregnancy rates, which we like always. Also reduces the proportion of sperm with fragmented DNA in the ejaculate before using it for the ART procedures. So, so coming to the microfluidics, which we have, I have 2-3 minutes left. So I'll be quick with this microfluidics. When we talk about microfluidics, it can help filter the sperms that are more likely to carry DNA damage from the normal forms. So the technique still works with the principle that the sperms with lower motility have higher DNA damage and the motile sperms are likely to carry DNA damage. So this is an example of a microfluidic device where the semen and media are kept in 2 different wells, and the competitor sperms, which are motile sperms, will travel into a different chamber where they can be directly corrected, and there is no centrifugation involved in this thing, so there is no question of producing an ROS. So this is one of the microfluidic device, and which has an inlet for media as well as inlet for semen, and there is a membrane there where the sperms will travel through and come to a come up, and then the embryologist will collect. It needs only incubation for almost 20 to 30 minutes, and the competitive sperms can be easily collected. And there are 3 types of sorting devices: those which isolate only motile sperms, and that isolate sperms without relying on the sperm movement, and those that monitor and choose individual sperms. So most frequently used for any ART procedure is a type 1 microfluidic device, which isolates only motile spermatozoa. So whether, here are the 3 different this thing, which helps us in separating that, because for ICSI, I need very low volume of good quality sperm. I don't need much. But if it is for an IUI, I require definitely a few million cells, more than 10 millions per ml, so that it can give a good chance for the fertilization and the pregnancy. So again, while some of the methods can choose sufficient sperm cell for infertility, and the vast majority select from a smaller and purer subpopulation which is suitable for IVF. So microfluidics is then the upcoming, of course it came into the practice and we love it for that. And to conclude, any ideal sperm preparation technique should recover that high functional sperm population that preserves DNA and does not include and induce dysfunction through the production of ROS. Thank you.
At the outset, I'd like to thank Sir, Surya Prakash Sir and Bhupati Sir for giving me this opportunity. The talk is testicular biopsy interpretation in male infertility. Before going to the exact biopsy findings, we'll just see what is the normal histology of the testes, or the structure of the functioning unit of the testes. So it's a male gonad which is measuring around 4 by 3 by 2.5 centimeter. Weight is around 20 grams. Right side is more heavier than the left. And we all know that it has 3 layers, that is tunica vaginalis, albuginea and vasculosa. Each testis is divided into 250 lobules, and each lobule will be having 4 seminiferous tubules along with the connective tissue and the Leydig cells. Now the seminiferous tubule is the basic structure or the functional unit of the testis in which this spermatogenesis occurs. So each seminiferous tubules will be having the spermatogonia or the germ cell lining epithelium, which will be ranging from spermatogonia, primary spermatocytes, secondary spermatocytes, the spermatids and the sperm, along with the Sertoli cells, and in the interstitium we will be having the Leydig cells, lymphatics and the blood vessels. So the normal maturation of spermatogenesis, it takes around 70 days, and the final maturation occurs in the epididymis. So this is just a schematic diagram to show how the spermatogenesis occurs. From the spermatogonia type A, we get type B, then it goes to primary spermatocytes, then they migrate to the adluminal compartment. First meiotic division occurs, then we get the secondary spermatocytes. The second meiotic division occurs, we get the spermatids, and then finally the spermatids transforms into the spermatozoa or the adult sperm. So this is the H&E section of the seminiferous tubules. This is one seminiferous tubules. Here we can see the peripheral lining. These are all the spermatogonia, and these have the spermian kind of nuclei, what is classically described. The in-between cells are the Sertoli cells. And then as the spermatogenesis occurs, the spermatogonia forms the primary spermatocytes. Now the secondary spermatocytes are not seen in all the tubules, so it will be very difficult for us to capture the secondary spermatocytes at a particular field in the microscope. So in this picture we can't see it, and then straight away we are seeing the spermatids and then the final mature sperms. Now these are these peripheral lining of the seminiferous tubules, which are formed by the smooth muscle layers, and in between this seminiferous tubules we will have the interstitium where the Leydig cells will be seen. Now the causes of infertility, as you all know, can be pretesticular, testicular and the post-testicular. The pretesticular are basically something which is occurring before the testes. That is, it is related with the hypothalamus and the pituitary axis. So it can range from all the abnormal hormonal levels like hypogonadism or estrogen excess or androgen excess. We can have hyperprolactinemia because of prolactinomas. There are other causes also like diabetes, hypo and hypothyroidism. In the testicular, it is basically the causes which are related to the spermatogenesis, that is the testis itself. So it can range from the infections like mumps, or it can go up to malignancy also. Certain, even the cryptotid testis can also have lead to abnormal spermatogenesis. And the post-testicular, as you all know, the common cause is the spermatogenesis is normal, but the transport is at stake, so the excretion doesn't happen, and we will get azoospermia. Now, whenever a case of infertility is there, as you all know, we take a detailed history, the general examination, followed by routine labs, semen analysis, hormone studies, and finally the testicular biopsy. In the history, we need to know the whether there was history of any viremia in the recent onset, because mumps, again, as I told, is a cause of infertility. There can be, we have to take history of surgery in the genital area, whether there was any history of chemotherapy, radiation, trauma, occupational history, etc. Now, semen analysis is the first test which occurs in the case of infertility of men. So first, how to collect the sample, as I think already been discussed. There should be abstinence for at least 2 days. Now WHO has come up with new guidelines, the new reporting system 2021, where the normal ranges are changed. So abstinence of at least 2 days is required, not less than 7 days, not more than 7 days. The sample has to be collected and transported immediately to the lab, and the transport time should not be more than 30 minutes, because if the time is delayed, again the morphology will be affected or the motility will be affected. Whatever sample comes, we have to finish the examination within 1 hour of collection. So the normal volume as per the 2021 guidelines is 1.4 ml with a count of more than 16 million. Motility of more or equal to 42% is considered as normal. And on morphology, we do certain stains and then comment on the morphology of the head, acrosome, midpiece and the tail. We also do the chemical analysis like fructose test to see whether there is obstruction or not. So with the help of semen analysis, we can come to some classification of infertility, like it can be an absent ejaculation, there can be azoospermia along with the causes. We can have oligospermia, asthenospermia, where motility is reduced, or it can be teratospermia, like the count, everything is normal, but the morphology is not normal. So after the semen analysis, the next tool for investigation would be the hormone status. So LH, FSH and prolactin are the routine hormones which need to be tested, so that at least a provisional cause comes to our mind, like what could be the etiology for azoospermia. Then the testicular biopsy. Now this is was started in 1960, first time by CME. So what are the indications of testicular biopsy? The absolute indication says azoospermia. Now, clinically, if you all feel that the FSH is raised to 3 times the normal, so there is no indication for you all to do a testicular biopsy because already you all know the cause. If on clinical grounds you can establish that obstruction is a cause for azoospermia, then again testicular biopsy is not indicated. But if you want to differentiate between obstructive versus non-obstructive azoospermia, there lies the role of testicular biopsy. So the absolute indications are azoospermia, oligospermia, teratospermia, and if there are any atypical cells in the ejaculate. And the relative causes followed by would be varicocele, cryptorchidism, or chronic infection and hypogonadism. In the literature, certain cases of vasculitis are also described as an indication for testicular biopsy. We can also do it to assess the viability in case of torsion. Especially in kids with ALL, after chemotherapy, it can be done to see whether there are any viable tumor cells or infiltration of the testes by the tumor cells. And cases which are at high risk of malignancy, the testicular biopsy is indicated to find out whether there are any malignant germ cells, especially cryptorchid testis, or there is a contralateral germ cell tumor, or on ultrasound there is presence of microlithiasis, because these are the predisposing factors for testicular germ cell tumors. So how do we obtain the testicular biopsy? It can be an open surgical biopsy or it can be a percutaneous testicular biopsy. These days even FNACs are attempted. FNACs also give a good information in comparison with the testicular biopsy. Like it can tell you whether we are able to see the mature sperms or not. But the only drawback with FNAC will be we won't be able to establish or look at or comment on the architectural morphology of the seminiferous tubules, the interstitial cells, or the matrix components. Those things would not be appreciated on the FNAC. So for that we need to go ahead with the biopsy. Now, as you all know, for all histopathology samples, the basic fixative is the formalin. But here, formalin is contraindicated in testicular biopsy because formalin leads to shrinkage of the tubules and thereby it gives a false morphological appearances of the seminiferous tubules or the spermatogonia. So the preferred fixative would be Boyne's fluid, Zenker's or Steve's. In our lab, we are using the Boyne's fluid. Now, how do we comment on the adequacy of biopsy? While taking the biopsy, we should make sure that the aggregate of the tissue is approximately around 3 by 3 by 3 mm. Immediately, the tissue has to be put into the Boyne's fluid so that there is no autolysis or there is no crushing artifacts. Now, when it comes to the lab, after processing of the tissue, we usually take around 5 sections, which are each section is around 4 to 5 micron thick. And then we look at the histology by staining with a routine stain, that is a hematoxylin and EOC. Now for us to call as an adequate biopsy, we usually see around 3 to 5 lobules per septate or 100 seminiferous tubules. So the routine stains, what we do in our lab is the hematoxylin and eosin. We can also add the special stains based on the what initial assessment or initial findings we think about, like special stains like tricho, von Giesens or elastic fibers to look at the basement membrane of the seminiferous tubule, and also the PAS stain. If there is a requirement or indication of electron microscopy, then the tissue has to be collected in 4% glutaraldehyde because Boyne's and formalin is not the absolute fixative or the media for doing EM. When we are looking at the slide, what do we see? We look at the overall morphology of the tissue, then we look at the size and structure of the seminiferous tubules. Then after looking at that, we look at the interstitium of the biopsy. We look at the spermatogenesis, whether it's happening normal or not. And then there are certain cases where quantitative assessment is done, but we do not practice that. Now coming to the histology. In the histological patterns of infertile male, these are the common patterns which are described and on which our report comes. Like it can be a normal histology, or it can be an immature testis-like morphology, or there can be sloughing of immature cells, hypospermatogenesis, maturation arrest, Sertoli cell only syndrome, or peritubular sclerosis and tubular hyalinization. So when the histology is normal, I mean that the spermatogenesis is happening normally. So the common cause for this would be the ductal obstruction. So if the report comes as normal spermatogenesis, the cause would be ductal obstruction and the corresponding management can be done. If there is an immature testis, what do I mean by immature testis? Is something, a testis morphology is like a prepubertal testis. So those morphology can also be seen in an adult. Here these the seminiferous tubules will be almost same like an adult, but only thing is the spermatogonia will be less in number and we cannot see the spermatogenesis. Now, the causes of immature can be abnormalities of hypothalamic pituitary function or pubertal androgen excess. Now, this is a photomicrograph where we can see that these are all seminiferous tubules. In the normal spermatogenesis, we will have all this normal round structures, but here we can see they are haphazardly arranged. There is lot of Leydig cells in the interstitium. Here we are seeing the basal lining by spermatogonia, but we are not seeing any mature sperms inside the lumen. The lumen is all empty. We are only seeing 1 or 2 linings of spermatogonia. Now the next pattern can be sloughing of immature cells. Here the tubules will be normal, but all these spermatogonia which are there, because of the underlying etiological factors, they slough off and come into the lumen, and which can lead to azoospermia or oligospermia. Here the maturation will be proper, but because these sperms are dying or the maturation is not happening, the center will be full of all these sloughed off cells. So the causes of sloughing can be varicocele or prior vasectomy. It can happen in moms or it can be idiopathic. The next common pattern what we see is hypospermatogenesis. It is also called as germinal cell hypoplasia. Here the morphology is normal, like seminiferous tubules will be of normal diameter. We will have the spermatogonia. The spermatogenesis will occur, but only thing, the number or the maturation will be very less. So these are the causes of hypospermatogenesis. Here we can see that this is the seminiferous tubules. See, so many lining of spermatogonia are there. We are seeing the spermatids, and sperms can be seen, but we expect a more number of sperms as compared to this. So this is hypospermatogenesis. And the next pattern what we see is the spermatogenic maturation arrest. So this is the most prevalent cause for infertility. Here the spermatogenesis beyond the primary spermatocyte level is arrested. So we will not get the spermatids or the mature sperms in the biopsy. So here the diameter again of the tubules will be normal, Sertoli cells will be normal, the basement membrane will be normal, but patient will be having oligospermia and azoospermia because the maturation is not happening. The hormone levels will be normal. These are the causes for this spermatogenic maturation arrest. So this is the H&E slide where we can see that the tubules are round, there is no thickening of basement membrane, the peripheral lining is all by spermatogonia, and we can see these Sertoli cells in the lumen, but there are no spermatids or the sperms. So this is a maturation arrest. Now 11 to 20% of the testicular biopsies can show features of Sertoli cell only syndrome, which is also called as a germ cell aplasia. What do I mean by this is there are no germ cells in this, it is all having only Sertoli cells. So this is the biopsy which is showing only Sertoli cells. See, you can see only Sertoli cells but no spermatogonia. So what we call is windswept appearance in the histology. I'll not go to this. Role of biopsy in carcinoma is still controversial, but it can be done as I already suggested. This is just to summarize all the patterns. This is Sertoli cell only syndrome. Here you can see no spermatogonia. Here we are seeing spermatogonia but no spermatogenesis. Here we are seeing hypospermatogenesis, and this is how the normal spermatogenesis looks. So what are the implications of this histological patterns is it helps in the sperm retrieval. If it is normal, then we know that the cause is obstruction. The obstruction can be relieved. It has excellent reproductive prognosis. If it is hypospermatogenesis, then in a study of 39 patients, the sperm retrieval was successful in 79% of the men. If there is maturation arrest, we need to know whether it is primary maturation arrest or late maturation arrest, because again the sperm retrieval percentage will vary. In Sertoli cell, again in a study of 373 patients, they were able to do successful IVF in around 50% of the cases. But the seminiferous tubule hyalinization is worst to have because the fibrosis will not allow the germinal epithelium to function properly. So this is just an algorithm where it shows how we are looking at the slide. On low microscopy, we see that whether it is testes, how is the seminiferous tubules, what is the interstitium, and then we go on to high part to see what is the type of germinal epithelium, whether it is homogeneous or non-homogeneous. If it is homogeneous, then we see whether the tubules are hyalinized or acellular. If the tubules are hyalinized, then straight away we can call it as seminiferous tubule hyalinization. If it is not there, then we see whether there are tubules are with absent germ cells or retained Sertoli cells. If absent germ cells, then it is Sertoli cell syndrome. If the germ cells are present, then we have to see whether it is mature sperms are present or absent. If it is absent, then it can be a maturation arrest. If it is present, then we have to see whether they are present in normal number or they are present in abnormal number. If in less numbers, then it can be hypospermatogenesis. If it is normal, then it can be normal spermatogenesis. In the similar way, if homogeneous pattern is not seen, then we have to see whether the tubules are having hyaline sclerosis is uniform or non-uniform. If it is non-uniform, it can be with aging. If it is uniform, then we have to see whether there is hyaline sclerosis, which can, and with the normal spermatogenesis, which can be a mixed type hypospermatogenesis. Or if there are any hyperchromatic angulated nuclei, we have to rule out crushing artifacts. If the crushing artifacts are ruled out, then these abnormal cells can be considered as germ cell neoplasia.
Here we have a 30-year-old male, wife is 26 years aged, married last 2 years, sexually active, trying for pregnancy for the last 8 months. No comorbidity, no addictions, whatever Bhupati has said, all the sexual history points, no lubricants, no comorbidity, no douching, and no significant medical surgical past history. Wife evaluation is normal. Raghavendra, would you evaluate this couple? You're not there first, right? Okay, I'll start with Karthikeyan. Would you evaluate this couple? Okay, I'll keep this slide for you. You can answer. Would you evaluate this couple?
So only they have tried for pregnancy for 8 months. So all other things are okay. So there are two ways of looking at it. One is we call them after 4 months, or if they are anxious, then maybe we can do the basic evaluation. So basic evaluation specifically for the female, we can put them through a gynecologist or reproductive.
Wife has been evaluated normal. Now we are talking about male factor.
Yeah. So then for the male, as I told, maybe for an anxious couple we can do the semen analysis. Only semen analysis will do, but the basic physical examination is very important.
So otherwise you may want to wait for 4 months. So all of you agree? Yeah.
No, I'll slightly disagree. The first evaluation, they have only tried for pregnancy 8 months. I am not dogmatic about the 12 months. You can do it in 6 months or 8 months, depending on their problems.
No, what do the guidelines say?
Why I am telling? See, agreed. But we have to look at the patient, customize. Because I will tell you an example which we commonly face. A 30-year-old male wife, 26 years, the husband will be in Gulf, or they may be planning to go for a job overseas. So you cannot say that you have to wait for 4 months, then only I will start evaluating. So in many patients, they may need an evaluation earlier. So first of all, you have to evaluate the male partner and see. Never be dogmatic about this 8 months. Definitely, we won't do anything very actively, or any surgical intervention may not be there, but we have to evaluate and counsel them.
So now the new trend is even people are coming for premarital checkup, premarital fertility checkup.
No, that we are not doing.
Even before.
We don't go into the premarital.
But so those are special situations. When patient.
Those are special situations. Agree. So in general, what guidelines say is wait for 1 year. There are some instances where you start evaluating.
No, in that there is one more point we have to be very, very clear. The one year they are mentioning, that is with active sexual contact without any protection, because most of the couples for the first 1 or 2 months there won't be any contact. There will be contact, but there won't be any real contact, because there will be lot of problems. We have seen so many couples, they have start contacting after 2 or 3 months.
If the wife has got advanced age, would you start evaluating earlier? Suppose the wife is 30,
definitely,
33, 34.
definitely. That is one indication you have to start early.
So the situation when we evaluate early, sir, if there are already family history of infertility, wife is more than 35 years, or any features suggestive of endocrinopathy, or if male person is having any archaeopexy or torsion testis before. So these are all the situations where we don't wait for 1 year. Even if there is a history of mumps arthritis in the childhood also, those are the situations we can go for evaluation without waiting for another 1 year.
Okay. So would you like to evaluate both the partners when they come for evaluation? I think agree. We should evaluate both the partners.
Yeah, this is what everyone should understand is very important. So whenever male or the female whoever is going to the respective doctors, it is a simultaneous evaluation to save the biological time of the wife. Because females will come with certain number of eggs over a period of time, drastically it is going down after 30s. So it is a simultaneous evaluation. It is not after complete evaluation of the female you can start male evaluation.
Karthik, would you like to ask anything else in the history apart from what I have told in the first slide? when you think that it's the right time to evaluate the couple?
Yes, so that's what the fact. In this patient, 8 months, we all want to know history of childhood mums or any surgeries like orthopexy. The factors where we need to do early evaluation. Those factors I would like to elicit in the history, sir, so that I can decide whether I will start evaluation at 8 months or whatever, 6 months at the earliest. Those are the factors I would want to know in the history.
I think Dr. Bhupati has already pointed out in his talk about things. So the guideline says investigate both partners simultaneously. That's strong recommendation. And infertility should be evaluated at 6 months. This I think we have discussed. If the wife is more than 35 years age. So these are all the questions you uncover. Even if the patient doesn't come, you ask leading questions about their lifestyle, sexual history, family history, congenital or acquired urogenital abnormalities, any history of radiation or chemotherapy, malignancies, infections, varicocele. Sometimes patient comes with a history of saying that they've got varicocele, endocrine abnormalities, genetic anomalies, and past surgery. So all these things you have to ask in the history.
So shall I bring in a practical point?
Yeah.
We all say that theory we have to simultaneously evaluate the patient. Is it really happening in our place? No. Because the infertility will be first reported to a gynecologist and they will be seeing the patient. At that time, they will be finding it difficult to even find a urologist because there may not be a urologist there. They will be sending a reference and this fellow may not go. So this is actually what is happening in our real situation, even though we are telling about guidelines.
That can be managed. I think you can tell, gynecologists can refer always the patient.
Yeah, they can refer, but...
Usually they refer when they find that wife evaluation is normal.
No, I think you can ask anybody. It is not happening. Either the gynecologist is not referring or they are not reporting.
Most of the times, the initial part of male evaluation is done by them only.
Then
they will...
Sir, it is because we are low in number. We should increase our number.
Because of Venos's statement only.
Sir, actually it's the other way, sir. 70% of male patients are seen by gynecologists in the beginning.
Because wife is evaluated. In our society, the blame first comes on the wife. So wife is evaluated. If they find that wife is normal, then they usually put the blame on the male.
Sir, actually the thing is, even with the gynecologist, the male won't come. That is a primary problem first. And most of the times in the periphery, the wife gets treated for 6 months or even more than 5 years till the male gets evaluated.
Yes.
So the problem is like the social problem.
Yes.
The male doesn't approach for a treatment. Yeah, even for semen analysis.
So this is exactly why I brought in that point. We have to, when we discuss, we want to really know what is happening in the practicing field and what are the problems with the gynecologist facing and what are the problems we are facing. We are telling that we are not getting patients. It is primarily due to the patient itself. Secondly, they just like Raghavendra said, there is not enough number of andrologists who can manage all the infertility hospitals. They will be finding it difficult to send from their hospital to a different hospital.
So the problem is with us. More number of, you should produce more number of andrologists. Okay.
And one more.
Mainly the male not getting investigated. That is the primary problem.
Okay.
After getting
Go to gynecology OPD and ask them to show the husband.
One more important.
Okay. As when you examine, Karthikeyan.
One more point here is we saw that everything is normal. So it may be important to ask once more whether their sexual history is okay and whether they're able to perform the penetrative intercourse. Maybe from the gynecologist side, sometimes we get a patient who comes with history suggestive of unconsummated marriage. So that point also is important here because everything else is normal. Young couple have already tried for 8 months. Maybe their everything is okay, but they're not able to do the penetrative sex properly.
Oh, that's entirely different than we are not talking about.
Yeah, the
sexual history is normal. Here sexual
history is normal. Even they may be thinking so that everything is normal.
Okay.
So that point
they have
also.
No idea about penetrative intercourse.
In this case, if the semen analysis is normal, we have to again go back. That also we have to keep in mind.
Karthikeyan has bring in a very, very great point.
Very practical point.
That is what is happening. When a patient lands into gynac, they will be asking everything is fine. Are you having sex? They will say yes. And they can see this patient has come to as a patient with the 12 months or 16 months of continuous intercourse with unprotected and no kids. Before suddenly jumping into your investigations, it is always better send all the males to the
So we have to go in detail into the sexual history, ask for a penetrative intercourse with proper deposition of semen in the vagina. So Karthikeyan, what do you look for when the patient comes to you? Examination, what do you look for? Male factor.
So for fertility, we measure the usual things, the androgenization, the build of the patient is seen. And then more importantly, the penile length, is there any curvature, is there anything which is making the penetrative intercourse difficult? Sometimes tight phimosis causing pain. And then examining the testicular size.
How do you assess testicular size? In your clinic, I'm asking you, how do you assess testicular size in your practice?
Because we have an andrology unit, we have a Prader's orchidometer, based on which we actually correlate the beats and we give the testicular size. Similarly, VAS, every patient we have to examine whether the VAS is present or not. And for epididymis, we see whether it is turgid or flaccid. And in standing position with straining, we assess for varicocele. So these are the most important things. And additional points would be thick scrotal skin and any other previous scars and history from there we can go. These are the main things.
So all of you are using Prader's, this thing in your practice?
See, to begin with, I was also using Prader's. Even now I have a Prader's, but now we know by experience that this is this much size. But to begin with, I think everybody should use a Prader's.
With cognitive, this thing you assess, give a size.
Yes, first few months we have to use it. After that we get used to.
Okay. You know what it is. Okay.
So regarding the Prader, it overestimates the size of the testis. Regarding the Prader, it overestimates the
size. Okay.
So because whenever we are matching with the testis, it is over the skin we are measuring, over the scrotal skin. So we have to close it, we have to put it by the side. So that is what we should understand. So whatever is the Prader archidometer size will not correlate with the ultrasound.
Ultrasound, yeah, that will come to it next later. So these are different colors in the Prader's archidometer. The green ones is a prepubertal, yellow is pubertal, and orange is red, adult. So as you said, Prader's has got its own limitations. It's not reliable when the patient has got a hydrocele, inguinal testis, thickened epididymis, thick scrotal skin, small testis, where epididymis is large in comparison to it. So in that cases, I think you have to go for ultrasound. So here, secondary sexual character is normal, penile shaft is normal, and bilateral testis is normal, Prader is 15 on both sides, epididymis normal, vas felt, but there is grade 2 varicocele which is present on standing position and reducing on supine position. What next, Vinod? Clinically, there is grade 2 varicocele.
So I will send for further investigations, look for the semen analysis, and then only proceed.
How do you counsel this patient for semen analysis? Do you tell them anything? How to collect the semen and how many days of abstinence?
For semen analysis? Yeah, in semen analysis, we need to really counsel the patient how to collect it.
And this is a very important point. We usually neglect this point. We just write on semen analysis and then send them. We don't know how they are collecting, how many days of abstinence. I've seen patients, half the semen is the spills outside and they collect in the toilet, hospital toilet, where they don't get proper arousal. So because you people are practicing hardcore,
we better have write-ups instructions for semen analysis. Usually that is better.
What is it?
Patient information
instructions. What is there on that? What is there on that?
Before that's also the number of abstinence days.
Days of
2 to 5 days of abstinence.
3 days?
WHO says 2 to 5.
2 to 5 days. Okay.
2 to 5. 2 to 5 days of abstinence. And you clean retract the prepuce and clean it, and the sample again there should not be any spillage, and the container which we give should be a white mouth container because it will avoid.
So it need to be a sterile container or a clean container?
It's a sterile container, sir.
Sterile. You need to have a sterile container.
Yes, sir.
You need a sterile.
Clean is sterile.
Clean is, yeah.
But usually it is a sterile. But only thing is you should not put any antiseptics to sterile, make it sterile.
Okay.
I can extend here regarding the abstinence. Why it is 2 to 7 days? Everyone should know that. So it is only for the WHO manual standardization. To across the globe to standardize the semen parameters, they have asked for the 2 to 7 days. That is what we should know. For the given individual, he may be giving a good sample at 1 day, he may be giving it 10 days, 15 days. What happens if the sample is collected if it is 1 day abstinence? Volume will be less, his motility may be less. If it is more than 7 days, what happens? Again, motility will go down, volume will be high. We are underestimating the report. Still, if the person is coming from far away place, where there is abstinence is 10 days.
If the report is normal, agreed. If the report is abnormal,
whether to accept or not to accept. We can accept those patients. We can mention there is a 10 days abstinence is there. your analysis may be substandardized. You have to repeat the sample
Like
after
the
10
7
days.
days sample or 10 days sample, you feel it is
Yes.
normal, you don't repeat it.
Yes, we don't repeat
That's
it.
fine.
So the another thing,
shall I-
sir, regarding the sample container. So what happens in the andrology laboratory, there should be a method to select which container to use. There is a proper standardized control will be there. In the control, there will be a sample. Again, in the test sample, we have to put the same sample in two containers. If the motility even after 4 hours is equal in both the containers, that is the container we need to use in our laboratory. It is not every container we can use for the collection also. So these are the things, standardization of the laboratory for the better results.
So what type of sample you go for? Masturbation, cleaning?
Shall I make one more point? One more funny instruction I give. I usually tell patients to have an abstinence and collect sperms when the wife is having menstruation. Because I've seen so many patients doing abstinence at the ovulatory period.
Okay.
They may be coming from a far off place or they may be taking leave, and finally in the ovulatory period they take
So
abstinence.
your
and,
situation is different. You get Gulf patients. There's a problem.
Yeah, Gulf patients and IT patients.
Okay.
IT patients.
IT also, okay.
IT patients.
Okay.
And in the others also this happens.
Okay.
In the others also, because this guy will be testing the semen every month or once in 2 or 3 months. And every time they will be doing this. So I request them, do it only during the menstrual period where it is useless.
So which sample you prefer? Doing collecting at the hospital or at the home?
No, in the home samples, the main problem will be transporting it in a practical sense. But the hospital, if you have an andrology center, usually we have rooms. For
You give a proper
the
privacy.
things.
Okay.
And in the ordinary labs, it will be difficult.
Yeah. So ideally, it should not be a toilet.
Yes.
Yeah.
So most of the hospital, it is collected in toilet where it's thinking bad smell will be there. Somebody knocking on the door when he is collecting the sample. So I think you should have proper situation.
And the sample will sometimes report as blood plus.
Blood. Okay.
Because of they are finding it very difficult to bring out the semen.
Okay.
Sir, another important point what we have to tell them is, most of the people while collecting sample, they use either soap or shampoo for lubrication.
Okay.
So there you get very less motility.
Okay.
That should be.
Okay. So post-intercourse sample, which one you prefer? Coitus interruptus. Somebody says I can't masturbate. Which one you prefer? Post-coitus interruptus or a condom collected?
So that's a condom collecting.
Condom will be better.
Condom is available.
The
That is
sample
better,
may not be
the coitus
complete.
interruptus.
What type of condom, Karthik? Any special condoms for that?
Yes, sir. Non-toxic, sir. That's available with Krishko. That's
Any names for that?
Male pack. Male pack. It comes as male pack, sir.
They're
Krishko.
available?
Yes, sir. They're available, sir.
But only thing is it's expensive, sir. Condom will cost you around 1200 to 1400.
No, yes, sir.
Each condom.
Each condom around 1000 to 1200 rupees is the cost.
Okay.
Only if we are going to indicate in a specific patient, so we can ask them to pay it, sir. They can.
So the other way around is, if you have a room with the privacy, you can ask the partner to be with him and collect. In many of the patients, it will be successful.
Again, it is coitus interruptus.
So
No, without coitus. I think I need not explain.
Okay.
Wife helps in ejaculation.
Okay. Yeah.
No, sir. Here we have to discuss why we are questioning about this coitus interruptus. What are the limitations we should know here? Given the situation where couple is not able to give the sample other than only with the coitus, if that situation is there, what happens? There will be a spillage of the sample. There will be a vaginal pH will be very high. Again, motility goes down, and there is a chance of contamination. These are all the limitations. For routine analysis, for the particular couple, if that is only sample, again we can take the sample and we can analyze it.
That's
we
what.
can report
In
it.
such cases, you prefer a condom
Yes.
sample.
Even if condom is not available, we can also go ahead with the coitus interruptus. Same thing, we can report it in the report.
Yeah, you have to
It is a
report
coitus interruptus sample. Reports may not be accurate. At least we will come to know that for the particular person, that may be the first report. Whether sperms are there also we know.
Yeah, agree. So once the sample is collected, how do you transport it? In what time?
So 30 to 40 minutes is the time, sir. And more than that, maintaining the body temperature is very important. So what I tell them is, I ask them to put it in the shirt pocket. Shirt pocket inside, if they are wearing a bunion.
Okay.
I ask them to put it inside. And how they come to the hospital, that is also important. If they are coming in a scooter and if it is exposed to hot sun, then again it can vary. If they are coming in a car with very low temperature, AC switched on, then even that can alter. Those two things we have to.
And in the lab, the personnel should be ready to immediately receive the sample and process it. Sometimes what happens is the sample is kept there, the technician may not be available.
So technician should note down the ejaculation time.
Ejaculation time. That's
not
very
the sample
important.
receipt.
Exactly. The time of ejaculation is very important. And it should be mentioned in the report.
Yes.
Sir, again, we should understand here, sir, we should not be forcing them to give the sample within 1 hour or half an hour. There is a high chance of road traffic accidents if they are coming with those samples. So again, we should know here what is the limitation of this home collection and transporting. What happens if it is 2 hours, 3 hours? There will be a temperature change, there will be pH change, again motility changes will be there. Same thing, this is a home collection sample given at 2 hours, we can report it. For the given individual, maybe we can ask for the second sample. So but we can report, we can accept these samples. Many laboratories, they say that it is only more than 1 hour sample, we cannot accept it. Again, they'll send them back. We should train our laboratory personnel. What are the limitations? That's where the role of clinical implication of semen analysis which comes into picture.
You mean to say you should process the sample, but
Yes.
make a note of it and
Yes.
try to repeat
Sir,
it.
actually, even for that, there is a solution now. A new media is coming up, which can retain the semen qualities for 24 hours. You can actually courier it also. Dr. Vasan is
Dr.
working on it.
Vasan's
He's working
recent
on it.
updates.
So you can actually collect it leisurely. They can bring it to hospital.
Is it available, those media?
No, it's not yet coming.
Okay.
They are using now. They are using in their center, but they are releasing into the market.
Karthikeyan, this is the semen analysis report.
Okay. So this is the only report available. So that is the first thing we have to see. So in this report we have low concentration, low motility. Morphology. Yeah, and morphology is 65%. So here we have to make sure what form of reporting is being used. So this is not the WHO method because 65% is written, which is not matching. So the 12 million and 10% is not matching with the normal forms. So one thing is pus cells is also high. So these are the things which can alter a report. So whether this sample was collected properly, transported on time, all those questions, whatever we ask, that also should come. And in the background of a varicocele, this may be significant, but we have to reconfirm it.
So these are all the parameters you need, or you want anything else in the semen analysis report? Or are you happy with whatever is given there?
So two things here. Reference values are inappropriate. One, anyway, for morphology, whenever we see a sample like this, we ask them to repeat sample in a fertility center. That is one thing, because in normal situations, morphology will never be more than 10%. Very rarely you see more. So second thing, motility, total motility should be more than...
never will be more than 20%?
Sir?
Morphology?
Morphology very rare, sir. Very rare, sir, now. According to strict criteria, morphology more than 10%, very rarely you see.
So this 65 is based on the 1999 reporting, sir. That was not on the stick criteria. Once the stick criteria has come, it is the base level is 4%. 4% is there, and very rarely we see more than 10%.
And motility also, total motility should be more than 32%. Sir. Here, rapid progressive, they say 10%, and it should be more. Reference value is more than 32. So now in this case, motility is around 20.
Whenever you see report, whether the lab is standardized or not, whether the lab technician knows the report, how to report, morphology itself it shows. If they are giving 80%, 90% morphology, they don't know how to report morphology according to the latest guidelines.
I think point
that itself shows. Yeah. And another thing they mentioned 30 to 40 pus cells and 10 to 12 epithelial cells. That itself shows it is a high chance of contamination for this sample.
And live is 60% and I think normal form 65%. Again, there is a contradiction. There are few points where we tell this report need not consider and we will have to repeat it in a standardized lab. Live is 60 and normal form 65, which is again will not be possible. There are few things which we have to see and better to repeat in a standardized.
So the repeat sample you do always when you in your evaluation?
Pick up error, sir. Pick up error. If we pick up error, we feel it is not there, we don't consider this report and next report will be the first 7 report. This one, I don't think we should consider this as a report.
Now, suppose the morphology they say is 10% with oligoasthenospermia. Do you still repeat or you take this? You repeat?
Repeat, sir.
Repeat, okay.
The entire point here is how is the standard of the reporting person and whether we can rely on this report.
So I
we
think
may not
we have to train the laboratory personnel because
Yes, sir.
entire
We
thing
cannot-
it depends on them.
Yeah, we cannot go and train like all the labs. We may not be able to set the
Yes.
standard.
Yes.
So when these patients come, even if it is normal, then also we don't know whether to take it. But especially when we have such a problem where there is discrepancy between the parameters, it is best to repeat these patients in a standard condition in our lab.
Yes, agreed. So regarding the pus cells, what is your take?
Pus cells, I think if he's reporting pus cells and we can digest it, then we have to get the peroxidase test also.
Because
to
sometimes
see
they
whether
get confused, the round cells, immature spermatids are sometimes mistaken as pus
So
cells.
that also has to be reported along with this so that it makes things easy.
Yeah.
But it is not the usual way in all labs is working.
So we agreed. We have to repeat the semen analysis. It's almost same findings because it's done in the same lab sometime. So would you do hormone analysis in this patient? Vinod, would you like to do any hormone analysis in this patient, oligoastenospermia?
Not in this one.
In this case,
So 12 million, no?
12 you don't do. So no indication. All of you agree?
No. All samples with oligospermia, if repeat sample also says 12 million, hormonal assessment is must.
Is required.
Yes, required. At least FSH and testosterone.
Okay. Also, there is some difference of opinion. So, otherwise, when do you do some Karthikeyan? What is your take on hormone analysis?
Actually, according to whatever guidelines we follow, more than 10 million, there is no need to do hormone analysis. That is
More
what
than
it
10
is.
million, there no need. That's
It
what
is okay.
guidelines say.
But yeah. Okay. This is what the guidelines say. I think even we can reduce that threshold because even with the 10 million, if we are doing a hormone analysis, we are not finding anything. Maybe in less than 5 million or even less than that, we'll finding some
10 million with motility abnormalities, morphology, you do, or irrespective of morphology, motility, 10 million is the cutoff.
Yeah, that's a count. Count part.
What are the guidelines saying for hormone analysis, sir? If it is less than 10 millions, are any features suggestive of endocrinopathy is there? Or anything sexual dysfunction is there in the particular individual? These are the situations where we do hormone evaluation. But practically,
in this case, I'm asking. 12 million.
In this case, what we do, sir, routinely, in particular case, what we are doing, even in this case scenario also, whenever a male person is coming, what we are doing is a basic male fertility evaluation. Because one time we are asking for semen analysis, is going back
No,
with the report.
don't go into that. That's
No, sir,
practical.
that people should know that what exactly we will do in the practice.
It's possible. Why not? You give semen today, tomorrow hormone. But a lot of cost is involved. So many things are involved. It's not just.
That is what even coming to the cost, sir. If he is coming for one time for the semen
If
analysis.
it's not indicated, why do you do that?
That's why again I'm coming for that indication also. So even if you're talking about the hormone analysis here, there is a role of empirical hormonal therapy. For that also we require hormones. If FSH, what is the level of FSH, so that we can start clomiphene. So for that also we require hormone analysis. I think there is not much controversy for me to go ahead with hormonal evaluation even with 12 million count here.
Actually, there are two things here. One is how do we practice? So if the patient is able to come repeatedly, then we can do one test at a time. But here we have been discussing that catching the male to do a test itself is difficult. So every time we call for one test, maybe there is a problem. And the patient also doesn't react well. And this is a case where only 8 months they have been trying, but there are some times when they come with a long. So there are multiple situations. It is not one situation. Second thing is we are thinking about hormone analysis because one, there is 12 million count, and second, we already seen a varicocele. Now what we have to come back and see is this only the varicocele which is causing a problem, or it may be a hormone issue also. So all these things are also revolving in the back of Raghavendra's assessment. That is what he's probably telling, that hormonal evaluation is also important.
So
But practically more than 10 million, 15 cc testes with the clinical varicocele grade 2, maybe hormonal analysis can
Usually
be
will
done.
be normal, that's why you don't do it.
At least FSH testosterone should be okay.
So if at all you do hormone evaluation, what hormones you estimate?
If only two hormones, testosterone and FSH, in the fasting state morning, sir. Right?
Testosterone, FSH.
FSH. These
So
two
you
preliminary.
don't ask for LH,
No, sir.
prolactin?
If the preliminary test, if caste is a factor, those two hormones we want. So as a panel, we ask for FSH, LH, total testosterone, and estradiol if he is a obese person.
So when do you collect this sample? You tell them some early morning sample or any sample is okay?
Morning fasting sample,
Fasting.
in between 7 to 10 a.m.
So when there are certain indicators, prolactin is not asked in every case, only there are some indications.
this is described, but in very few cases we see the hyperprolactemia producing an infertility. The talk also I mentioned, I saw
correct.
that.
The borderline mild elevation of prolactin, and we don't know how to interpret in such cases.
Regarding the prolactin, sir, again same thing. When we can order specifically for the prolactin, if there is a headache is there retrospectively, and vision disturbances are there in those particular individual, sexual libido is going down. Whenever we are asking for sexual history, if libido is low, that is where we can ask for the prolactin. If mild elevations up to 35, 40, 60, nothing will happen. So there are so many variations for the prolactin levels. Even if it is 200, 300, then definitely we can go for cranial imaging.
Even in medical history says if he is on long-term PPIs, then it's better to do.
That's what it is. So hormone evaluation was normal in this case. LH, FSH are within normal limits, testosterone is normal. Vinod, do you ask for any imaging in this patient?
No, absolutely no.
All of you agree? And no difference of opinion. Okay.
This is grade 2 varicocele is
Already no.
Clinically grade 2 varicocele.
clinically palpable, but
you want to confirm your findings?
Yes, sir. So even EAU guidelines also clearly mention if you are contemplating any intervention, you have to document with the scrotal Doppler. Even 2023.
Scrotal Doppler is done to confirm varicocele or for some other reason?
No, various other reasons are also there to look for the
my question is, you do scrotal Doppler to confirm your clinical findings?
No, sir, that's what I'm telling. Even in this particular case, clinical examination is showing varicocele is there.
Grade 2 varicocele.
And patient is having abnormal semen parameters.
Yes.
So whether to operate or not, that is what we have to do. Clinical basis, we can tell the patient, okay, your varicocele is there, I have to operate you. But you have to show the patient there is an objective evidence, there is a varicocele with a scrotal Doppler report. Even the guidelines are also saying the same. For that, scrotal Doppler is
Is it mandatory in all the guidelines? I'm not sure.
Second thing, other reasons.
Is it mandatory in all the guidelines?
It is. No. Whether to follow the guidelines, whether it is mandatory, that is different.
My question is it mandatorily described in guidelines that it should be done?
That's what AUA says. Even clinical examination is enough. And EAU says clinically you need to document if you are subjecting the patient for the varicocele surgery. And what happens in our clinical scenario? Patient is there, you have examined, varicocele is there, and you are telling based on the semen analysis you require surgery. But he won't listen to you. If you are saying surgery, so he wants definitely will go to some other doctor.
No, Raghavendra, don't deviate.
No, sir. No, I'm not deviating the clinical practice as well as the guidelines.
We'll talk pure guideline subject.
No, guidelines also says we need scrotal Doppler here, sir. Even for the guidelines.
No, we don't need a Doppler to confirm your clinical findings. I agree you do Doppler to pick up some other things.
No, sir. Even again I'm saying EAU guidelines, you can read 2023 guidelines also.
Sir, two things. For diagnosis of varicocele, it's a clinical diagnosis, it's not necessary.
Yes.
But when you're contemplating for surgical procedure or to document sometimes subclinical varicose on the opposite side, everything, we'll have to do an ultrasound, not for a clinical diagnosis. Sir.
Yes.
That's what he's telling.
So when you do a Doppler, what size of vein is significant when you say that vein size? Any idea?
For this scrotal Doppler wise, it is a more than 3 mm and with reflux, and there is a peak systole. They'll mention PSV, it is more than 2 seconds.
So I think ideally it should be done in both sitting
and standing position.
And also on Valsalva.
So the only point here is most of the patients, when they go for radiological investigation, the radiologist does it in the supine position and gives no varicocele.
Correct.
So clinically we have varicocele, ultrasound no varicocele. So again, like semen analysis, this ultrasound also should be standardized. We should know to which doctor to refer. They should be able to do the patient in standing with Valsalva so that we don't miss that.
Okay. So do any of you use handheld Doppler in your
Yes, sir. Yeah, I mean, I've shown in my lecture. I use handheld Doppler. It helps.
How is it like? Gives more information?
For me, if radiologist is not well trained, I can pick up on my clinical examination very early varicocele, grade 1 varicocele. Even I am doubtful, so I can put a Doppler where I can hear a reflex.
Clinical examination and the scrotal Doppler.
Yes, it helps. If I am feeling a reflux on examination, again I'll resend the patient to the radiologist to confirm in a standing position. Even in standing position, they should wait for at least 1 minute. Then only the blood pull-up will be there.
Yeah, I think the classification and all has already been discussed in the talks. So now this comes a question. So apart from varicocele, what else you look for? I think these are the reasons why you do a ultrasound when you take this patient for surgery. Scrotal ultrasound gives us information about microlithiasis, any mass lesions which are not picked up clinically. a testicular homogeneity. Sometimes there can be testicular dysgenesis, and it can even pick up indirect signs of obstruction like dilatation of retitestis, cystic lesions in the epidermis, which suggest epidermal obstruction or absent vas deferens.
See, these are all findings you can get in an ultrasound, but I don't think that we should do an ultrasound to pick up all these things. If it is an azoospermia and all, looking for a testicular microlysis may be significant, but in other situations, I don't think that we should go for an ultrasound to see all these things. Even the size assessment, your varicocele assessment, vas assessment, I think it's all clinical examination is sufficient. And
so now
I would like to highlight here one more point. In all the lectures, every time we are focusing on clinical examination, even I also told the same thing. Regarding the clinical examination, the accuracy of physical examination to diagnose a varicocele is only sensitivity is 70%. Even specificity is 70%. We are missing 30% of the patients, which is a very huge number.
No, those 30% don't require surgery.
No, I'm saying that regarding the limitation of the physical examination, what we are doing.
But that physical examination is enough to treat infertility.
Physical examination is sufficient for detecting clinically significant varicocele. We are not going to eradicate varicocele.
Exactly.
You are going to look at clinically significant varicocele.
No, I'm not saying again here, sir. Even 30% of the patients where we cannot diagnose the varicocele also, even it is a significant one. I told in my lecture also. Hernia, if it is there, we cannot diagnose. If it is a patient is not allowing to touch the testis, we cannot diagnose.
Whether this patient has come to an andrologist, not to.
No, this happens even in andrology OPD, sir. Patient, they are very sensitive. They won't allow you to touch the testis.
So these
sometimes they are shy to show their genitals.
That's different.
I agree to that. I agree to this point because there are certain situations we should send for an ultrasound. One is an associated hernia where you can palpate the cord. If you have a lymphatic obstruction, chronic infection where you feel that you think that the cord is bulky and you are not able to comment on the varicocele. Thirdly, like Raghavendra said, thick scrotal wall or in a patient who is not permitting for an
indications for imaging when your clinical examination.
These are definitely indications.
Definite indications. Definitely. So here Raghavendra, the radiologist is confused now. He says there is varicocele on the right side also. Clinically there was varicocele on the left side. Now he has given the report that it is varicocele on the right.
Yes, sir, it happens. On clinical examination, we may miss very early varicoceles. So definitely we'll go with the radiologist diagnosis, provided they have given proper vein diameter and reflux of the vein.
I'll just read out the report. Dilated bilateral papilliform plexus of veins showing reflux on valsalva. Diameter of veins on the left side at rest is 2.6, on valsalva 3.7. On right side at rest 2.5 and on valsalva 3.5. So that's why they said right grade 1, left grade 2.
So even regarding the grading also I told in the lectures. Actually, so that is a highly heterogeneous reporting from the radiologist. There is no standardization.
I assume that this is done by an expert radiologist.
Even they have not mentioned which grading system they have followed. Courtesy grading system will not be like that.
Vein
so
diameter
it is a limitation in our practice.
Yeah. Okay. We should not go with the grade. We have to go with the vein size, reflex, all those things because
this vein diameter is significant. 3.7,
yes, since
3.5.
It is more than 3 mm. It is significant. And especially when it is more than 3.5, we can take it as.
Now we'll start with Raghavendra.
So why this significance also we should know, sir. Why 2.5, 3 mm, 3.5 it has come. There is a study on the physical examination versus scrotal ultrasound. If the vein diameter is more than 2.7 to 2.9 mm, which is correlating with our physical examination. That is the reason they are considering it as a significant dilatation, so that radiologically they have defined it as a varicocele. So there is a dilatation and reflux.
So that is the reason if you find a clinical examination, you don't need a Doppler. So how do you manage this patient now? So as you asked, we did an ultrasound. Now how do you manage this patient?
Yeah, at this juncture probably I'll ask the patient, I will counsel the patient. So they are trying for 8 months. He has not used any antioxidants or any medications he has not used. So I'll tell the options. So I cannot label it as per the guidelines there is a primary infertility. But anyway, marital life is 2 years. We can mention it is primary infertility. Oligoasthenospermia is there. And bilateral varicocele is there on examination. This is the clinical diagnosis, working diagnosis for me. I will counsel there is an option of surgery, microsurgical varicocelectomy, and there is also option of using an antioxidant.
So what are your options number 1, 2, 3?
Yes, sir. Here, medication on empirical basis.
So your option, antioxidant is your first option.
Here, first option it goes varicocele surgery.
That's what. What is your first option?
Surgery is the first option, followed by empirical medical therapy, and if they are
all of you
willing to go ahead with ERT procedures. As a 3 options, I'll give according to the patient selection. We'll proceed.
So if your patient opts for surgery, what surgery you do, or will do unilateral or bilateral?
Here I'll do bilateral.
So you're treating subclinical varicocele.
Yes. If one, because I have seen in my practice, when we operate only on one side which is clinically significant, the opposite one will augment after 3 to 6 months. For various reasons, there will be an internal communication between the right and the left which will augment the opposite subclinical varicocele.
So all of you agree you operate bilateral?
Yes, the right side it is documented, sir. We can go and operate.
Okay. Suppose in a different scenario, clinical examination is normal, there is no varicocele, and during ultrasound you find that a varicocele with oligospermia. Would you operate?
There is a paper which says that one side there is.
No. If
Both
clinical examination is normal, oligospermia, Doppler shows varicocele, would you operate on that patient? When you are operating here, why not operate in that case?
No, that says only one side if there is clinically significant varicocele. Opposite side there is contralateral.
Subclinical.
Varicocele. Then it is.
So unilateral subclinical varicocele you don't operate, even if there is oligospermia.
That may not be the cause.
Okay, so that's clear. So bilateral, one side clinical, one side subclinical, you will do bilateral varicocele, but unilateral subclinical you will not operate. I think point.
The reason for that is because we are now able to do microsurgical. We are able to preserve the testicularity, all those things. That is one side. Second thing is, in these patients, taking them to the theatre again may be difficult, and there may have initial improvement in the parameters. Once the opposite side increases in the size, again there will be a drop and there will be confusion. And in this case, the ultrasound also shows that the opposite side also is equally good, equally big veins. That is why in this particular case, bilateral is preferred.
So every bilateral subclinical varicocele, will you operate?
Bilateral no, sir. Bilateral subclinical no.
So when there is one side clinical, other side subclinical, there is an indication for bilateral varicocele.
When you are
in that case, the definition for subclinical itself is less than 3 mm, and on clinical examination it is not that. That is what qualifies for subclinical varicocele. We are not able to detect it clinically, and all these patients, when they reach us, they have an ultrasound where it is less than 3 to 3.5 mm. In these situations, if we don't feel a varicocele, then probably this is not the cause, so we cannot operate.
How do you explain patient about the surgery results, expectations? Patient has got high expectations, and how do you counsel this patient?
We counsel them based on, that is where the initial role of antioxidants, if they don't improve, counts don't improve, and we tell them that you are a young couple, other things are all okay. So that is how we start the discussion with the patient.
So, okay. Now, do you give them any percentage of success rate, something when you do take up this for surgery?
We do give success rates, but in this particular patient, if 3 months antioxidants did not work, then we tell them that there is no other role, there is no other way for you other than this surgery to conceive naturally.
That's 60% we tell, around 60% chances, because the problem here is we go and operate varicocele, but we are not sure that 100% the varicocele is responsible for this suboptimal sperm parameters. So we tell them that there are 60% chances that you might have improvement in semen parameters or positive pregnancy. There are 40% chances even after varicocelectomy you may not have improvement in the semen count, or the pregnancy may not be possible. That time you need to change the plan for pregnancy plan.
Okay.
I counsel in a different way, because see, even after suppose you are doing a varicocelectomy and after the varicocelectomy the count drops, because he may be having some other pathology along with this, maybe a chronic infection which is having a subacute obstruction,
how do you counsel them?
Which may be producing this. So what I usually tell them is, see, you have a varicocele, you have a seminal problem. Definitely the varicocele is contributing to it. We will first correct it and see what is the improvement. Sometimes there may be some other pathology which is happening and you may have a reduced count later, but we are doing our best to see that this will improve.
Yeah.
So this bailout thing also have to take, because after the surgery you say that there is some other pathology, they will become
I think you have to put it in such a way that this is the only surgically correctable factor. You treat it, and then if it doesn't improve, then we investigate further.
That is what.
As sir said, I think we are missing, even in this case, there was history of pyospermias. I think that we have to give importance to that. We have to rule out that first.
Correct.
And then we have to think of
So other bailout option what sir was telling is if you're going to operate when the counts are falling, like you're already advised surgery around 12 million, it becomes 10 and 8. The bailout option rather than explaining, you cryopreserve and then operate. When you're doing it in falling count, when it's coming to 6, 4, you better to cryopreserve and then wait for the results after
So if
verification.
you operate in a patient with very low counts, severe oligospermia, do you
Yes, cryopreserve
and then do operate?
Yeah, less than 5 million, I cryopreserve and then operate, sir.
Okay, I think point well taken. Okay.
Give the option to the patient.
Yeah. So what approach you do, Raghavendra?
So before two more points. So this may be one of the reasons why we do hormone evaluation in these patients. If the FSH is high, it also means that probably the varicocele has caused enough damage. Maybe the surgery cannot give complete improvement in the parameters. At the time, we are trying to improve the sperm parameters rather than the number, and maybe we are not modifying the.
But there is definite indication. Very low counts, falling counts, then you do some.
FSH was normal. FSH is 5. So in this patient, probably we are looking at all rosy pictures. So after surgery, the counts should improve, everything should be okay. Here, before we as andrologists take up these patients for surgery, we should be very sure about the female factor, whether she will be able to conceive naturally. That is one thing. And second thing, we are telling the patient that your counts may stay at this level also. If it doesn't worsen, it is your luck. If it doesn't improve also, if it is at this level, your ART will work better. So these are all the additional points which you tell. And as others also told, if the count is less than 5 million, etc., or there is a drastic reduction in counts over 3 to 6 months, then it's very important to preserve, especially we are doing bilateral, it is all the more important to preserve.
I think approach, there is no confusion. You do, if you have got a microscope, that is the best gold standard, microscopic varicocelectomy. Next comes the subinguinal with magnification.
Yes.
So you have to preserve the artery, you take all the precautions to see the artery, preserve the artery. Yeah? And what measures you take to prevent recurrence?
First thing, proper magnification, proper techniques in subinguinal location. Why subinguinal location? We can encounter more veins, so we can ligate more number of veins. And second thing, even if you want to do prevent recurrence, you can deliver the testis and you can ligate the gubernacular veins,
that's most
even
important.
in the first itself. But routinely I don't do because I have done in few cases, but I don't see much difference.
For postgraduates, I think you should tell them that cremaster veins are more important. Those you can encounter when you do a subinguinal rather than inguinal or
for beginners, probably they can start with inguinal varicocelectomy, where we can cut the inguinal ligament. It is easy in few number of veins. More larger veins, we can ligate, we can identify the artery, we can spare the artery, we can save it. So slowly we can go ahead with the subinguinal procedure.
So the problem with inguinal subinguinal is you don't ligate cremaster veins when you do inguinal approach.
We can ligate in the cremastic veins, no issues, because anyway cord is there, even if you open, cord is widely open.
At subinguinal level, you get more veins sometimes. Those can't be ligated.
Yes, sir, that can't be ligated. There is alternate channels are there in the subinguinal location. That is the reason recurrence is
So
less.
when do you do repeat seminal analysis after surgery?
minimum, I start with 60 days, 60 to 74 days first sample. Before that, doing semen analysis is of no use. First semen analysis is after 2.5 months.
So the guidelines say you have to wait for at least 2 spermatogenetic
cycles, but at least we'll know whether he is improving or is there a positive trend or not. If there are any other issues, at least we have time to correct.
Yeah. So suppose you have done semen analysis and there shows no improvement. Same report, some 10 or 12 million. What will you do?
So we put them on antioxidants, we rule out infections. That is the time we have to do. If initially culture is not done and he is not improving, this is the time we have to do semen culture.
So would you do a Doppler at this stage?
No, sir. There is no.
If the semen analysis doesn't show improvement, you will. So all of you agree you don't do a Doppler?
No, sir. No. Practically, as you are talking about guidelines, we have to do. If there is a recurrence, it is difficult to explain to the patient.
So the Doppler shows varicocele, no varicocele, what will you do? The Doppler shows varicocele. Sometimes possible. You do, in spite of doing a meticulous, perfect job, Doppler shows there is varicocele.
No, so coming this also regarding the recurrence of the varicocele and Doppler, scrotal Doppler, how it differs. In the scrotal physical examination is inaccurate. First, we should understand in case of recurrences, unless until we are able to feel the gross hearing sound.
So you do
and the Doppler will document reflux. If dilated veins will be there even after 3 months or 6 months, that we should not label it as a recurrence. If reflux is there and the follow-up Doppler, then only we'll consider as a recurrence.
What do you do if there is a reflux? In the
No, if reflux is there, that documents there is the recurrence of the varicose.
So how do you manage recurrent varicose?
So again the question comes, there are two options. Again the patient, what is happening to the patient? Varicocele is recurred, semen parameters are normal and they are
improved.
If it is abnormal, then again I will counsel the patients. At this juncture.
So what is your option? You go for intervention radiology or do you operate?
That's what, sir. We are talking about only the intervention for the varicocele. Again, I'll do, provided if it is done, first one is done by me, I'll go to send them to the interventional radiology. The reason why I'll send them is where they can do the venography. So where they can identify alternate channels in a better way, where they can embolize it.
So all of you agree with that?
If it is
if you have done the
proper
varicocele,
surgery is
there
not
is a
done
recurrence,
first, I do redo
you send for
microscope.
intervention radiology. So if done by someone else, you'll do it.
Yes, if it is not done properly, it is not just because someone
We don't know whether they have done it
Failed and
properly.
microsurgery under not under loop, microsurgical
So if
varicocelectomy.
it is not a microscope done under microscopy, you will repeat it. If it is done under
Under loop, we can go out and redo surgery, sir. If done under loop prior, we can go and do.
Surgery is inguinal, then
No.
microsurgery is better. If already microsurgery is done, then embolization.
Embolization.
So these were the guidelines, I think, what we have discussed. Do not treat in varicocele in infertile men who have got normal semen analysis and in men with subclinical varicocele. This we have discussed, I think. Now we move on to the next case. I think the running short
No,
of time.
before we move to the next case, I just wanted to chip in. See, we have completely neglected that pus cells part.
Then I will discuss another case.
Okay. So
One more case.
for the delegates.
Sir.
Delegates,
Yeah,
you have
please,
to
we
consider-
get
We neglected the semen
Yeah,
report.
question are this.
The semen report is not done properly. We neglected semen report. So pus cells is forgotten.
One small question. He has a subclinical varicocele. Semen count is low. You are given antioxidants. He is not improving, and he has gone for ART, all the things. He has failed. Will you go for varicocele surgery if it is subclinical?
This is the area where we should go for advanced evaluation.
Yeah.
So what is his oxidative stress if you are able to measure? What is his DNA fragmentation? And what is the evaluation from the female side for this ART failure? Any female factor is contributing. And we should also go for unexplained
So there is
things.
no need for surgery. No,
Immediately we don't go for surgery. If probably we need to look at
no
other things.
indication for a treatment for subclinical
If
varicocele.
DNA fragmentation is there,
High
subclinical
DNA
varicocele.
fragmentation is there in subclinical varicocele. Again, we have to discuss it. There is no guideline for it. We have to discuss it with the individual. So nothing we could find. Only thing we are able to see is only DFI. Is there any in the particular individual? If he is a smoker, alcoholic, or he is working in a hot environment, all those things are ruled out. There is no other reason for high DFI. What we call it is an idiopathic, but only varicocele is there, not idiopathic. Then probably we can offer them. It is only a one-to-one discussion.
Okay.
And that time again a repeat physical examination in the standard conditions is very important. We may uncover a varicocele at the time. If our clinical picture matches the ultrasound report done by a good, because now here we are looking at causes which can improve the fertility. So one ART has failed, probably ICSI has failed, and we don't have any other we don't have any other mechanism to improve his parameters. At that time it is like a desperation we are trying
So
to
those
identify.
are exceptional cases.
Yeah,
So,
so-
we have go to second case. Huh?
Final point what we have to say is that any given point subclinical varicocele
Doesn't need treatment at first instance. There are some exceptions. Okay. So we have the next second case. Yeah, here is a 57-year-old gentleman. He's got 4 wives. He's got 5 kids with first wife, 1 kid with second wife, 1 kid with third wife. Then he married 4th wife 3 years back. The wife age is 29 years, trying for kids the last 3 years. No, the sexual history is normal, everything is normal. And somebody diagnosed varicocele 2 years ago and he underwent bilateral varicocelectomy. So you can see subinguinal scars, bilateral subinguinal scars. A focused general examination is normal except for left grade 2 varicocele. This is post varicocele surgery. Clinical examination, there is a grade 2 varicocele. What next?
Semen analysis.
This is the semen analysis. Again, don't look at the morphology. So just concentrate on this. So obviously you repeat the semen analysis in this case.
Yes, sir. Progressive
Repeat semen
motility is
also
the low.
shows-
If we forget about the morphology and see it, it is a delayed liquefaction and motility is low motility, sir.
Low motility is there, morphology is normal, viability is normal, and it's got high liquefaction time.
So here related to the liquefaction also, its clinical importance. before labeling it as a delayed liquefaction, one thing is we should look at the timing, whether they have checked properly or not for the sufficient time. No, that is one thing, sir. After doing that, this analysis also, they have to do some enzymatic digestion or chymotrypsins or bromelain they have to add to the sample. Then only they have to analyze the sample for reporting count, motility and morphology. Whether they have done it or not, we have to cross check with the
No, assume it is done properly, liquefaction is delayed. So what is liquefaction basically? How does it happen? Normally semen coagulates once it is ejaculated because of the, not just for the sake of postgraduates, when you see the volume of the semen, 10% of it only comes from the spermatozoa and epidermal fluid, 65% of it comes from the seminal fluid, 25% from the prostatic and 1% from the bulbourethral glands. So there are proteins in the seminal vesicle fluid called semenogelins which are responsible for the formation of coagulum. So upon ejaculation, semen immediately turns into a coagulum, gelatinous material, and the sperms are entrapped in this coagulum. So the prostate secretes substances called like PSA, prostatic acid phosphatase, and other proteins like prostatic secrete protein. They cause liquefaction of the semen. So human semen liquefies in 15 to 20 minutes post ejaculation. It's a very important step for the next further processing of the sperm, like capacitation. So there are certain factors which affect the liquefaction, like factors affecting the production and the activity of the kallikrein, semenogelins. Zinc inhibits liquefaction. So certain endogenous protease inhibitors and accessory gland infection, male accessory gland infection, all these affect the liquefaction. And something called seminal hyperviscosity. How do you test hyperviscosity? You aspirate the semen and allow it to fall like a drop. If the drop length is more than 2 centimeters, then you call it a hyperviscous semen. So again, the causes of viscosity are infection, inflammation. So now we have got a patient who's got
about liquefaction, sir. One important thing I want to know is liquefaction actually happens in the female genital tract. The capacitation happens in the genital tract. We don't, unless we find any source of infection like pustules or leukocyte positive or something, we don't give importance to liquefaction because liquefaction affects only for the semen analysis.
Yes.
The laboratory part, when it's not liquefied, we can't do the semen analysis. Like Dr. Raghavendra mentioned, you do the enzymatic digestion or you pass to the pipette and make it liquefy and then do the analysis. If there is no evidence of infection, male accessory gland, there is no pustules, everything, you don't have to run big in liquefaction because liquefaction happens in the female genital tract.
In the female genital tract, yes.
So if in this case, if there is no pustules or no evidence of infection and liquefaction is there, for treatment part, we don't have to worry about liquefaction, sir.
No, but there is infertility is there and there documented. There are no other cause. The only
on liquefaction, the current available evidence is insufficient to recommend any specific treatment modalities. There are various reasons, maybe inflammation, infection, or possible reasons may be there. If it is there, we can treat it. But for majority of the times, we don't find reasons also for
now, how do you treat? There are no reason that there is a delayed liquefaction and the couple has come with infertility.
That's what we should evaluate for any other infections or inflammatory things.
So
are there?
the
Nothing is
evaluation
there. We don't do just only in the laboratory part whenever he is
So
giving
now
the
we'll come to
sample.
the management.
Only
How do you manage this patient? He has got a recurrent varicocele left side. Clinically, do you do imaging in this patient?
yes, sir. For documentation
Yeah,
of the varicocele,
So
definitely
they
yes.
say there's grade 2 varicocele on the left, right grade 1.
So again, we have to discuss with the patient. Sir, here wife is very young, husband is 57 years.
So would you do angioembolization? What do you take? These are the options.
So again, I'll offer, sir, based on the previous surgical details, if they are there, properly exactly surgical findings are there.
No, you have done this surgery. You have done first surgery.
I'll send for the embolizations. That too, what is the limitation of the embolization? We should know.
Or do you address liquefaction factor?
Sir, I think it's better to address liquefaction factor
Correct.
first. Because even after the surgery, if it is a case of seminal vasculitis or prostatitis, he will not improve. So I think we have to address the liquefaction issue first and then we have to think of surgery. Because it's a surgery.
So is there any role for processing of the semen and doing IUI?
Yes, sir. This is where we have to discuss the options with the patient because
This
of
is
the
the case
age.
where there is a role for IUI in spite because other parameters are normal. Suppose other parameters are normal of the semen analysis, only you find abnormal liquefaction, delayed liquefaction.
Yes, sir. They can go ahead with an IUI because in the lab they can process it.
Yes, yes.
So for the sake of postgraduates, according to new ART law,
Yeah.
After 55 years, once male patient is 55 years and female patient is 50 years, no ART procedure should be advised.
Okay.
IUI or IVF. Both are should not be done, according to new ART.
With the husband is more than 57 years. 55. Okay. So I think, Bhupati, time. And we'll have one short last case. Oh, last case. So, we'll stop? Stop. Yeah, okay. Okay. Then we'll move on to next year case discussion, video session, semi-live videos. Thank you.
If you had done good microscopic surgery, what interventional radiologist extra, what?
That is what, during interventional radiology, where they can go ahead with the femoral puncture. So where they'll do the venography. With the venography, we can know the abnormal communications which we cannot see in the subinguinal location. So that collateral channels, they can embolize it better. But practical problem, what happens when we are talking about embolization? What happens? In general also there is a question whether to go ahead with the microsurgery or embolization procedures. In 20% of the cases, they cannot access internal spermatic vein. And there is no way they can access the external spermatic vein. So these are all the limitations, and it has got a high recurrence rate. So there are many patients, even general surgeons, after having an embolization, come to me for my microsurgical varicocelectomy. So these are the practical limitations. In a good expert hands, maybe they are equally good procedures for the patient.
There are so many gray areas, Kashinath. That's why probably each should pay.
Yes, it is difficult. Right side, it is very difficult. It is very difficult.
See, I think I should share one of my concerns for which I never got an answer. See, testis is an exposed organ, and during interventional radiology and angioembolization, you know how much radiation they are putting and giving to that testis, which is already compromised. So I didn't get any answer in any of the articles. So, but this is one concern which. No, they have to see. No, they have to see. They have to embolize down. It has to be exposed.
Okay, sir.
Yeah, I thank
Thank
all
you
the
for that
panelists
excellent
your
discussion.
valuable opinions.
So we don't have any recorded video. So I have taken this from recording from Mark Goldstein and Sandra Estive's videos from the net. So the microsurgical vasovagal anastomosis is that we anastomose the vessel mucosa, so a single epidermal tubule. Of all the microsurgeries which we do in the andrology, varicocele, or the testicle aspiration or vasovessel, the most complicated one is the vasoepidermal anastomosis. So when you start the microsurgical practice, you do not attempt this surgery. You can start with first with the loop. You can start the microvaricocele, then upgrade yourself to the microsurgical varicocelectomy, then vasovessel and vasoepidermal the last. So where we do this vasoepidermal anastomosis is the vasectomy reversal when the patient is having epidermal obstruction, or if in case of primary epidermal obstruction, or in the case of failed vasostomy due to the missed epidermal obstruction, we go ahead and do the vasoepidermal anastomosis. So even in this era of IVF, ICSI we are talking about, why we do this, the advantage is there are high patency rate following the microsurgical reconstruction, the chances of natural conception, it is cost effective compared to the IVF ICSIs. The female partner is not subjected to any hormonal manipulation, and we have a fresh ejaculate for assisted reproductive techniques rather than an testicular aspiration or a frozen sample. So the various techniques described for microsurgical vasoepidermal anastomosis is the interception technique, end to side and end to end. But the most one which we do is the longitudinal interception, which is called LIVE. So what we do in this longitudinal interception vasoepidermostomy is we take two double arm 10-0 nylon sutures, which we place simultaneously in the epidermal tubule, and in the in-between place you make an incision and you take the fluid for analysis. If there is no sperm in that, you again go for a more proximal, choose a proximal location for anastomosis. If you have a good sperm present, then you go ahead with the anastomosis. So this is what I was talking about. This is the needle which we place 10-0 nylon inside the tubule and inside the middle and aspirate the fluid you send for analysis. So this is a video which I've taken. There are two methods of interception technique. This is the transverse method, but what we usually preferably do is the...
I request Dr. Anil to chair this session. Anil, Dr. HOD from SNIMS. Rahul, you also chair the session.
So this is what I was talking about, rather than the previous one where the needle was taken, the transverse, which we usually do is the longitudinal one where we have a good lumen of the vas. So both the needles are placed in the longitudinal fashion. So once we place the needles and you make an incision and the fluid is, you are confirmed that there is a needle present, then you make an transact the vas and you mark the points at the vas, and both the needles which you already placed you can take inside out from the vasal lumen, and once inside out is, this is the fluid which is come out. So the needles which already placed in the epidermal tubule, you take inside out from the vasal lumen, and once all the needles, the threads have passed into the vasal lumen inside out, you intercept the vas into the epidermal lumen. Once you finish the anastomosis of the epidermal tubule with the vas, then you place a 9-0 suture to reduce the tension of the anastomosis. So this is the stitch what has been taken after placing the anastomosis. Next, the outer layer, what we do is we close with 9-0 nylon sutures.
Microscope recording, direct recording.
So the
Direct recording from microscope.
microscope recording, sir. The camera is placed along the microscope which records it. It's a magnified view.
But the size of the needle is 10-0 nylon?
The outer one is 9-0, sir. Inside the anastomosis is 10-0. 10-0.
Size of
Needle size.
needle size. 10-0, what is the 10 and 30, what is it there?
7.
6-0 needle will be 11 mm.
Yes, sir.
This 10-0 needle, how much size it is?
Needle measurement you're asking. I'm not sure, sir. What needle is this?
Maybe about 6 mm.
This is 7 mm, 6 mm or 7 mm.
6 mm, 6.36. 6 mm also comes in 2 sizes. 6.3.
6-0 comes in 11 mm or 30 mm?
9 mm also. 6.3. 9.3 ಉಂಟು 9.3 ಉಂಟು 6 mm 60 9.3
3.8. So the studies which have shown this with the microvascular anastomosis, the patency rate usually ranging from somewhere from 70 to 92%, and the pregnancy rate usually about, various studies have shown that from 20 to 60% is the pregnancy rate with vascular anastomosis. So when we select the patient, the proper selection of the patient with vascular anastomosis, we have a good opportunity to restore the natural fertility with the good patency and pregnancy rate. The most important thing is we have to evaluate the patient so that we can improve the prognostication and counsel the patient so that we can tell the chances of fertility. And the operative success is based on the intraoperative decision making, and also we ensure that there is a tension-free and watertight pattern anastomosis is the success of the end results. So the outcome is basis of the reconstruction and the reconstruction technique, and the patient-specific factors define the success of this anastomotic method. Again, thank you for the opportunity.
So next topic would be surgical sperm retrieval. So here we have to again, as we discussed in the morning, we have to choose the method of sperm retrieval. So I will just like to re-emphasize that in non-obstructive, we are trying to look at the differences in the spermatogenesis areas, while in an obstructive azoospermia, it is a more straightforward procedure, where we are able to get sperms from wherever we hit. So going into further details, here we have epidermal sperm and testicular sperm. The differences between epidermal and testicular sperm is, in epidermal sperm, the sperm has undergone the maturation. We are able to get a motile sperm, and it is more like, it is better than a testicular sperm, and the motility maturity is better, and it will be almost similar to a semen analysis sperm when compared to a testicular sperm. Whereas in testicular sperm, mostly they are immotile and the maturation has not happened. So if we are not able to get a epidermal sperm, then we have to go for a testicular sperm. So when do we get epidermal sperm in a better way is when we have a obstruction. So whenever we have obstruction, the epidermis is turgid, and that is the situation where this case is more suited for a epidermal sperm aspiration. So the next thing is in men with CBAVD, so congenital bilateral absent vas deferens, most of the times the head of the epidermis may be present, but it may be absent also. So in that particular situation, maybe whenever the epidermis is palpable on the table, then it is better to go for a PISA. Otherwise, then we have to resort to a TISA. So testicular sperm is more suited for non-obstructive type, and epidermal sperm is better possible in a case of obstructive azoospermia. So that is the basic distinction we have to remember. So this is a video which will show how a PISA is done. So it may be even done under local anesthesia. We use a 1 ml syringe with a 24 gauge needle, and we take media in the 1 ml syringe. So we hold the testis and we insert this needle into the epidermis, and by constant to and fro motion, we start noticing that the fluid is coming into the... Yeah, it's insulin syringe. So we take media and then we keep aspirating it, and the fluid starts coming into this syringe. So that's a straightforward, simple procedure. The other thing is, please don't use a bigger bore needle here, because this is potentially damaging the tubule. So the smallest needle is the best suited one for this.
Only one place you do?
So we usually, that is what, so in epidermal PISA, we expect that wherever we hit, we get. Only those patients, this method will work better. So usually the epidermis is turgid, and wherever we prick in one place, we will get a lot of fluid. So this is how the specimen appears after a good PISA. So rather than the PISA, the correct case. So in this particular patient, the PISA was a suitable procedure, and because of that, we are able to see good motile sperms on the sample. So next is going to TISA, which is testicular sperm aspiration. Here we use a scalp point set 18 gauge. That is the most commonly used method. Some people also use a 18 gauge blood set needle, but here we traditionally use a scalp point set, and a 10 ml syringe is used to give pressure. There are people who use the 20 ml syringe also. That is based on the comfort. So again, we hold the testis. We perpendicularly we insert the needle into the testis, and by constant to and fro motion with the pressure applied. So once we insert the needle, the assistant inserts the syringe and gives pressure and holds the syringe. So that is what they do. And with that constant pressure, we keep moving to and fro. And here we do it in multiple directions to get a good core out of the testis. So that is how we remove the core from the testis. And that is then given for processing. So here also we can see the same thing. So actually, non-traumatic technique, we can pull out more tissue from the same spot. So this we can do it in multiple levels also. If it is negative in the first place, we can do it in 3 or 4 places called multi-quadrant TISA, where we will be able to find sperms in some corner. After we remove the tissues, we give it to the embryologist who processes it under the microscope. So there are some people who process the tissues themselves, when most of the embryologists who are experienced in processing these specimens, they can tease out the tissues like this. We either tease out the tissues, we make it into small thin layers, or we can even cut these tissues and we make it into small pieces, because that is when the sperms come out of it. So when we compare the first dish and the second dish, we are able to see the small tissue bits here, which will be then examined under the microscope. And this is how the sperms will appear. So in contrary to the PISA sample, here we get only occasionally, here and there we get sperms. If we are able to get a motile sperm, that is a good thing. So going on to micro-TC, it is done when there is non-obstructive azoospermia with a negative testicular sperm aspiration or a small volume testis. And it is also said that micro-TC can pick up better sperms when TISA has not picked up. So as I told, this is the internal architecture of the testis where we have multiple lobules, and this is where we are trying to find out the differences. So the areas where sperm production is not there will appear like this, and wherever there is a sperm production, probably it appears as a dilated tubule. So this is the basic difference we are trying to make out, and this difference actually goes up only when the FSH goes up. So for a FSH of 5 or 6, maybe micro-TISA and TISA will give the same results. As the FSH moves up, the area of focal spermatogenesis, it's very scarce. So that can be picked up on the micro-TC. So midline scrotal incision, open in layers, we open the tunica and we expose the testis and we make a transverse incision on the testis. So the transverse incision over the testis, and we bivalve the testis and we try to expose this. This is the first step. Then we cauterize the bleeding points. We take not to cauterize in this area. We don't do a lot of cautery because we have to identify the tubules. And then what we do is we do superficial inspection of the parenchyma. So to see how the quality of the tubules is. And are we able to make out the differences? Are we able to identify little plump dilated tubules which can contain sperms? If at this point we get sperms, that is the best thing. We can stop there. If not, then we proceed to, under magnification, we go up to 25x magnification. So we try to identify what is a dilated tubule. So these are some dilated tubules. We have more videos to show these things. So this video will show it in a better way. So if we see across this entire area, this area, there will be some additionally dilated tubule. So that is the difference which we are trying to make out. So when compared to that area, how is this area? This is what we are trying to make out at 25x and see whether this contains sperms. So the next step would be to further split the testis and open it. If we are not able to get it on superficial dissection, then we open it, we expose it, and then we go lobule after lobule to see whether we are able to get sperms. This is in a systematic fashion we are doing based on the anatomy of the testis. So this is how we do the processing on the table. So each area we try to see which is different and which is having, which may contain sperms. That is what we do. And then we go further to do deep dissection and quadrangle based quadrant based dissection, etc. And then closure is done after we get a good sperm. So we do stepwise so that we keep going deeper into the testis and we make sure that we have not missed any area and we have not missed a small sperm containing focus. So closure can be done with proline and in layers. So the next thing is whether micro-TC is a damaging procedure. It's an anatomical dissection and we have minimal damage to the architecture and Leydig cells are not affected that much. So it's a better method. So what is the requirement for micro-TC? We need to have a dedicated operation theatre time, not doing the procedure within 45 minutes, 1 hour. We have to have at least 2 to 2.5 hours planned for the procedure. And our microscope should contain at least 25x magnification. This procedure, when done under the operating loop, we cannot call it as micro-TC. And the embryologist should be ideally present in the next room. So this is done in the IVF lab. The next room is the embryologist. He keeps seeing the tissue, still we give a positive result. And they should also be meticulous and they should also be ready to process so much tissue. So we give at least 10 to 12 or even 15 dishes at times which contain so much tissue. If they become lazy, they don't want to process or they have other works, then the procedure doesn't get completed. So we in fact go into the embryology lab and we sit with the embryologist and ask them to tease. We try to assess each place, whether they have done it properly, whether the processing has been okay. That is how the entire lab and the entire setup becomes better to process these samples. Microsurgical seals also is important. Patients the patient also should have the doctor and the embryologist. All should be patient, only then the microsurgery will work better. And after so much patience, we may be able to get that one moving sperm which is giving the success. So I thank all my teachers and I acknowledge them because we have borrowed some videos from them. We are now having the hands-on training sessions in the last Androcon and we also in the Euromed. We have the Androcon session planned for this andrology annual conference at Siliguri also, where microsurgery hands-on will be taught. So this will be just a primer for those who want to take up microsurgery, because by attending conferences, webinars, etc., the knowledge comes. But once we start doing microsurgery, we need to know how to operate the microscope, how to change the magnification, how to use the instruments. So in the last year in Delhi, we had at least 120 participants, and this year also in the Siliguri conference, we are planning to have this. So if you're interested, you can join us. Thank you.
Good afternoon, everyone. Probably this is the last session. I'm happy that at the end of the session, almost more than 50 people are here. So, concept of microsurgery for varicocele. The most important thing is preservation of the testicular artery, which is an internal spermatic artery, preservation of the lymphatics, and this is how we can go on with one finger up and one finger down with a clamp, and this is how we can do. This is a gubernacular veins, what we are talking. So we can ligate these veins, and this is a small incision. It is a mini incision microsurgical subinguinal varicocelectomy. So what are the types of internal spermatic artery which we were discussing? This, if you open the spermatic cord, if you are able to see this type of artery, it is very easy. Once you open spermatic cord, internal spermatic phase expansion, you can see easily. And this is little bit difficult, and this is the one which requires your skill. So if it is completely embedded by multiple venules, it is very difficult. You may require to spend more time. So these are the operating steps. Anesthesia position. First step is identification of the external ring, subinguinal incision, ligation of the external spermatic veins, delivery and opening of the spermatic cord, identification and preservation of the internal spermatic arteries and lymphatics, and ligation of the internal spermatic veins, and ligation of the cremastic veins, and closure of the wound. So this is what the position. Your neck should be straight so that we can operate for longer periods. You should be looking straight into the microscope, and your hand should rest on the patient, and there should not be any hanging hand. Otherwise, I had myself had a tennis elbow. So because of the hanging hand over a period of time, I realized I forgot my training while doing surgeries. Again, reposition my hand. Now I'm comfortable now. So this position is very, very important.
Standing you can do, I can sitting also.
Both. It is depending upon the which objective lens which you are choosing for the microscope. If it is a 200 objective lens, you can do with sitting position. If it is 250, 300, that higher gap should be there from the patient to the objective eyepiece, and as well as the objective piece. It is objective lens length, working distance. If it is high, it is very difficult. So low cost microscopes, usually they will come with 200 working distance. It is very difficult to do in a standing position. For those cases, definitely we have to do in a sitting position. For that, nothing should be there below the table, where the base of the table will come, where you cannot keep your legs comfortably. On long duration, we cannot do the surgeries. So if there is any extension to the table, you can add the extension, like what we do in a CM while putting the CM for extension. We can put the extension so that there will be a lot of gap will be there for the legs, so that we can do the prolonged procedures. And this is what identification of the external inguinal ring. So from below which we can start the marking the external ring, and probably this is what incision, subinguinal incision in the direction of the inguinal canal. I think you know we are incising the skin and subcutaneous tissue, fascia, camphor and scarpa layers. You can have a protective rubber shot on this to avoid cautery injuries to the skin. During that time, sister could not give.
This part of the surgery is done with naked eye or no?
This is with naked eye. This is with naked eye. A microscope still, even you can do from skin to skin microsurgery, but it takes time. Unnecessary, it adds to the time. We'll bring microscope once spermatic cord is up. If you are using, your bleeding will be less. If you are using from the skin incision, you can identify small vessels, you can cauterize.
Handle the card nicely, spasm also less, but result identification will be easy.
Yes, sir. No, we were not going to the depth. It's only superficial layer we are incising here. Once we are going in, we can use the retractor, Langenbach retractor. Ideally, Journey's retractor is ideal here, which is a little bit bigger size, so that you can open. You can use it vertically, up, one down, or sideways, so that you can see the spermatic cord. So slowly you are able to see here in the center. Just even you can use your finger also downward, so that we can identify even better. This is once you are identified, you are sideways, so that we can pick up easily. And then we are able to pick up the spermatic cord with the Babcock's, and we can brought it out. There are different ways how people can do. Dr. Rupin Shah does directly in the inguinal canal, even cord itself in the inguinal canal, so that there will not be any artery spasm as we were talking. But I don't see much difference. Whenever I am facing any difficulty in identifying the artery during that part of the surgery, I'll again keep it in the inguinal canal. I'll look for the artery, again I'll brought it, because it makes my surgery easy when it is on the surface. Just I'm that will be said. Most of the time we don't come across. We can see this is for looking for other floor veins or any external spermatic vein. This we cannot do with the embolization. So just I'm looking for the sideways, even just below the under surface of the cord, we have to look immediately to look for the external spermatic veins. So if those veins are there, probably we can ligate those veins. Here we can see vein attached here. Probably I will be ligating next step. I think this is the vein, external spermatic vein on the floor under surface of the spermatic cord. These are the veins we have to ligate, otherwise recurrence will be high. Just you can ligate with 3O or 4O vicryl. Initially I was using 4O silk, 3O silk, but some patients are coming with the suture abscess. Later on I have stopped using silk now. I am using only the vicryl. You can ligate those veins and we can deliver the spermatic cord. Just these are the steps. I have a complete video next so that you can understand better. So next thing, and this is how I can brought it to the surface, the internal spermatic cord. And now I'll bring the microscope in and I'll operate under microscope. This is intraoperative Doppler which I can use. I think it will be helpful to you to identify the artery faster. In at least 20% of the cases, it is very difficult with even papaverant. So this Doppler will help you. With sterile immobilization. So if proper person is there in CSSD, they can do ETOs. Otherwise, they'll damage the probe. That is a problem, practical problem. Sound is not coming. Audio. If audio is there, we can hear the sound of the artery pulsations. Is it possible? No? Okay, so that's where we can see I'm not able to have an audio. We can put the probe, Doppler probe on the artery, suspected artery, we can hear the sound. This is the way we can identify the only challenge is this probe is very long, we have to support with other hand. And this is the entire video. Easy case, from skin to skin you can see. I'm incising, I'm going and delivering, and this is another instrument I've kept under high magnification. Now I'm opening the internal spermatic fascia, both external layer as well as internal layer. Straight away, it is under microscope. So this is an artery, you can see the pulsations. I'm identified and measuring the vein size, ligating with the 3O seal. This is the whole case. It is around 8x magnification. So ligate both the ends, and in between we can take out the small segment to avoid recurrence if it is possible and it is easy. And there is another artery, you can see that in this case another artery is there. It is not only one artery, so we can preserve that artery. And these are the lymphatics. You can see that lymphatics we can preserve. And these are rest of the veins I am ligating. So at the end of the procedure, this is our last step. Under the finger we have to scan any smaller veins. We can cauterize those veins, so to avoid recurrence. I am closing the internal spermatic fascia. Those veins, whenever it is a recurrent case or in the initial setting itself, it is a very big, more than 3 mm, 2 veins are there, I ligate 1 vein. Or in recurrent cases, I ligate at least 1 vein. At least 1 vein should be there for the written. This is what, if time is there, I can show another. This is a difficult case, same. Every varicocelectomy will not be, this case took around 3 hours for only one side. A lot of veins were there. Identification of the artery is very difficult. I think same video I presented recently. I have recorded one more in the recent, but I could not edit it. It is very challenging case where we cannot see anything. Where is the artery? Where is the vein? The loops, there is no way I identify in these cases. So with great difficulty you could identify the artery here. This is a challenging case.
Sometimes we feel that it is a varicose, but sometimes they may have vascular malformation also.
Yes, sir. So one is vascular malformation, other thing lymphatic obstructions. Radialis, they'll mention there is a enlarged veins, but there is no blood flow in that. We should ask them. So color Doppler, with the color Doppler.
If it is heavy malformation is there, how to deal that way?
Malformation of in the spermatic, within the spermatic cut. Same thing, if it is abnormal, probably we can ligate those veins, but that is not real varicocele. AV malformations is rare. I have not seen AV malformation in the inguinal canal, in the varicocele. And this is what tough case. I think same thing to demonstrate is a difficult case.
What do you do if you accidentally cut the artery?
So far, sir, that is a practical challenge for me. Practical challenge in the sense regarding the operation time and the cost logistics. When I was in Cleveland Clinic, Cornell University, where Mark Goldstein was doing a vasovasostomy, incidentally cut the artery. So he took Teno suture and he has again anastomosed the artery. So far I think I have done in my initial career, I have damaged the artery, but I could not do that procedure. But I can attempt it over a period of time. There are practical the reasons only I am not doing, but we can do it immediately. If you identify, incidentally you cut the artery, their pulsations are there at both sides, immediately we can do the anastomosis. But only the thing, time is additional thing, we can do that. And you can see here in this case where the artery is looping here. So if you think that once artery is there, you can see the internal spermatic artery looping here. So there is a high chance that you can damage this type of arteries. So you should be careful. That is the reason one step we can do whenever doing a varicocelectomy, you should go in only in one line. If you are starting from here, go only in the one line so that these things will not be there.
When when you feel that it is an adequate dissection, you have completely ligated, what are the factors you consider?
At the end of the procedure, I would be able to see only the vasal vessels, internal spermatic artery, lymphatics. And even cremasteric I have to dissect, cremasteric muscle, cremasteric artery I have to preserve, and cremasteric veins also I have to ligate. And at the end of the procedure, I have to do the finger scanning, where small tiny venules will be there. I have to, with the bipolar, I have to cauterize those things. And under surface, we have to ligate all the veins, whatever the veins are there. If you are delivering the testis, if gubernacular veins, probably we can ligate those veins. At the end of the day, these things should be preserved.
In extension to the Kasi's question, most of the urology OTs will not have microscope and mini Doppler. What general precautions do you advise?
Yes, sir. Even I started my practice where there was no microscope. Initial cases I did with the loop. So, what are the challenges we face while doing the loop? Only thing is identification of the artery is very difficult. Identification of the lymphatics are difficult. For the beginning cases, if you are doing with the naked eye, doing mass clamping and ligating and cutting, instead of that, probably we can do. That's where I'm coming, sir. One thing is the loop we can use, and second thing, papaverine you can use. Papaverine we can use papaverine, and other things to identify. If the question is to identify the artery, how best we can identify. Usually artery color will be a dark color. It is a red color when compared to the veins, and the artery thickness of the artery wall will be, it is very thick when compared to the veins. While dissecting also, we'll come to know that. And most of the times artery is close to the lymphatics, and even it is entangled with the small venules. So these are all the things, and we can do if BP is low. If it is 90, 60, because of general anesthesia, we can ask them to increase the BP. If the spermatic cord is above, probably we can put it again down and we'll wait for some time. We can look for the pulsations. So these are all the various things. Even if your microscope is at lower magnification, at that particular point you can go ahead with a higher magnification, which is a luxury for me. So I can see at the higher magnification, I can identify the artery pulsations better. With the Doppler, you can use the Doppler. So these are all the various things we can identify. In a practical purpose, what best we can do, simply we can use a papaverine. We can put the cord down in the inguinal canal, wait for some time, and ask the anesthetist to raise the BP so that we can identify the artery. This is robotic surgery.
Small incision, it is difficult to pull out the testis to tackle the gubernacular veins.
Whenever we want to deliver the testis, the size of the incision should be the approximate size of the testis. We have to measure it first, roughly clinically, so that we can do. And other way, with the small incision, we can deliver the testis. Is the orientation of the testis, if you change, even with the small incision, it comes out. If it is with the same size, if you are pulling out, incision is bigger. If you are orienting crossly, it comes out easily with the smaller incision. While putting it is difficult, but same thing you can follow with the. This is robotic. Only one reason I put this video is I have done only one case. I am not presenting the. No, sir. So far, I could not face that situation. Yes, sir. Almost all the cases. But initial cases, when I started my practice 10 years back, I have damaged the arteries. I could not see the artery. So, but every case we can find the artery, whether it is one artery, two arteries, or three arteries. Maximum I could find 3 arteries at different levels. On average, usually I measure even in my OT notes. I'll measure it as a large, medium, and small veins. In my opinion, large is 3 to 4 mm. If it is medium, 2 to 3 mm, and it is small, 1 to 2 mm. These veins. Usually large veins will be around 2 to 3 veins, and medium veins around 2 veins, and smaller veins 3-4 veins will be there. So on average, around 8 to 10 veins will be there. Probably that is what I want to take up as a project now because of the bigger microscope, where I can measure in the OT, as well as the recording version also I want to see exactly how many numbers. And does it really matter? Number of veins versus semen reports. Probably in future I will come with the data with those things.
Does it matter, results, sir?
If there is a paper on that, number of veins versus results. So if more number of veins are there, more larger veins are there, as we are talking in the lecture in the morning also, higher the grade of the varicocele, results are better because damage is more. That is what evidence says. No, most of the times it won't correlate. Where radiologist says there is a grade 3 varicocele, I could find only grade 1 varicocele, clinically very less varicocele during surgery. They say it is a grade 1, I could find very bigger. That is also, not only sir, clinical versus intraoperative, it is not correlating.
We are worried about more than 3 mm and reflux only. Why should we tie off small also?
No, that is what. So it is only the bigger veins not causing the reflux. Every vein causes reflux there. The concept is What we are doing is avoiding the reflux of blood, so the temperature alteration will not be there. So we have to dial if it is very small at that point, and it will become bigger over a period of time. This is the robotic procedure I could not do after this first case, and this is the last case because of the logistic reasons. I have changed the hospital. Probably in future, definitely after 50 years, you will be seeing robotic andrology will be there, sessions will be there. So just for the time sake, 2 minutes I'll present. Yeah, many robotic surgeons, upcoming people will be there. So then no sir, nothing, just only air docking, what we can do with the robot, that is what I want to show. So but the clarity with digital zoom we get in XI is almost equal, sir. For the varicocele it is sufficient. If you want to do vasovasostomy, vasoabdominoplasty, where they use an external camera, additionally what we use in erythroplasty like that, probably that helps better. But why I am presenting this robotic thing, it is very difficult to do a procedure for 4 to 5 hours under microscope, where there will be a neck pain, back pain. If number of cases are there, high volume centers, it is very difficult. With the robot, definitely suturing will be very easy. So this is where the same thing I am replicating. Even the left hand instrument is not an ideal instrument, where we can use micro instruments. Black diamond forceps is there, same thing we can use it here.
The size of the robotic instrument is bigger than your micro instrument, sir.
No sir, this is a black diamond forceps, there is a very small. So this is what I am telling. This is a Maryland third one which we cannot use because it was not there. It is the first case of mine, and so after that I did not do any robotic cases also. With this we can do, sir. With the black diamond we can do that, it is easy. So it is very small, we can do that. Even if it is a curved one is there. So but even it doesn't require even curved. Maybe because I have done number of cases, by the time I attempted robotic I could do that. Without any proctor I did. So probably it is easy for people to pick up this robotic things. We can identify artery, lymphatics. Just I'm closing, so just I want to show that we can, same thing I can replicate here. I can stop here. Thank you for your precious time.
So dear friends and respected chairpersons, this is actually not my video. It was gifted to me by Arun Karthik, and that's also a video from Lip Shoots. This is about, it's actually a self-explanatory video. I will try to explain in which all places you need to explain. See, in a vasovasostomy, the challenges we face, it may be done by a urologist or a general practitioner, and he has made it a point that this vas will never reconnect. So that is the way he cauterizes it, ties it twice or thrice and things like that. That is how it is usually done. And now we are going to reconnect it. So what are the challenges we have? It's not the challenge is not only in the connecting the both vaselines, which we can do because as a urologist and andrologist we can do that. The challenge is in finding the normal vas. What happens is they might have tied it off, and what we will be finding it difficult is it might be near to the epidermis, and it may, even if we cut the vas, you may not find any fluid coming out. So sometimes you may have to go into the epidermis, and finally the vasovasostomy becomes a vasoepidermostomy. But the only good thing is you can learn to do a vasoepidermostomy, and such vasoepidermostomy has a good result than the usual vasoepidermostomy we do. So the main challenge is finding that the lower part, if a vas element is available and the vas above is approachable, which can be approximated, it is well and good. And so we usually put a long incision in that scrotum, up, especially in the upper part, to start the dissection. Now you can see that. So this is that scarred area you can see here. That scarred area you can see. Now the adventitia is dissecting. Now he has found a good place to for dissecting. For see now they have put that holder, nerve holder. If you have something like this, if it is not there, if you have something like this, your cutting of the vas will be good. Otherwise, what will happen is it's a thick structure. When you cut, you can damage that lumen and damage that mucosa, and it will be ragged, and your anastomosis will be at danger. So if you have something like this, or if we can innovate something like this, it will be good for you. Now you can see how sharp that cut comes, and it is a straight cut. This is an optional thing, but usually we may be able to find out a place in the, especially in that proximal part, because it will be dilated. You find that area, and they are putting in an angiocatheter there. I think we can even use a guide wire to see how is the lumen. That is a better thing than in this one. This can even produce a false track. No, that is different. That we can get. No, for checking the lumen to look at the patency, because initially what happens is that that mucosa will be approximated. When you cut, the mucosa may remain approximated sometimes. So if you put in something like a small guide wire, 0.3 or 0.35 or maybe 0.25 if you have, that will open up, then you can aspirate. That's the proximal part. Is it repeating? Distal. Okay. It is better if you have a cautery with a fine blade. Our usual bipolar may not work here. Now it's an approximation suture to keep it approximated, and there is no tension. Now he is marking the dots. This is the first suture at 6 o'clock position. This is the muscular layer. So the basic strategy will be to first you approximate the adventitia part, keep it near to your field. Then you put two muscular sutures at 4 and 6 o'clock position so that the vas is approximated. Then you start doing the anastomosis, and it has to be a double armed, and you should have all the double armed ready. Now the tenonylon, both from inside out, both sides, because outside in may produce a damage to the mucosa. 6, 4, 10, 12 and 8 and 2. So for an andrologist who is doing a vasoepidermostomy, this may not be a big challenge, because in vasoepidermostomy, taking that sutures from the epidermal tubule is a challenge. Here you have a decent mucosa where you can take all the sutures. The only thing is you should have the skills to take manage the tenonylon, and the rest of the things are fine. Thank you.
Scope of andrology as a urological subspecialty, is it viable? So I take this opportunity of all my teachers, Dr. Rupin Shah, Dr. Ashok Agarwal, Dr. Mark Goldstein, Peter Schlegel, and microsurgery training teachers and Ranjit Ramaswamy for my teachings. I express my gratitude. So all of you are well aware, andrology is an upcoming super subspecialty of urology. It deals with male reproduction as well as the infertility, sexual dysfunction, and men's health. It is to the male like a gynecology and even more. It covers from before conception to the aging. I think already discussed why already it is an increased incidence of infertility. It is neglected both by the patient as well as by the physician. Unfortunately, it is exploited by the quacks. Already Surya Prakash sir has mentioned in the morning. So it should be a one-stop solution for all andrology services under one roof. Probably in future, in the next 1 decade, you will see the difference in the subspecialty because many youngsters are taking up this branch. It took almost 1 decade for me to start the department because of the practical reasons, where I have to do regular urology, andrology as a part. It took almost 1 decade. Lot of problems will be there whenever you want to start. But nowadays, even corporates are also interested to start subspecialty. Whoever wants to start this branch, probably they can start from the beginning without wasting much of your career in general urology. So this is what are the various reasons why it is increasing. I'm not going. So what is the role of andrologist as uroandrologist? Why I have taken this branch? I can be a urologist. I can play a role of part of the dermatologist or venereologist whenever I am dealing with STDs, or a part of endocrinology, and I can do a counseling, psychosexual counseling whenever I am dealing with an unconsummated marriage patients, even fertility patients, and psychiatry where these patients, depression, anxiety patients will come to you, or you should play a role of geneticist, and you should be a researcher as a part of it, and ultimately we are surgeons. So I always say, I am a surgeon who can also, I am a physician who can also operate as a surgeon. It is an extended thing for me. So our role as a fertility specialist is to upgrade the fertility status of an individual, as I told in the morning, from different levels. Going from the donor away towards the natural conception, that is our ultimate goal. In terms of sexual life, our goal is to improve the quality of sexual life so that we can expand the life of the individual. So what are all the 5 P's we require as an andrologist? You should have a passion, and you should have a patience, and you should persist on this because many troubles will be there while you are encountering this subspecialty, and you should have patience, then only you will get money, that is paisa. So what you need? Confidentiality, communication skills, privacy, and at almost all the times you need to maintain the quality. Transparency is very important, and your treatment should be affordable to the patients, and you need to maintain doctor-patient relationships. And most of the times you should be ready, be as a visiting consultant to many fertility centers, and you have to maintain the time because they'll give trigger where egg retrieval or oocyte retrieval will be there. If you are not going on time, next time they won't call you. So you should maintain your time on time and be ready to learn every day because it is an upcoming subspecialty. Still we are learning every day. What are the services? Outpatient, OPD, routine urological services, same picture. What are all the things we can do in the OPD? Male infertility, sexual dysfunction, pelvic pain or scrotal content pain, prostate health check we can do, pivotal issues, and sexual transmitted infections. Other issues, even hernia, hypospadias, we can extend. If you spend time in this branch, probably we can expand. Oncos, fertility is another issue, and oncosexuality. These are upcoming things. And andropause or late onset hypogonadism, that is an entire thing. And premarital health checkup, comprehensive men's health checkup, probably we can expand services. And OPD procedures we can do, office sildenafil test, ISTVAD, vibrator, VD training, penile traction therapy or low intensity shockwave therapy, spermatic cord blocks we can give, radiological services, you know. And it is also not without any emergencies. Yes, it is also having andrological emergencies like paraphimosis, priapism, fracture penis, torsion testis, prostatic abscess, genital trauma, fourness gangrenes, penile strangulation injuries, penile abscess. These are all the cases. With their laboratory services will be there. And as a surgeon, we can do all these microsurgeries, implants, sperm retrievals. And as a sexual dysfunction specialist, we can do the penile surgeries. I'm not going into the details because of the lack of time. And who are all the professional colleagues you want? Gynecologists, female fertility specialists, endocrinologists, psychiatrists, dermatologists, general physicians, cardiologists, and geneticists. We need to work in coordination with all these people. So training opportunities are there. So this is my journey of training. And financially, is it viable? Yes, I can say after 1 year of exclusive andrology, it is viable. Ethically also, we can do this practice. Thank you.